Nana udah niat kok lah. Jodoh.
Yes, sir. We wish each one of them good morning, good afternoon, as well as good evening to some parts of the world, to all the participants. Myself, Mr. Bhupati, the representing Inovine Conferences, welcomes all distinguished guests, dear doctors, scientists, educators, colleagues, friends, ladies and gentlemen. It's a great honor for me to welcome you to join this webinar on behalf of organizers of 4th Virtual Conference on Cancer Science and Oncology that is going to happen today as well as tomorrow, September 27th and 28th, 2021. I would like to express my most sincere gratitude for your opening in this opening ceremony as a gateway to initiate our scientific program. I am especially thankful to Mr. Henry Bruce as well as Ms. Nadia, who as well as her heavy burdens, duties and responsibilities to make this happen today. I would also like to thank participants, especially those who are joining from a mile distance and sharing your valuable experience and ideas. With a good number of participants, I am sure this conference will be memorable, highly educational and not to be missed event. Meanwhile, we ask all the participants to keep mute of audio while speaker is giving his her talk. If you have any problem with uploading of your PowerPoint presentation, you can send us immediately to mention email ID I sent through chat box. Just you can find any queries regarding this conference, you can find through chat box as well as your WhatsApp number. This webinar is going to cover all the topics like cancer biology, genetics, organ defined cancers, oncology subspecialties, radiation oncology, surgical oncology, cancer and stem cell therapy, precision cancer medicine and oncology, cancer biomarkers, cancer epidemiology, radiology, cancer preventive and research, cancer therapy and treatments, cancer pharmacology, cancer vaccines, cancer immunology and immunotherapy, oncology nursing and care, cancer psychological and social aspects, cancer science, breast and cervical cancer, lung cancer, hematology, nuclear oncology, DNA damage, mutation, so many. We do have more than 40 to 45 different topics we are going to cover among the listed topics as well as subtitles from the website. Make sure to introduce everyone at the beginning. Ensure that you have clean and appropriate background. Especially I am saying to you, look into the camera while taking instead of your introducing yourself. And one more thing, have a good internet connection. If you are getting any problem having a poor internet connection, you can share us immediately. Your PPT will be playing behalf of you. Also be aware of your audio as well as video settings. Now I would request Dr. Sundaresan, the Associate Professor from Department of Medical Research from SRMMCH and RCSRMIST from Tamil Nadu, India, to start the opening ceremony as a keynote speaker. So I would request Dr. Sundaresan to start his presentation. Yes, sir. Go ahead with your PPT.
Yes. Hello. It's saying I could not. The disabled was disabled. I could not able to share the screen.
Yes, sir. Just be on. We are going to assign as a co-host. Yes.
Okay.
Just open your video as well as audio.
Which one? Thank you.
Yes, sir. It's fine.
Thank you. But do you all see my slide?
Yes, sir. It's fine.
Thank
Go.
you. Dear colleagues and friends, I am delighted to welcome you to the 4th International Conference on Cancer Science and Innovation today and tomorrow. This global meeting will assemble the world researchers in the expanding fields related to cancer research and development. The conference series through the hard work and the commitment makes the genuine and reliable contribution to the scientific community and to the uh, to, in the work globally. And the virtual platform in the happened for the conference makes the researchers to connect globally. So I congratulate all the organizers for the commitment and active participation, and wish you all the success in conducting the conference. The title of talk today, the keynote talk today is investigation on tumor marker, Golgi protein 73 in hepatocellular carcinoma patients. I am Dr. Sundaresan, Associate Professor, Department of Medical Research, SRM MCH and RC Research Center, SRM Nagar, Tamil Nadu, India. So World Cancer Day is celebrated on 4th February every year. It began in 2019 to spread the awareness and inspire change and reduce the global burden of cancer. And it is to reduce the misconceptions about cancer and to help people in getting the right information about it. And to make an impact in the betterment of life of cancer patients and survivors. WHO and IARC, International Agency on Research on Cancer, had reported that the incidence of tumor in 2040 going to be 30% of hike from the 2020. Cancer is the second leading cause of death globally. Everyone have to come together with an agenda to achieve a healthier and a brighter world free of cancer. IARC Globocon 2020 has reported incidence, mortality, and a 5-year prevalence rate in both sexes, wherein the Asia is occupying the maximum number of percentage of incidence, prevalence, and mortality rate among all the countries. IARC Globocon 2020 has reported the number of new cases in 2020 in both sexes in all ages, wherein liver, which occupies 4.7% in incidence, and liver, which occupies 8.3 in cancer mortality rate. Primary liver cancer is the second most frequently occurring cancer in the world and the second most common cause of cancer death in mortality. Mongolia has the highest incidence of liver cancer at 93.7% in 1 lakh population. The HCC incidence declined in many Asian countries, but increased in India, Americans, and in the European countries. The IARC WHO report, which showed that liver, which ranks 7th position in cancer among all the cancer sites. And in India, the liver cancer is reported to produce a tumor in 27,670 in number. The incidence of hepatocellular carcinoma in cirrhotic in India is 1.8%. The age-adjusted incidence rate of hepatocellular carcinoma in India for men ranges from 0.7 to 7.5 per 1 lakh population, and for women it is 0.2 to 2.2 per lakh population. geographically in India, the cancer incidence found to be higher in eastern and the southern parts of India. The prevalence of hepatocellular carcinoma in India varies from 0.2 to 1.6%. The male to female ratio for hepatocellular carcinoma in India is 4:1. In India, the age of presentation varies from 40 to 70, and the age standardized mortality rate for hepatocellular carcinoma in India for men is 6.3 in 1 lakh population. The etiology for hepatocellular carcinoma, the 70 to 80% of all hepatocellular carcinoma are related to the hepatitis B virus, and approximately 15% are related to hepatitis C virus, and 5% to comprising of both hepatitis B virus and C virus. And there are reports from tertiary care centers in India on hepatocellular carcinoma indicated that there are 70 to 97% of hepatocellular carcinoma cases or at the diagnosis of at the time of diagnosis had cirrhosis of liver. And etiologically, alcohol alone accounts for approximately 8% of all hepatocellular carcinoma cases. Further, iron overload may have a role to play in some geographical areas in India. Cirrhosis, hepatitis B virus, and hepatitis C virus are all the known risk factors. Among them, hepatitis B virus is the major risk factor which produces hepatocellular carcinoma. The hepatitis B virus infection that produces inflammation in the liver, thereby that converts the inflamed liver into cirrhotic liver. Then further it transforms into hepatocellular carcinoma by switching these cancer signaling pathways. And there are oncogenes like MIC, EGF, TGFA, AKT, and many are involved. Likely, the other factors like oxidative stress, inflammation, telomere shortening are also involved in converting the hepatitis B virus induced hepatocellular carcinoma. And there are new risk factors including diabetes and obesity were also found to cause hepatocellular carcinoma in recent years. Moving to the tumor marker, the tumor markers are defined as molecules which indicate the presence of cancer or provide information about the likely future behavior of cancer. And they are applied in all the parts of cancer occurring sites in the human body. And they have clinical applications in phases like screening the cancer, early detection of cancer, diagnosing cancer, and the stages of cancer, determining the prognosis of cancer, and to determine the effectiveness of treatment, detecting recurrent cancers, and to assess the response to treatment, and to follow up a cancer patient. And there are various studies that found that alpha beta protein testing as lacking the adequate sensitivity and specificity for detecting the hepatocellular carcinoma. And there are numerous studies which come to propose newer tumor markers as a complement for alpha beta protein, wherein we chose 3 tumor markers: alpha beta protein L3, des gamma carboxyprothrombin, and Golgi protein 73. This Golgi protein 73 is a resident Golgi type 2 transmembrane protein with a single N-terminal transmembrane domain and an extensive C-terminal coil domain, which is located on the luminal surface of Golgi apparatus. This GP73 is found in the chromosome 9 and has 3042 base pairs containing 9 introns and 10 exons. And it is detected in the serum of patients with liver disease, particularly hepatocellular carcinoma. The need for this study is it can differentiate the hepatocellular carcinoma patients from cirrhosis, and that of high-grade hepatocellular carcinoma is also an early biomarker for hepatocellular carcinoma. The picture which shows the HPV infection, once that is produced in the human liver, that triggers the GP73 molecule, wherein the GP73, which plays its role through the autophagy, apoptosis, and EMT, epithelial mesenchymal transition, are the vital forces that needed for cancer development. And there are literature coming for the favor of lack of tumor markers or biomarker driven clinical trials may partly explain why some drugs that appear to be effective in vitro, such as rapamycin, tivantinib, or dasatinib, failed in patients. Hello? Hello?
Yes, sir, go ahead, go ahead.
No, my slide is not moving.
I think there is a problem from your side. Just check your cursor, sir.
Oh, sir.
Yes.
Yes. Thank you. And further, Wang et al. Had showed that GP73 had the best individual performance characteristics in the different stages like cirrhosis and from stage 1 and stage 2 of hepatocellular carcinoma. So further study is required to determine the details of relationship between serum GP73 and hepatocellular carcinoma size. So having these two as literature to prepare our objectives, hence we propose the objective aim and objectives into determining the role of tumor marker GP73 in hepatocellular carcinoma diagnosis, and also to compare it with the existing tumor marker alpha beta protein. The objective is to determine the tumor marker GP73 in hepatocellular carcinoma cases using the ELISA method. The materials and methods which used for our study is, we used a BCLC method of staging the disease. The next is the tumor clinical management and HCC survival time. The irrespective of the treatments, various treatments which is followed in the hepatocellular carcinoma cases, the survival time which starts decreasing. So here, what we propose is the role of tumor markers or biomarkers are essential in the initial planning of treatment regimen itself. When we do not do that, it becomes responsible for the survival time of the hepatocellular carcinoma patients. The study participants are in total 210 hepatocellular carcinoma cases from the Global Hospital Chennai were enrolled in the study. They were diagnosed as hepatocellular carcinoma according to the radiological and clinical procedures. All patients were newly diagnosed cases. Ethical approval was obtained from the Global Health Hospital, Chennai. A structured proforma was used to collect the demographics, laboratory, and other clinical data. The study is a prospective clinical study. The patients with hepatocellular carcinoma of both sexes are included. A patient with other GI cancer and patients with any communicable disease are excluded. The statistical analysis were done using the medical software, and the results of biochemical variables are analyzed using the one-way analysis of variance, and the data were presented as mean plus or minus standard error mean. A Pearson test was performed to study the relationship between the tumor marker and the other variables. Results of the study. The graph 1, which describes the demographic characteristics of hepatocellular carcinoma cases. In that, a total 210 hepatocellular carcinoma cases comprising 143 male cases and 67 female cases. The mean age of cases were found to be 56 in number. The majority of subjects were in the age range of 55 to 64. And table 1, which describes the demographic profile of subjects. As said, the majority of cases are male cases, 143, and 181 are from the age of more than 50, and 113 are from the urban population, and 69 are from the lower upper socioeconomic status. There are 124 are from the lower school level education status. And what is very alarming here is there are 162 cases where do not add any family history of cancer. The chart 1, which describes the socioeconomic characteristics of hepatocellular carcinoma cases. The most of hepatocellular carcinoma cases are in the category of lower upper, followed by the upper middle and lower middle class. So in this study, there are 59% of hepatocellular carcinoma cases are below the school level education. And the chart 2, which describes the distribution of risk factors among hepatocellular carcinoma cases. There are 50% of cases are HPV virus infected, and 20% are HCV positive cases, and 23 had non-alcoholic steatotic hepatitis cases. And there are other reasons, other risk factors, including 7% of HCC cases. The table 2, which describes the tumor characteristics of hepatocellular carcinoma cases, and where 72 number of hepatocellular carcinoma cases are in the stage 2 of the disease. 117 of them are more than 2 centimeter tumor size in number, and there are multiple number of tumors are 112 in hepatocellular carcinoma cases, and majority of hepatocellular carcinoma are present in the right lobe of hepatocellular carcinoma cases. The treatment, most of them add TACE procedures. Moving to the receiver operating curve analysis of tumor markers. Graph 2, which describes the alpha beta protein tumor marker in hepatocellular carcinoma cases. The sensitivity was found to be 71%, and the specificity was found to be 60%. The criterion value was found to be 24. Area under curve value was found to be 0.6, and the Jordan index value was found to be 0.31. Hence, the value was found to be statistically not significant. And the graph 3, which describes the area under ROC curve for alpha beta protein, the lower bound and upper bound values were found to be 0.6 and 0.81. And as per the ROC curve analysis, the values are not significant. The graph 4, which describes the level of a GP73 tumor marker in hepatocellular carcinoma cases, the sensitivity value was found to be 81, and the specificity was found to be 94.2. The criterion value was found to be 105. Area under curve value was found to be 0.91, and the Jordan index value was found to be 0.75 for GP73. Therefore, the value are found to be statistically significant at the 0.001 level. The upper and the lower bound values were found to be 0.94 and 0.97 for GP73. And according to the C90% interval, and the ROC curve shows that GP73 is statistically significant at the 0.05 level. We further explored the GP73 in hepatocellular carcinoma cases, cirrhosis, and healthy individuals. The mean and SEM value for found to be 123 plus or minus 4 for the hepatocellular carcinoma cases. Mean and standard error mean value for cirrhotic individual was found to be 14.9. Mean plus or minus SEM value was found to be 1.94 for the healthy individuals. And the below plot for alpha beta protein and the GP73 is given as a Whisker plot. The Pearson chi-square test was to study the association of GP73 with the tumor size, tumor number, and the tumor stage. The results revealed that GP73 marker had associated with the tumor stage, tumor number, and the tumor size, and it is statistically significant at the 0.05 level. Moving to the interpretation and discussion section of the study, the major challenges in current cancer research are the discovery and the justification of biomarker that could be used to detect the initial stages of cancer. The pre-neoplastic stages like fibrosis, cirrhosis are all have to be turned to early hepatocellular carcinoma. So therefore, the therapy approach that is proposed here is chemoprevention and the primary treatment approaches, including EGF inhibitors, immunotherapy, ECM modulator, anti-angiogenic, and anti-proliferative agents, all that require the future challenges, including biomarkers of response to therapies and trial stratification. The proposed, all the proposed guidelines for hepatocellular carcinoma globally all recommended that alpha beta protein along with the abdominal ultrasound for 3 to 6 months for the detection of hepatocellular carcinoma at the early stage is proposed, and wherein the cutoff value that is proposed for alpha beta protein level is 20 nanogram per ml. Though having that, it has higher false positive rate for the detection of small or early stage tumors, and is often markedly elevated in the patient with the cirrhosis and other hepatitis infections without hepatocellular carcinoma. Therefore, in developing countries, the delayed diagnosis of hepatocellular carcinoma is the bigger problem. And the proposed GP73 sensitivity specificity value around 0.65 and 69 are proposed in the study. Our values were found to be more better than this sensitivity and specificity what we observed in our study. And therefore, in our study, almost 43% of HSC individuals were diagnosed at the 3rd and 4th stage of disease. The major task in cancer research is the detection and the validation of tumor marker that could be used to detect the early stages of cancer. And the level of evidence that is needed for proposing the tumor marker or for the inclusion of tumor marker in the clinic, that needs 5 level of evidence as per the NACB guidelines. The level 5 which requires from pilot studies, and level 4 which requires retrospective, and 3 prospective studies, 4 that requires in the marker data, and 5 high powered prospective controlled studies are needed to show up the tumor marker as a good diagnostic method for diagnosing the hepatocellular carcinoma. Therefore, with this, the GP73 was not statistically elevated in patients with the disease of organs other than the liver, which was proposed and studied by other researchers. Along with that, the GP73 was found to be elevated in the serum in the HSC compared to non-neoplastic liver. So with this, we propose that GP73 could be a newer biomarker come tumor marker, which can be used as a adjunct along with the existing tumor markers. So therefore, we propose to study the knowledge of emerging role of GP73 as an effective marker for the diagnosis of hepatocellular carcinoma. And our study showed that the level of tumor marker was significantly increased in hepatocellular carcinoma patient when compared with this cirrhotic and healthy individuals. See, this is the study which done by one of the researcher. What he did is he compared liver cancer tissue and paracancer tissue and the normal tissue, wherein the GP73 mRNA expression were found to be different in all of the levels. The sensitivity and specificity of marker were higher when compared with the alpha beta protein, and it showed a statistically significant value. The significant difference in the range of these tumor markers between cirrhotic and hepatocellular carcinoma cases indicated that it may be an useful and valid marker for the early diagnosis of hepatocellular carcinoma. And it is GP73 is upregulated in the expression in virus-induced hepatocytes. And it is showed that sensitivity and specificity around 81 and 94.2 respectively. Zagir et al. Showed that the level of serum tumor marker, especially GP73, were considerably increased in hepatocellular carcinoma cases compared with cirrhotic and non-cirrhotic control groups. One of the author, Wang et al., who proposed the AU-ROC curve value about 0.94. This value is closely synced with our AU-ROC value. That is, our value is 0.91. So hence we go together with the proposed AU-ROC value of the GP73. Association of tumor markers with the tumor characteristics is of great importance to predict the better clinical outcome in hepatocellular carcinoma cases, which was observed in the GP73 and hepatocellular carcinoma in our study. So this picture which shows the glycosylated and various glycosylated patterns of GP73 and SPS antigen, those which are linked with the formation of hepatocellular carcinoma from normal liver to hepatocellular carcinoma. So the glycosylation is the important process involving the glycoproteins that are influenced by the glycosylation site, and the defects in it may be detrimental in physiological functions. The post-translational modification process, including phosphorylation, ubiquitination, and glycosylation, are all happens in the cytosol cell of the cell of the organs, wherein the glycosylation, which uniquely that happens in the Golgi apparatus. The other phosphorylation and ubiquitination where happens in the out of the Golgi apparatus. Here, the GP73, which is present in the lumen of Golgi apparatus, are related to the glycosylation changes and other modification that happens in the Golgi structure, which regulates the protein glycosylation. And there are proteins, glycoproteins and proteoglycans, the combination of proteins and carbohydrates, which are modified as post-translational modifications, are also influencing the cancer processes. See, molecularly, we propose that the defective glycosylation of plasma membrane and extracellular matrix has been identified as a hallmark of a tumor metastasis for many years. Though with multiple sets of antibodies have also been developed to detect tumor-associated glycans, while the benefits are still limited due to tumor heterogeneity and complexity of glycans. So these are the proposed clinical and molecular reasons for GP73 in hepatocellular carcinoma cases. Further, we are proposing the perspectives of other researchers in 2020 and 2021. Here, the liquid biopsy, including cell-free DNA, circulating tumor cells, are all done, which also having the pros and cons of it. here that requires a special preparation of biological material and a special laboratory incubants are needed for it. Therefore, what is that is needed it to intensify the developing fast and simple inexpensive analytical techniques are needed. So in light of the experimental and clinical studies, the lack of such a method is a serious limitation on use of liquid biopsy in clinical practice. And there are modern methods like mass spectrometry and RNA arrays are being studied for tumor markers. Therefore, the screening for various tumor markers could be incorporated into different clinical practice, and therefore more number of studies are needed. With that can be helpful in developing the guidelines like EASL and AASLD. So I come to the summary of the results. Here, our results showed that the elevated level of tumor marker in hepatocellular carcinoma and its association with the tumor characteristics might be a promising result. Most importantly, it was increased in the stage 1 and 2 of hepatocellular carcinoma cases, as it could be a potential tumor marker for the early detection of hepatocellular carcinoma cases, thereby improving the clinical outcomes. Here, the clinical imaging that gives the imaging traits, wherein the genetic profiling will give the genetic profile. Both this imaging traits and the genetic profile have to be combined with the clinical data, wherein we derive a radiomics data. It's called a radiomics data, and new approaches come to study the cancer processes, wherein the outcome that is from the radiomics data are proposed to give you a result for the prognosis and treatment of hepatocellular carcinoma cases. So with this, the future research should focus on this line and is supported by the fact that many groups of researchers have demonstrated high sensitivity and specificity of biomarkers, tumor markers, but their introduction for use in the clinic is highly unlikely until a simple analytical method have been developed. And I conclude that the urgent need of tumor marker in hepatocellular carcinoma diagnosis, screening, and surveillance is needed. Some of the reviewed procedures will likely help the physician to perform a more accurate diagnosis through synergetic effects of tumor markers along with the established radiological techniques, including ultrasound, CT, and MRI. And additional tumor markers based on clinical utility might lead to the synergy of overcoming the image-based drawbacks. Ideally, tumor marker based on clinical utility, the cutoff values should determine the diagnosis and increase the image-based diagnosis confidence. Therefore, finally, what is needed is here the hepatocellular carcinoma liver have to be turned to normal liver. That is all of our objective. With that, we finally conclude with the tumor marker GP73 showed better sensitivity and specificity, AUC curve, and further validated with the Jordan index and criterion value when compared with the existing marker alpha beta protein. And I acknowledge my research team, P. Rajapriya. She worked into this project. And I acknowledge Joy Varghese, who is our collaborator from Hepatology Unit Global Hospital, and Dr. Arivadagan, a chief biochemist from the Adyar Cancer Institute, and our SR Medical Research departmental team.
Yes.
And my special thanks to the organizers for keynote presentation in the 4th virtual conference on Cancer Science and Oncology 2021 today. Thanks to all of you for your patient listening.
Yes, sir. Any questions? Any questions to Dr. Sundarazan?
Yes, sir.
What is the biological function of this particular protein? And then how does it manifest actually in the overall cell function?
Yes. Sir, the Golgi protein 73, which plays a very vital role in modulating the autophagy, apoptosis, and the cancer signaling cascade mechanisms in both at the cellular level.
But within the Golgi, what is its function?
Yes.
Does it actually help in transporting
Actually,
some of these?
we propose to study it, sir, in our future research.
Yeah.
That is our aim of the study in our future research. Thank you, sir.
Okay. Thank you.
That's our future study. We are proposing it for.
Because Golgi plays a critical role in processing actually cholesterol transcription factor SREP2 and BP1. What is the effect on that particular truncation? Unless the truncation takes place in the Golgi body, the transcription of the cholesterol synthesis will not be proper. That becomes one of the major factor in actually metabolic defect of this thing.
Yes, definitely, sir. Golgi that plays a very critical role in all of the biomolecules, including cholesterol, proteins, and carbohydrates. Thank you, sir. Thank you.
Thank you.
Yes, any questions further to Dr. Sundarajan? Just if you have any questions, you can text in chat box. We will be asking you behalf of you. Even after the completion of the conference, officially we will be sending to the concerned speaker.
Yes. Thank you, sir.
Yes. Thank you so much, sir, for participating in this event on behalf of virtual conference.
Thank you. The organizer. I'm thanking the Lakshmi Baji sir as well as the organizers for giving me the keynote presentation in the virtual conference on Cancer Science and Oncology 2021. Thank you all of you.
So one more thing, if everything goes well in 2022, we are planning either in Asia Pacific, especially in Dubai or in Europe, sir. If you are willing to join this event, we ask you to prepare from now itself.
We hope so. We all hope so.
Yes, sir.
Thank you.
Yes, looking forward to meet again next time, sir. Thank you for joining and for your attention.
Thank you all of you.
Next we ask Dr. Shipang Maholagu, the topic from Hamad Medical Corporation and King's College London from UK, United Kingdom. The topic will be the innovative use of A1 in breast cancer screening imaging as a tool to address cancer challenges.
I'm struggling a bit here to share my screen. Just a second. If you can see it on the slide. Can you see it?
Sir, if you are facing any problem, just you can send us your PPT. We have mentioned in the chat box.
Okay. Let me just send you my
Okay.
presentation, and you can upload it on your side for me.
Yes, sir.
Okay.
You can send us immediately through chat box. Sorry, from WhatsApp number or through email.
Yeah, I really apologize for that.
Yes, yes. No problem, sir. Take your own time.
Did the lecture start? We are not able to hear actually.
No, sir. Actually, there's a some problem from Dr. Shipang. He is going to share this slide.
Oh, okay.
He is unable to share these slides. So let's wait.
Yeah, we are not able to hear properly.
Let's wait for 2 to 3 minutes, sir. I think there is somewhat technical problem from Dr. Shipang. Hello, Dr. Shipang. Are you going to share your slide to us, or you'll be sharing from your side, or else we go with alternate speaker?
Yeah, I think for time's sake, it will be better to move on with another speaker until I sort out this problem quickly.
Oh,
I'm sorting it out quickly.
yes, sir. Is Dr. Zia Gong from China is ready to present? The poster presenter? Zia Gong, are you ready with your presentation? If you are ready, so that we can invite you. So meanwhile, if anybody are ready with your slides, either Zia Gong from China or Dr. Sutapa Mukherjee from India, or else Dr. Karin from Philippines. If you are ready with your posters, you can start sharing, or else we'll go with Dr. Desak Gede from Indonesia. So we'll be sharing presentation of Dr. Desak Gede Paramisti Devi from Chief Resident of Department of General Surgery, Faculty of Medicine from Erlangga University, Dr. Suetomo, General Hospital of Surabaya from Indonesia. Just
Good afternoon, ladies and gentlemen. Firstly, I would like to address the committee, and I would like to say thank you for the opportunity that's been given to me. My name is Desak Agung Pramisi Devi. I am a chief resident in Department of General Surgery, Faculty of Medicine, Erlangga University, Surabaya, Indonesia. Today, I would like to share some of our study. It's about changes in Ki67 expression and clinical response to neoadjuvant chemotherapy in locally advanced breast cancer. Firstly, the background of this study was locally advanced breast cancer still become the most common stage found in breast cancer patient in Indonesia. Neoadjuvant chemotherapy is the initial therapy and the main pillar of LABC treatment. And neoadjuvant chemotherapy, as we know, they could provide less extensive surgery and improve patients' overall survival to those who achieve a pathological complete response. Ki67 expression is a tumor biomarker that represents tumor cell proliferation and has been extensively investigated as a promising predictive and prognostic factor in breast cancer. Various studies stated that the decrease of Ki67 expression after neoadjuvant chemotherapy was associated with a reduction of tumor size in the breast cancer group, especially with luminal subtypes and luminal HER2 subtypes. So the methods of this study we designed this study as a case control study in order to determine the relationship between changes in Ki67 expression before and after neoadjuvant chemotherapy on the clinical response of anthracycline-based neoadjuvant chemotherapy in locally advanced breast cancer. We also assess the relationship between initial Ki67 expression, or we say pre-treatment Ki67, and the response rate of anthracycline-based neoadjuvant chemotherapy in locally advanced breast cancer. So we evaluate the post-chemotherapy clinical response based on the RECIST criteria, and we divide the patient into two groups, which is the case group and the control group. The case group consisted of patients who received anthracycline-based neoadjuvant chemotherapy for at least 3 cycles, and they had a good response, which is a complete response or partial response. And the second group is the control group, which is consisted of patients who underwent anthracycline-based neoadjuvant chemotherapy for at least 3 cycles and resulted in having poor clinical response, which is progressive disease or stable disease. And then the expression of the Ki67 itself was divided into high Ki67 expression and low Ki67 expression following the ESMO guideline and our Indonesian Oncology Society guideline in 2020. which is the expression of less than equal to 20% was defined as low Ki67 expression, and the expression more than 20% was defined as a high Ki67 expression. We also analyzed the changes, the Ki67 level between before the patient having the neoadjuvant chemotherapy and after the patient having the neoadjuvant chemotherapy, which is the changes we use that from the previous study. The optimal cutoff was 12.5%. So we will divide the group that have a decrease more than 12.5% or having the decrease level of Ki67 less than 12.5%. And then we analyze the data using the chi-square test using the SPSS statistical software. And the result of our study is that we found 66 female subjects that eventually were included in the study with the mean age of 47.9 years old. And we divide those subjects into two groups. Each of them contain 33 subjects, whether it's in the good or in the poor chemotherapy clinical response group. And in our study, we found that a low pre-treatment Ki67 expression was found only in 14 subjects, which is 22.7%, and high pre-treatment Ki67 expression was found in 52 subjects, which is 77.3%. In this study, as I stated before, we divide the changes in Ki67 level into two groups, which is a decrease level less than 12.5% and the group with the decrease level more than 12.5%. And we found that there were no statistical differences between this group in terms of age, tumor size, histopathological characteristic, histological grade, hormonal status, expression of HER2 or the subtypes, and the number of neoadjuvant chemotherapy cycle, except for the lymph node involvement, which we found the p-value is 0.038. And we also found that there's no statistical differences between a good and a poor clinical response group in terms of age, tumor size, histopathological characteristic, histological grade, hormonal status, expression of HER2 subtype, and the pre-treatment Ki67, except for the low post-treatment Ki67, which is Ki67 less than 20%. We're using the ESMO guideline and the Indonesian Society of Surgical Oncology guideline. We found the p-value is 0.027. Here you can see the full table, the full result of our study. And here we try to see and analyze the association between the subject characteristic with the clinical response to neoadjuvant chemotherapy. And as I stated before, between the good response and the poor response, there's no differences in terms of age, size, nodal status, histopathological characteristic, grading, pre-treatment Ki67, and the subtype of breast cancer. But we found that the post-treatment Ki67 in terms of low group post-treatment Ki67 is associated with a good clinical response to neoadjuvant chemotherapy, breast cancer with p-value 0.027. And further analysis that we done in the study to see the association between the changes of Ki67 expression with the clinical response, we found that the decrease of Ki67 level more than 12.5% is associated with a good clinical response, and it's statistically significant with the p-value 0.007. We also done the multivariate analysis, and the decrease of Ki67 level more than 12.5% were strongly correlated to the response in neoadjuvant chemotherapy more than the low post-treatment Ki67 expression with the p-value 0.037. In the setting of neoadjuvant chemotherapy, three parameters of Ki67 expression, namely pre-treatment Ki67 expression, post-treatment Ki67 expression, and the changes of Ki67 itself could be obtained and assessed. But up until now, which value of Ki67 that correlated in response to neoadjuvant chemotherapy is still become a matter of debate. Also, a standard of cutoff point to classify high or low Ki67 expression has not been found just yet. And this resulted in the different studies using a different cutoff point for classification of the Ki67 level. And in our study, high Ki67 expression before neoadjuvant administration could not predict the response of neoadjuvant chemotherapy in locally advanced breast cancer. This is in line with the study that we cite in our research that pre-chemotherapy Ki67 was not significantly associated with chemotherapy response, because we knew that chemotherapy response was not only related to proliferation of cancer cells. However, conflicting results were obtained from a number of other studies which report that pre-chemotherapy Ki67 expression was consistently become significant predictor of therapeutic response and prognosis. It has been reported that high pre-chemotherapy Ki67 expression is a stronger predictor of good therapeutic response and a poor marker of prognosis. This is based on the premise that the tumors with higher rates of cell proliferation may respond better to chemotherapy than the tumor with a lower rates of proliferation. It can be concluded that patients who experience a decrease in Ki67 expression after receiving chemotherapy were the group that benefit the most from receiving neoadjuvant chemotherapy. Those findings were similar with our result in the study that showed low post-treatment Ki67 expression and changes in Ki67, which is a decrease more than 12.5% in Ki67 expression. Both are correlated with a good clinical response to neoadjuvant chemotherapy. In multivariate analysis, a decrease more than 12.5% in Ki67 was strongly correlated to response in neoadjuvant chemotherapy more than low post-treatment Ki67 expression. Another study stated also that changes in Ki67 expression from more than 20% on the biopsy or pre-neoadjuvant chemotherapy to less than 20% on post-neoadjuvant chemotherapy had a better outcome in the terms of disease-free survival when compared with patients with high Ki67 even though after they receive the neoadjuvant chemotherapy before having the surgery. This also shows that the decrease in Ki67 after chemotherapy has a major role in determining the response to chemotherapy and also the long-term outcome in patients. So, the conclusion of this study is that we found Ki67 is useful in determining the clinical response to neoadjuvant chemotherapy in patients diagnosed with locally advanced breast cancer. And changes in Ki67 expression with cutoff points more than 12.5% were strongly correlated to the response in neoadjuvant chemotherapy with anthracycline-based regimen. So thank you. That was my presentation of our study here in Surabaya, Indonesia. I hope you found this study to be useful. Thank you.
Yes. So this was the presentation from Dr. Desak Gede. The topic on changes in Ki67 expression and clinical response for neoadjuvant chemotherapy and local advanced in breast cancer. If you have any questions regarding this topic, you can ask directly, as Dr. Desak is online in Zoom meeting. Any questions?
Yes.
Yes, sir. Go ahead.
I congratulated Desak for doing the work on Ka67 in breast cancer. So I also did a study which is on Ka67 on oral buccal mucosa carcinoma subjects. So we did a immunohistochemical method for detecting the Ka67, and I like to know about Ka67 method, how it is determined, and where were the tissues samples were collected. Hello.
Hello. Yes, madam. Go ahead with the
Is that
question.
reached?
Yes, the question asked from Dr. Sundaresan. Sir, just you can text in chat box, sir.
Okay.
You can ask through chat box.
And another information, we may not able to see the slides properly. I don't know.
Yes, sir. Actually, it's previously it was a video presentation made by from Dr. Desik, sir. If you are going directly live, you will
Okay.
get it clear cut.
Okay. It's a video presentation.
Sir,
Okay, got it. Thank you.
the question you are asking, you can ask through chat box, sir. I think Dr. Desak is in online.
Okay.
They'll be understand because due to some vocabulary as well as due to some issues, they are unable to give direct answer. That's why you can ask through chat box. Yes, doctor. This is congratulations from Dr. Sundaresan to Desek. That's it, sir. Just we'll go with another speaker.
Wait. I am typing the question.
Okay, no problems. Yes, Dr. They say the question is, I had worked for K-67 and wants to know. Oh, hello, doctor. Just you can read the question from the chat box. Okay, sir. We'll be getting this answer.
Yes, she may be not available.
Yes,
So you can go to the next presenter and proceed with that.
Yes, she got from the. Yes, the answer is yes. You can see from chat box.
Okay.
Yes. Thank you so much. Yes. Thank you so much, madam, for participating in this event. Thank you so much for joining as a speaker for this event. Looking forward to meet again next time. Thank you so much for joining and for your attention. Meanwhile, we ask Dr. Shipang Mahalangu from Hamad Medical Corporation and King's College, London from UK. Sir, we are going to share the slide. Just after the completion of every slide, you can mention the words slide change. I'll be changing from me.
Okay. Thank you very much. I really appreciate it.
Yes.
We'll put it on the first slide, please. Before we start, I'd like to thank the organizers of the event. I'd like to thank everybody who attended. I'd like to thank the keynote speakers for giving us this wonderful opportunity to share wonderful ideas and research and all the things that we've managed to come up with so far. I will be discussing the innovative use of artificial intelligence in breast cancer screening, imaging as a tool to address cancer challenges. Next slide, please. Artificial intelligence, which on a basic level means intelligence demonstrated by machines, has become a popular and a rapidly growing form of technology. Artificial intelligence in breast cancer screening is a tool that has been considered with the current modalities that has a potential of addressing some cancer screening challenges and thus strengthening healthcare systems, more in particular, oncology and cancer centers in both developed and developing countries. Detecting breast cancer in its early stages has seen some limitations due to late detection, false positives and false negative reports, reporting delays, lack of resources and screening facilities, etc. Artificial intelligence has demonstrated the ability to learn and interpret data with high accuracy. Thus, its application in breast and chest imaging radiological modalities has shown that it can be beneficial for early detection of cancer, reduce average reporting time, triage X-rays, reduce false positives, and more research is being added daily. Some more innovative applications of artificial intelligence in breast cancer screening include thermal source instead of radiation source application modality, free open source artificial intelligence software that interprets radiographs, and more. All the above mentioned benefits can address cancer challenges, yet ethical consideration of artificial intelligence application must be considered. Next, please. According to the World Health Organization, 7.8 million women were diagnosed with breast cancer as of the end of 2020. Breast cancer treatment can be highly effective, achieving survival probabilities of 90% or even higher, particularly when the disease is identified early. Early detection and treatment has proven successful in high-income countries and should be applied in countries with limited resources where some of the standard tools are available. Improvements in survival began in the 1980s in countries with early detection programs, combined with different modes of treatment to eradicate the invasive cancer diseases. The World Health Organization Global Breast Cancer Initiative GBCI has also committed itself to reducing the global breast cancer mortality by 2.5% every year to a target of 40% reduction in deaths by 2040 among women under the age of 70 years of age. Next, please. According to Benjamin Anderson, who is a medical doctor, in a published article in the Breast Journal titled "The Early Detection of Breast Cancer in Countries with Limited Resources," stated that the early detection of breast cancer can reduce the stage at diagnosis, potentially improving the odds of survival and cure, and enabling simpler and more cost-effective treatment, and suggested as one of the 4 pillars of his conclusion that when resources become available for screening, they should be invested in screening mammography, as it is the only modality that has thus far been shown to reduce breast cancer mortality. The American Cancer Society recommends women between 40 to 44 years of age have the option to get mammograms yearly. 44 years to 54 years should get every year, and above 54 years of age can switch every other year or continue yearly. Next, please. And there are some challenges to breast cancer screening or imaging or mammography. And the challenges, they exist outside of the healthcare systems. The challenges are different from country to country due to socioeconomic and political reasons, disease prevalence and health need, individuals' lifestyle choices. And for this presentation, we are going to focus on the challenges that exist within healthcare systems, which include prioritization, doctor-to-patient ratio, of which you know in most countries the doctor-to-patient ratio is unequivocally very high, reliable pathways from primary health facilities to dedicated cancer centers, fees, waiting lists, delayed and false reports. According to the World Health Organization, survival of breast cancer for at least 5 years after diagnosis ranges from more than 90% in high-income countries to 66% in India and 40% in South Africa. I mean, those health inequalities are a bit of a concern. The World Health Organization also stated that strategies for improving breast cancer outcomes depend on fundamental health system strengthening to deliver the treatments that are already known to work. Next, please. Breast cancer screening or imaging has come a long way from the discovery of X-rays in 1895 by William Röntgen to the first clinical mammography performed by surgeon Otto Kleinsmith at the Leipzig University Hospital in 1927, to the modern mammography systems which were developed around the 1966 to 1980. To fast forward the 21st century, the digital mammography systems and the 3D mammography systems, and now mammography with artificial intelligence. On your top right, you can see the first picture there of the earliest mammograms which were taken as you look at the examples of the mammographic images from 1940 to 2006. Below is the sources of this information. It really shows the advancement of the technology to where we are now. Next, please. In a study published in the American Cancer Society journals in 2009, authors used a surveillance epidemiology and end results or SEER program to estimate the number of breast cancer deaths averted by screening and improved treatment since 1989. The conclusion found that since 1989, between 384,000 and 614,500 breast cancer deaths have been averted through the use of mammography screening and improved treatment in the United States. Stephen W. Duffy and fellow researchers performed a Swedish 2-county randomized trial of mammographic screening for breast cancer to estimate the absolute numbers of deaths prevented and the absolute tumors overdiagnosed in mammographic screening for breast cancer at ages 50 to 69 years in the UK study. The study results showed that the absolute benefits were estimated as 8.8 and 5.7 breast cancer deaths prevented per 1,000 women screened for 20 years starting at 50, and the corresponding estimated numbers of cases overdiagnosed per 1,000 women screened for 20 years were 4.3 and 2.3. And the conclusion, as obvious, is that there's a benefit of mammographic screening in terms of lives saved is greater in absolute terms than the harms in terms of overdiagnosis. Next slide, please. Now, the innovative use of artificial intelligence in breast cancer screening and imaging. Artificial intelligence, which on a basic level means intelligence demonstrated by machines, has become a popular and a rapidly growing form of technology, most especially in the medical field. And we should all know that we are now living in a digital era, apparently, since even with our meeting is virtual. The use of artificial intelligence in healthcare is being used as a tool to imitate human cognition in the analysis, presentation, and comprehension of complex medical and health data. Artificial intelligence processes this data and gives it a well-defined output to the end user through machine learning algorithms and deep learning. A deep learning is a subfield of machine learning concerned with algorithms inspired by the structure and the function of the brain called the artificial neural network. An algorithm is a simple process or a complicated process or a set of instructions that is followed by a computer to solve problems based on input data and desired outcome. Think of it as an ingredient book if you're cooking in the kitchen. Artificial intelligence algorithms can recognize behavioral patterns and create their own logic. Next slide, please. In a recent study published in the Journal of Medical Imaging and Radiation Oncology, aimed at evaluating deep learning based on artificial intelligence techniques for detecting the presence of breast cancer on digital mammogram images, authors found that deep learning-based artificial intelligence techniques have shown promising results in retrospective studies for medical image analysis applications, though some improvement could boost its performances. And this study is from this year. In another study published in the Radiological Society of North America, whose purpose was to evaluate the accuracy and efficiency of a combined machine and deep learning approach for early breast cancer detection applied to a linked set of digital mammography images and electronic health records, the algorithm was the first of its kind to learn and make decisions from both imaging data and a comprehensive patient's health history. The model was able to correctly predict the development of breast cancer in 87% of the cases it analyzed, and was also able to correctly interpret 77% of non-cancerous cases. The author's conclusion was that the algorithm, which combined machine learning and deep learning approaches, can be applied to assess breast cancer at a level comparable to radiologists and has a potential to substantially reduce missed diagnosis of breast cancer. Next slide, please. And in another recent clinical investigation to evaluate the benefits of an artificial intelligence based tool for a two-dimensional mammography in breast cancer detection process, published also in the Radiological Society of North America, it demonstrated that the concurrent use of artificial intelligence tool improved the diagnostic performance of radiologists in the detection of breast cancer without prolonging their workflow. Another article published in the American Journal of Radiology titled Artificial Intelligence in Breast Imaging, Potentials and Limitations, concluded that the algorithms of AI for workflow improvement and outcome analysis are advancing. Using imaging data of high quality and quantity, artificial intelligence can support breast images in diagnosis and patient management, but artificial cannot yet be relied on or be responsible for physicians' decisions that may affect survival. I think we can all agree on that one. And education in artificial intelligence is urgently needed for physicians. Next slide, please. So far as the extension of the innovative applications of artificial intelligence in breast cancer screening, we see that some applications have been applied in ultrasound as well. Developers from NVIDIA presented an artificial intelligence system that achieves radiologist level accuracy in identifying breast cancer in ultrasound images. With the help of artificial intelligence, radiologists decreased their false positive rates by 37.4% and reduced the number of requested biopsies by 27.8%, while maintaining the same level of sensitivity. And the developers then continued to state that this highlighted the potential of artificial intelligence in improving the accuracy, consistency, and efficiency of breast ultrasound diagnosis worldwide. And we also see the applications of it in magnetic resonance imaging. In an article published in the Radiological Society of North America to evaluate whether the diagnostic performance of radiologists in the differentiation of cancer from non-cancer at the dynamic contrast material enhanced breast MRI is improved when using an artificial intelligence system compared with conventional available software. The researchers concluded that the use of artificial intelligence system improves radiologists' performance in the task of differentiating between benign and malignant MRI breast lesions. And all of this are recent studies. Next slide, please. Next slide. Further interesting innovations or applications of artificial intelligence in breast cancer screening or imaging are in the areas of automation, triaging, and other sources instead of radiation source. And in terms of automation, there is a startup company called Isono Health, which is committed to developing an affordable automated ultrasound imaging platform to facilitate monthly self-monitoring for women to help with early breast cancer detection. The device is bundled with the application, AI application that can analyze the results and tag any changes in the back end in real time. And there are also a few more companies committed to this endeavor of making portable automation devices for self-monitoring. Triaging. Google and Chicago-based Northwestern medicine company are teaming up to develop an artificial intelligence tool to support clinicians' work by triaging mammography patients, according to a May 18 Google press conference. And a tool, they concluded that a tool is expected to detect signs of breast cancer in mammograms at a similar accuracy as clinicians. It is also expected to alleviate the anxiety associated with patients having to experience long waiting times for results. The artificial intelligence tool will analyze a mammogram images and flag potential patients who may need more imaging to confirm a diagnosis. A clinician will review the flags, and if the clinician agrees, they will contact the patient for more mammograms. This system is supposed to help patients get through the mammogram and triage process much quicker, but it is not yet expected to be released for several years. Thermal source artificial intelligence breast screening. Niramai, which is a company based in India, founded by two wonderful ladies, has developed a breast cancer screening solution that is a non-intrusive and gives a patient complete privacy. The core technology of the solution is an artificial intelligence-led diagnostic platform that uses patented thermal image processing and machine learning algorithms for reliable and accurate breast cancer screening. And Kevin Health, which is a Bulgarian startup, which is more like a spin-off of image recognition company Imaga, was established in 2020 with the mission to combine thermal imaging and artificial intelligence to allow for remote disease screening. Next slide, please. Now, in terms of ethical consideration, it seems like everything was developing so quickly as I've been speaking as well, I may guess. Just for your thoughts and for your own questions. This one study was performed by researchers to check if artificial intelligence can distinguish between a bone radiograph from photos of flowers or cars. Researchers evaluated the behavior of a publicly available deep convolutional neural network bone age algorithm when presented with inappropriate data inputs in both radiological and non-radiological domains. They found that in their findings that the publicly available artificial intelligence algorithm or application failed to distinguish between appropriate and inappropriate data inputs and calculated bone age for inappropriate images, flowers, and cars. The awareness of inappropriate outputs based on inappropriate DCNN input is important if tasks such as bone age determination are automated, and same can be said for breast cancer imaging, emphasizing the need for appropriate oversight at the data input and verification stage to avoid unrecognized erroneous results. Next slide, please. In my conclusion, I'm going to keep it short. AI is a great tool coupled with current breast cancer screening modalities. It can correctly predict the development of breast cancer, improve the diagnostic performance of radiologists in detection of breast cancer. AI in breast cancer screening can improve on the workflow within departments through its different applications, such as the new idea of triaging images, automation, patient accessible devices for self-monitoring. And this is great for addressing cancer challenges that exist within healthcare systems, especially if we think about strengthening oncology and cancer centers, both in developing and developed worlds. But we have to think about the limitations. What are the limitations that are imposed to a self-learning handheld device that can sometimes inappropriately diagnose flowers for bones or cars for flowers, or maybe mammograms for flowers? And who will take responsibility? How much autonomy can be granted to self-developing softwares in the hands of the vulnerable public? And I would like us to have this discussion. Thank you. Thank you, everyone. This brings me to my conclusion of the presentation.
Yes. Any questions? Any questions to Dr. Shipang Mahalangu?
Can I ask?
Yes.
Yes,
Yes, sir. Yes, go ahead.
Yeah. You were referring actually to thermal changes in the tissues. Would it be possible actually to use this particular technology to determine actually thermal status of differentiated cancers and metastatic cancers?
Thank you very much for the question, sir. Actually, that technology that you're asking about is the one that I mentioned in the further interesting applications of artificial intelligence. One company being founded actually in India called Niramai actually uses a thermal source sort of like scanner to actually look at the tissue changes to evaluate whether the tissue is cancerous or not. But I can provide you with more information regarding the company and the specifications of their equipment. But yes, it can be applied for that purpose.
Yes. Any further questions to Dr. Shipang? Just if you have any questions, you can ask through chat box. We'll be asking behalf of you. Yes. Thank you so much, sir, for speaking about this meeting and providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meeting
There's
next
good
time.
information, but technology needs to be more focused on actually this particular question which I have asked. The reason for that is differentiated cells under hyperthermic conditions actually differentiation takes place, but metastatic cancers normally take place under the low temperature conditions because the mitochondrial metabolism is not activated properly there in metastatic cancers.
That is correct.
Yes, sir. Go ahead. Did you hear the question, the answer from Dr. Lakshmipati?
Pardon?
Yes, Dr. Shipang. Did you hear the answer from Dr.
Yes,
Lakshmipati?
I did understand his input and what he mentioned in terms of the differentiating cells and then how thermal energy actually affects them, and compared to metastasizing cells. And he is making a valid point.
Yes, sir. So, once again, thank you so much, sir, for joining and for your attention. Looking forward to meet again next time in physical event if everything goes well in 2022.
Thank you very much. Anybody who is looking for the full article and with references and the presentation can forward me an email.
Definitely, sir. Just we'll be sharing your PPT to all the participants. Yes. Next, we ask Dr. Sutapa Mukherjee from Department of Environmental Carcinogenesis and Toxicology from Chittagong National Cancer Institute from India. The topic will be Piatic suppresses metastasis and induce apoptosis in breast cancer cells by disrupting the interplay of serine threonine kinase. Yes, madam, you can go ahead by sharing your slide.
Am I audible?
Yes, madam.
Yes. So let me share the slides. Oh, here it is written host disabled participant screen sharing.
And we are going to we are going to assign you co-host.
Okay. So you are going to share the slides now?
No, madam. We had just assigned you the co-host. Check once.
But here it is written host disabled participant.
So may I know your name on Zoom meeting so that we can assign you? May I know your name?
My name is SUTAPA.
Yes.
MUKHERJEE. Here it is written it has been disabled by the host. So I can't share my slides.
Just be online. Just be on. I'm going to check once.
Okay. Thank you.
So we assigned you, madam. Just it's showing you from here. We assigned you. We assigned you co-host. Even in participant list also you can check in participant list.
So I am leaving from this computer and I am again rejoining. Okay, just give me some time. 1 minute. Is it visible now?
Yes, it's going to share. Yes, it's already open.
Yes. So shall I start?
Yes, madam, go ahead.
Yes. So hello everyone, and thank you for giving me this opportunity. And the title of my presentation is PEITC, which is phenethyl isothiocyanate, suppresses metastasis and induce apoptosis in breast cancer cells by disrupting the interplay of serine threonine kinases. So from this very title, 4 keywords is coming. What are they? Number 1, it is serine threonine kinases. Number 2, metastasis. Number 3, apoptosis in breast cancer cells. And number 4, PEITC or phenethyl isothiocyanate. So let me explain the whole story. So we know that serine threonine kinase is nothing but a class of protein kinases. So what are protein kinases? Protein kinases are a group of enzymes that catalyzes by adding a phosphate group to its substrate with the help of either ATP or GTP. Means it is a energy dependent process. So why phosphorylation is required? Why the protein needs to be phosphorylated? Because it may be because of functional activation or maybe because of functional deactivation. A very good example here I must mention that the protein tumor suppressor protein P53. P53, which is known as guardian of genome, this protein has multiple phosphorylation sites. So if phosphorylation of P53 occurs at its conserved domain, that is serine 15 or serine 20 like this, then what happens? P53 becomes functionally active and performs its tumor suppressing function. Contrarily, if any serine threonine kinase phosphorylates P53 at serine 315, means 315 or serine 215 residue, then P53 fails to perform its function, its tumor suppressing function. And what happens? What will be the fate of this P53? It will undergo MDM2 mediated proteasomal degradation. It means same protein, multiple phosphorylation site, but it depends on the site where phosphorylation is going on, and that determines the fate of the protein, whether the protein will perform its function or the protein will be functionally deactivated. Now the question comes, why these protein kinases, what they do? They are mainly involved in signal transduction pathway, cellular differentiation, proliferation of cells, progression of cells towards cell cycle, and finally apoptosis. But in most of the cases, what we found that it has been reported that aberrant expression or dysregulation of these serine threonine kinases or protein kinases, particularly I must mention, in different malignancies. Now coming to serine threonine kinases, which are part of protein kinases, because protein kinases may be tyrosine kinase, it may be serine threonine kinase, or it may be some other kinases. But we are here focusing on serine threonine kinases. So what are the functions? They, as I have mentioned, that they may play a role in signal transduction pathway. They are very important enzymes for cellular metabolism and most importantly mitotic event. These are some of the examples of serine threonine kinases. Now, in our laboratory, we are mainly focusing on three important serine threonine kinase. One is protein kinase C family, another is prolo-like kinase or PLK1, and third one is aurora kinase. But for today's presentation, my focus is mainly concentrating on protein kinase C delta, because several subfamilies of protein kinase C are there. I will be concentrating on protein kinase C delta, PLK1 or polo-like kinase 1, and aurora kinase A. Now, what is protein kinase C delta? It is like it is a serine threonine kinase. It is mainly involved in anti-tumorigenic property because it facilitates apoptosis, tumor cell apoptosis. But in some literatures, oncogenic potential of protein kinase C has been reported. So you can say its role is a bit ambiguous. What actually happens if we look into the protein structure of protein domain structure of this particular serine threonine kinase, then you can see that here there are 4 conserved domain: C1, C2, C3, and C4, and some 5 variable regions are there. Unlike like other serine threonine kinases, protein kinase C has a N-terminal domain and a carboxy terminal domain. Now, this C1 region, this C1 region is very crucial for determining the apoptotic fate of this particular kinase. What happens if, because protein for functional activation of protein kinase C, 2 cofactors are required. One is DAG, diacylglycerol, and another is PMA. So if it binds with this hinge region of protein kinase C, C1 region, then what happens? Phosphorylation at tyrosine 155 and tyrosine 187 occurs, and this helps this particular kinase to attach itself to the membrane, because recruitment of protein kinase C delta to its membrane is very crucial to further perform its apoptotic function, because then there occurs a conformational change in this particular serine threonine kinase, and upon attaching a NLS, that is nuclear localization signal, this particular protein kinase C delta enters within the nucleus and it performs its apoptotic function, particularly by cleavaging nuclear lamine B1. Nuclear lamine B1 degradation is a major hallmark feature of apoptosis. So Based on these findings, we are again coming to another kinase, that is polo-like kinase, another serine threonine kinase. Here you can see in this figure that polo-like kinase enzyme has two polo box domain and a kinase domain. This blue one is the kinase domain, and this domain is being connected by a linker region. And what happens in normal condition, these two polo box domains are masked by a protein MAP205. It is just for nothing else. It is masked by a protein MAP205. When cyclin dependent kinase 1 protein phosphorylates this MAP205, then polo-like kinase domain becomes free because unmasking occurs and the kinase becomes free, and upon further phosphorylation by Aurora A with the help of Bora in this kinase domain, you can see, then the enzyme becomes functionally active. This polo-like kinase becomes functionally active, and it helps in centrosomal maturation, bipolar spindle assembly, M phase entry, and ultimately mitosis. And another master regulator of mitosis, which we have studied in our laboratory, is Aurora kinase. It is also a serine threonine kinase and very, very important kinase for mitosis. And we have two subfamilies, Aurora A and B. And the functions are centrosome duplication, maturation, and spindle microtubule formation, and chromosome condensation and correct chromosome segregation. Sorry, here it is written, please move this window from the shared. Are these slides visible?
Yes, madam. Go ahead. Yes.
Okay. So there exists a complex interplay between polo-like kinase and Aurora kinase and cyclin-dependent kinase for performing faithful mitosis. How? Because Aurora kinase A, as I have mentioned here, it phosphorylates polo-like kinase in its kinase domain with the help of a protein Bora. Then PLK becomes functionally active, and what it does, it inhibits the functions of V1 protein, which is another protein involved in mitotic pathway. And V1, function of V1 is to keep the CDK1 phosphorylated so that phosphorylated CDK1 cyclin B complex remains in an inactive form. But if V1 gets inhibited by PLK1, then phosphorylation V1 fails to phosphorylate CDK1. Additionally, this Aurora A and PLK1 conjugately, they activate CDC25, which is a phosphatase. Function of phosphatase is to remove the phosphate group. So V1 on one hand, it is failing to phosphorylate CDK1, and CDC25 on the other hand, it is removing the phosphate group. Means even if there is any phosphate group present in the CDK1 domain, that has been removed by CDC25. So this dephosphorylation facilitates functional activation of this complex. Here you can see, where previously we have told that phosphorylation activates a protein. Here is an example where dephosphorylation is activating a protein complex, because CDK1 cyclin B then becomes active and facilitates mitotic entry. Therefore, based on these features, we can say that elevated expressions of these proteins results into loss of strict control, and therefore targeting these proteins may be a rational strategy, and that too by using natural phytochemicals. And for the present study, we have used phenethyl isothiocyanate, which is a isothiocyanate compound. This is the structure of PEITC, and it is found in cruciferous vegetables, particularly in broccoli. Now, for this particular study, we have chosen two human breast cancer cell line. One is MCF7, that is ER positive, PR positive, and EGFR negative, which is weakly invasive with wild type P53. And another one is MDA-MB231, which is a triple negative breast cancer cell line and very, very aggressive type of breast cancer cell line. Now, before look into the details about the role of serine threonine kinases, we just check whether PITC could affect the proliferative potential and clonogenic ability of these breast cancer cells. For this, what we did, we performed first cell viability assay. We treated MCF7 and MDA-MB with different concentrations of PITC and checked the viability. And you can see from this result that upon the viability is reducing in a concentration dependent manner, particularly in case of MCF7. In metastatic cell line also it is reducing its cellular viability. So since PITC is imparting its effect on cell viability, next we checked whether this cell killing viability is reducing means cells are killed, whether this killing is due to apoptosis or any other necrosis or any other mode of killing, for which we perform FACS analysis to check the sub G0 G1 content of the cells, because sub G0 G1 increase in sub G0 G1 population is an indication of apoptosis. And here from this result you can see that there is a significant increase in the level of sub G0 G1 peak upon PITC treatment. We furthermore checked the clonogenic ability of cells in presence of PITC, because cancer cells has the characteristic to remain in a cluster form, in an aggregated form, because they lose the contact inhibition properties. And here also upon PITC treatment for 24 hours, you can see that clonogenic ability has been reduced significantly. All these results indicate that PITC is imparting its effect on breast cancer cells, and that too probably by apoptosis. Now, based on this, we further checked whether these how PITC is inducing or inducing cell killing, whether it is by regulating STKs or not. For that, we first checked protein kinase C delta expression, and it is clear that in case of, we checked the cytoplasmic and membrane fraction as well, and in case of aggressive cell, in the cytoplasmic fraction hardly there is any expression of PKC delta, and in the membrane fraction as well there is no expression has been noted. But in case of aurora kinase A, which is a serine threonine kinase, another kinase, and expression is very, very high in case of aggressive metastatic breast cancer cell line. Not only that, when we checked the phospho aurora A, that is threonine 288, here I must mention and one thing, that aurora kinase A gets autophosphorylated at threonine 288 to become functionally active. So if phosphorylated aurora expression is more, threonine 288 expression is more, this is an indication of active form of aurora A. And in our case, we also found that phospho aurora expression is too high in case of MCF7 and MDA-MB. Not only that, its downstream target protein phospho-PLK1 is also upregulated. So the question comes in our mind whether the how PITC is acting on these kinases, how it is regulating protein kinase C delta, or even if it is regulating protein kinase C delta, is there any change in the nuclear lamine B1? As I was discussing, that nuclear translocation of protein kinase C delta is very, very important event in the field of apoptosis. Then we checked, then we found that with PITC treatment, significant increase in the expression of phospho-PKC delta. Not only that, we observed in the nuclear fraction also we found phospho-PKC delta. Then we checked the expression pattern of nuclear lamine B1, and we found that upon PITC treatment, expression is very low. In the control cell, you can see, and compared to control untreated cells, the expression of lamine B1 has reduced a lot. Then we treated the cells with rotlerin. Rotlerin is a specific PKC delta inhibitor for 1 hour, and with subsequent treatment with PITC, and we found that nuclear lamin B1 expression has been restored or retrieved in presence of rotlerin. This indicates that this reduction in expression of nuclear lamin B1 is probably mediated by PKC delta. Based on these findings, the question comes in our mind whether how PKC is regulating, whether or how the PKC is regulating other serine threonine kinases like Aurora A or PLK1. So we checked the expression of another transcription factor, NRF2, because NRF2 activation is an important factor for, as it plays an important role in anti-metastatic event. And literature shows that PKC delta phosphorylates NRF2 at serine 40 residue, and which facilitates its nuclear translocation. And we checked the expression pattern of NRF2 serine 40, and we found upon PITC treatment significant nuclear accumulation of NRF phospho NRF2. However, upon rotlerin treatment, accumulation has been reduced a lot. Nuclear accumulation of NRF2, here you can see, has reduced a lot. Then we checked the expression of Aurora A in presence of PITC, and we found that upon PITC treatment, expression of Aurora A has been reduced. Whether this inhibition or reduction is mediated by PKC delta, for which we checked, we treated the cells with rotlerin, which is specific PKC delta inhibitor, and we found that upon inhibitor treatment, expression has been increased. Expression, even if I am using PITC, the expression of Aurora A has been increased. Similar results has been obtained here also. When we are using Aurora A inhibitor, here you can see Aurora A expression is decreasing, vis-a-vis PLK is also decreasing. And when we are using poloxine, which is a specific PLK1 inhibitor, then PLK1 expression is decreasing. And if you check here, Aurora A compared to untreated one, Aurora A expression has also been decreased. So it indicates that probably somehow there is a feedback regulatory mechanism between Aurora A and PLK1. As I was discussing that Aurora A is regulating PLK1, and PLK1 may be to some extent regulating Aurora A, but this part of the work we have not yet validated, but this is underway. We have to check it again. So based on these findings, what we found that PITC is exerting its effect on PKC delta, and PKC delta is some way or other is regulating Aurora A. Means upregulation of PKC delta is inhibiting the expression of Aurora A. Means an inverse correlation, inverse association between PKC delta upregulation with Aurora A inhibition. But we didn't find any direct relation between PKC delta with PLK1. It is probably through Aurora A. But in this case, further experimentations are going on for validating the hypothesis. So based on these findings, because in the slide 1, we found that in presence of PITC, sub-1 peak level has been increased. In second slide, we observed that nuclear lamin B1 expression has been reduced. So all these results prompted us to investigate the characteristic features of apoptosis, whether indeed apoptosis is going on or not. We performed tunnel assay, and here you can see that upon PITC treatment, tunnel positive cells were more, and in case of Aurora A inhibitor, also tunnel positive cells were very high, but when we are using rotlerin, then positive cells were tunnel positive cells were decreased. And similarly, we checked DNA ladder assay, and we found that upon PITC treatment, significant ladder pattern has been observed. And upon rotlerin treatment, when PKC delta gets upregulated, then hardly there is any ladder. And all these results and PARP degradation, because degradation of PARP is an important feature of apoptosis. So PARP degradation, cleaved PARP was increased upon PITC treatment. So some notification is coming, but I don't know how to move. Please move this window away from the share slides, but I don't know what to do. Shall I have to do anything?
No, madam. Just is what from your side only, madam.
Okay, okay. So it is obstructing, isn't it? Okay, now it is visible. So based on these findings, we tried to investigate that whether PITC is restraining the migratory ability of breast cancer cells by regulating serine threonine kinase signaling. For which what we did, we performed wound healing assay. We treated the cells with either PEITC or Aurora A inhibitor or Rotlerin plus PITC. Here you can see when in untreated cells, migratory ability of cells were very high and they were capable in healing the wound. But upon PITC treatment, there is a gap that persists, means PITC is preventing the cells from getting migrated towards the wound region. Similar pattern has been observed in case of Aurora A inhibitor, but upon Rotlerin treatment, PITC failed to restrain these cells from getting migrated within the wound region. Similar results have been observed when we perform transwell migration assay. Here also upon PITC treatment, hardly any cells have been migrated towards the transwell matrigel. But upon Rotlerin treatment, you can see significant number of cells has been migrated, even in spite of adding PEITC. And if we calculate the percentage of fold change of migration, here also the results reflected similar trends. So based on these findings, we can say that PITC efficiently altered the functional abilities of serine threonine kinases concerning their entangled functional interplay. Such alterations in protein expression by PITC was chaperoned with inhibition of the aggressiveness of breast cancer cells and ultimately induction of apoptosis. So this is our team members of environmental carcinogenesis and toxicology, and the entire work has been done by Shovik, who is a senior research fellow of my department. And this is the place where I work. And my take home message is, although signaling is very, very complex, but it can be regulated. And thank you for your patience hearing. Thank you so much.
A wonderful presentation.
Yes. Any questions? Any questions to Dr. Sutapa Mukherjee?
Yes.
Yes,
It's
sir.
a good presentation. Congratulations to Sutapa Mukherjee.
Thank you so
Thank you
much.
for your presentation, madam.
Okay,
Thank you for
so
exploring
much.
the breast cancer cell lines with the PETC treatment. So we want to know more about how the migration, the phenomena for metastasis component,
Yes.
how it can be
Yes.
related to in vivo and clinical conditions.
Yes.
Could you explain it in detail? That will be helpful
Yes,
for us to.
yes. Some of the specific marker proteins are there, like matrix metalloproteinase or MMP, particularly MMP2 and 9. And these are overexpression of these proteins facilitates metastatic event. And not only that, some EMT markers, because when metastasis occurs, there is a tendency of cells to move towards the mesenchymal layer. From epithelial layer, cells wants to move towards the mesenchymal layer lining. So, and this movement is being regulated by some EMT markers like E-cadherin, vimentin, etc. So, if we look into the expression of these proteins, maybe in the cell line, maybe in the in vivo model using mice, or maybe in the human samples, patients suffering from breast cancer, if we check the protein markers of these particular EMT markers or metastatic protein markers, then it may give some clue whether the cancer is on the verge of aggressiveness or metastasis or not. That may give some clue as well.
Okay, thank you,
And
madam.
so-
Thank you. And you said that there are wound healing assay and transmigration assay. You did it.
Yes,
These
yes.
two are enough to conclude the metastasis migration assay.
These are the overall findings, but we are looking into the intricate mechanisms. We checked that whether metastasis
Okay.
is going on or not. This is the preliminary findings whether metastasis is going on or not. Now we found that yes, indeed metastasis is going on. Now we are checking the intricate mechanisms, how metastasis is going on, what are the regulatory factors that is regulating this metastatic event in breast cancer. And this work is underway.
Yes, madam, underway. And okay, thank you. And I want to be in touch with you. See, we are also working on the similar line of work.
Okay,
with,
okay, please. I will be
Gila-
glad
Gila-
to. I will be glad to
yes,
share
Gila
our
Cancer
ideas.
Line. Thank you,
Yes,
madam.
yes.
Gila
May
Cancer
I
Line.
know your name,
be.
please?
I am
May
Dr.
I know your-
Sundaresan.
Okay,
I am
okay,
Dr.
thank you.
Sundaresan, professor
Okay.
from Department of Medical Research, SRM University,
I will be
Tamil
glad
Nadu.
to share
Tamil
with
Nadu.
you. Okay,
Thank you,
okay.
thank you, madam. Thank you,
Okay,
madam.
thank you. Thank you
Thank
so
you.
much.
Yes. Any further questions to Dr. Sudappa Mukherjee? Yes. Thank you very much, madam, for speaking on this.
Okay, thank you so much. So may I leave?
Yes, yes, you can go ahead, madam. Thanks for sharing tips. On behalf of
Okay.
Organization Cancer Summit 2021, we want to thank you for your presentation. Looking forward to meet again next time.
Okay, thank you so much, and I'm really thankful to the organizers for giving me this opportunity. Thank you so much.
Yes. Next, we ask Dr. Karin Kabilogi from Clinica Karina Anesthetics and Regenerative Clinic from Philippines. The topic will be explore the latest innovative treatment and prevention of oncology and cancer challenges. We ask Dr. Karin to start the presentation by sharing your slide.
Ay, unmute muna. Can I start already?
Yes, sir. Yes, madam. You can go ahead. Sorry.
Good day, everyone. I am Karen Kabiloke, a clinician. And my task is how to explore the latest innovative treatment and prevention of oncology and cancer challenge. New approaches to tame the immune system in the fight against cancer and getting us closer to a future where cancer become a curable disease. These approaches are personalized vaccine, cell therapy, gene editing, microbiome treatments, and stem cell transplant. These 5 technologies will change the way cancer is treated. Curing cancer is certainly one of the big challenges of the 21st century. Our knowledge of cancer has greatly improved in the last 2 decades, and it seems increasingly evident that there will never be a single cure. Rather, each patient will be treated accordingly to their specific needs. However, for personalized medicine to become a reality, we need a range of therapies wide enough to cover the whole spectrum of cancer. In recent years, there has been a surge of new technologies aiming to help the immune system identify and attack tumors, a field known as immuno-oncology, and these technologies could make a big difference in the way we treat cancer, taking us closer to being the cure to this disease. First, let me tackle personalizing cancer vaccines. Personalized as applied to vaccines refers to targeting vaccine antigens towards an optimized outcome, maximizing immunogenicity and minimizing the risk of either vaccine failure or vaccine reactogenicity and side effects in a host at risk of serious disease or complications. Cancer is caused by genetic mutations that transform healthy cells into tumor cells. These mutations are often at the center of new therapies for cancer. However, they can be very different in each individual tumor. Mutations in cancer are random. If you look at one patient's tumor and compare it to another patient, it would be highly unlikely that there will be a match. Hence, there is one German immuno-oncology company that developed therapeutic vaccines that are created for each individual tumor. By comparing the DNA sequences of the tumor and of healthy cells, the company can identify multiple cancer mutations and select the ones that are more likely to provoke a strong reactions from the immune system. The vaccines are given in the form of RNA, a molecule that gives cells the instructions to create a particular protein, in this case, a cancer antigen that primes the immune system against the tumor. Unlike with gene editing, the vaccines do not directly edit human DNA, but just provide the message. Another advantage is that the productions of the messenger RNA is cheaper than that of other new cancer technological such as cell therapy. Still, the company is yet to establish a manufacturing system that can reliably produce a different updated product anytime. Moreover, these personalized vaccines could be particularly useful for certain types of cancer with lower mutations load like ovarian or prostate cancer. Other technologies such as CAR T therapy might be more suitable for the patients. Another second innovative approach is cell therapy. Another second innovative approach is cell therapy. In 2018, we saw the first approved cell therapy for cancer. The technology is called CAR T cell therapy. Consists of taking immune T cells from the patients and genetically engineering them to target a specific cancer antigen. T-CAR is changing the treatment paradigm for cancer by creating targeted treatments that are specific to cancer cells. This is quoted from a Belgian CAR T developer. The goal is to develop precise, targeted treatments that eradicate disease while sparing healthy tissue and in doing so, improving patients' lives. CAR T clinical trials have shown impressive results in patients that relapse and have exhausted treatment options. However, the technology has also shown some severe side effects that led to patients' deaths. With the potency of CAR T, what you want to absolutely ensure is to target antigen will not be expressed on normal tissue. The technology is so far only available for treating certain rare forms of blood cancer. Several players are developing a new generation of CAR T treatments that can target a wider range of cancer. Among these players is Gilead. The company engineers T cell to carry a molecule borrowed from another cancer cells. This could make it effective not only against blood cancers but also in solid tumors, which are a challenge for cell therapists. Another issue with the technology is its six-figure price. Part of the therapy has to be manufactured individually using each patient's cells. Several companies are developing off-the-shelf versions that can be received from a donor with a simplified manufacturing process. These new and improved generations of CAR T cell therapy are promising. However, they are still in early stages of clinical trials and will need a few years until they can reach the market. Third is gene editing. In the goal of making cancer technology more precise, CRISPR has changed the field of gene editing by making it much simpler and faster to modify DNA sequences with high precision. One of the first medical applications of this technology could be in cancer. In China, scientists are using CRISPR gene editing to remove a gene from immune T cells that encodes a protein called PD-1 that tumor cells can use to evade an immune attack. Another trial with a similar approach is currently running in the US. In addition, CRISPR technology could also be used to improve cancer therapy such as CAR T cells. CRISPR Therapeutics, a Swiss company and a pioneer in the therapy, is behind the first human trial using the technology in Europe, which intended to treat a genetic blood disorder. In particular, they make two edits to the donor cells. The first edit changes the genetic of health donor. These donor T cells so that they are programmed to attack only cancer cells versus indiscriminately attacking the patient's cell. The second edit cloaks the T cells so they don't appear foreign to the body and can provide more durable response. The technology is still in its early stages, and these are concerns that overall effects of using CRISPR in humans are not yet really fully understood. Fourth, let me tackle microbiome treatments. In the last decade, researchers have uncovered that the human microbiome, the collection of microorganisms that live in our bodies, plays an important role in many aspects of our health, including cancer. Elements of microbiome play a role in suppressing an overactive immune system in cancer. A French company named Interom developed medicine based on microbiome science. This new therapy is based on our knowledge of the interaction between the immune system and the gut microbiome. Tumor cells are often invisible to the immune system, and within the microbiome, there are peptides that mimic antigens on the surface of the tumors. This can be used to make the tumor visible again to the immune system. Enterom has created a cover reclaimed based on these tumor mimicking molecules, which generates strong immune response against the tumor. Interom aims to combine this technology with checkpoint or inhibitors, a type of drug that blocks one of the mechanism by which tumor cells hide from the immune system. Fifth is stem cell therapy or stem cell transplantation. Stem cell transplants are used to treat conditions in which the bone marrow is damaged and no longer able to produce healthy blood cells. Transplants can also be carried out to replace blood cells that are damaged or destroyed as a result of intensive cancer treatment. Stem cell therapy or stem cell transplants are used to replace bone marrow cells that has been destroyed by chemo or radiation used to treat cancer. All the blood cells in your body, white blood cells, red blood cells, and platelets, start out as young immature cells called hematopoietic stem cells. It means blood forming. These are very young cells that are not fully developed even though they start out the same. These stem cells can mature into any type of blood cells, depending on what the body needs when each stem cell is developing. Stem cells mostly leave the bone marrow and enter the bloodstream. Stem cell transplants that are being done came from three possible sources. First, bone marrow. Second, the bloodstream. Third, umbilical cord blood. When they are given into a cancer patient, the stem cells are put into a vein, much like a blood transfusion. The stem cells travels into the bone marrow, engrafted, and then start making new normal blood cells. The new cells are usually found in the patient's blood in about 4 weeks. The goal of the transplant is to wipe out the cancer cells and the damaged or non-healthy cells that aren't working right and give the patient new healthy stem cells to start over. In conclusion, advances in multiple fronts are increasingly making cancer a more manageable disease. There are still many unmet needs in cancer. Any new and effective treatment will be a positive addition to the oncologist's arsenals. With more options available, patients will be able to get therapies that are specific to their needs. Most of these new technologies against cancer still have to prove their worth in clinical trials. Even in the best case scenario, it will be several years until they are available. However, we are on track to reach a future where cancer treatment is personalized and the chances of beating the disease are higher than ever. Thank you.
Wonderful presentation. I have two questions in this.
Yes, sir. Go ahead.
Number one is talking about the stem cells. If I am not wrong, actually aggressive proliferation takes place only when the somatic cells or differentiated cancer cells transform into stem cell, pluripotent stem cell state. How is it going to actually correct the deregulated pluripotent stem cells? Second question I would like to ask is, you talked about the microbiome, and that is an important development actually in the past 10 years. We are seeing that much of the pathology is because of the circulating metabolites that are released inside this thing, and that varies with the type of diet also. What type of actually metabolites are circulated with this, and what type of microbiome, how actually the circulating metabolites are altered because of the microbiome?
Can I get the first question first?
The first question
Please
is
come again. Yes.
it is the differentiated cells or somatic cells transforming into pluripotent stem cells is the cause of aggressive cancer, right?
Right.
Then in that case, if you are transplanting your stem cells, what is the guarantee that they do not transform into pluripotent stage and then proliferate? That is number one.
What you mean is that when we transplant the stem cell, is it differentiated or not? Am I right? Was that the
Yeah,
question?
yeah. Actually, the carcinogenesis occurs
It
because of,
depends upon the type of stem cell, because if we do mesenchymal stem cell, they get to be differentiated and then divides into certain organs of the body wherein they are needed.
yeah.
So that type of stem cell that is differentiated is the best type of stem cell, which will be ideal for the cancer patients. Normally we have in the market mesenchymal stem cell, which is derived from human bone marrow of a healthy adult human, and then it differentiates into many different cells and becomes and regenerates the organs that really need regeneration. Did I answer your question? Sorry.
Sorry,
Yeah,
just you can.
is it actually, does it actually promote immune cells which will be killing the carcinogenic cells? Are there any specific uh, mechanisms, methodology to select actually that type of cells which will be actually recognizing metastatic cancer cells and then kill them?
These are the type of stem cell that they normally, when given in the right amount, would counteract the bad cells or the negative cells or the unhealthy cells in the body. So the oncologist should know how the exact amount of that bad cells, and then the oncologist should also know how much amount would he transfuse with the healthy cells to counteract the bad cells.
One final question in this is, will we be in a position to modulate the stem cells for a specific purpose of killing actually the aberrant cells, either in terms of immune improvement or in terms of phagocytosis?
There is one diagnostic assessment tool that is used in China, which they call quantum resonance imaging. It's using artificial intelligence, and then what they do is they monitor how rapid would the metastatic activity in one organ of a cancer patient. Uh, if properly monitored, I think the healthy cells that we would give or transplant to one patient will be regulated and be quantified as to how much would we need for a patient to counteract the metastasis of the cancer. This assessment tool is radiation free, and you can do it as often as possible, which will not be risky for the patient to have unhealthy cells and metastatic cancer cells.
Yeah.
So it would depend on the monitoring, the frequency of the monitoring for you to monitor, for you to have a real quantification of the healthy cells and the metastatic cells.
Okay, thank you. Let us go to the second question. What are the metabolites that are normally activated in the blood circulation and type of microbiome that is actually secreting these molecules?
Uh, the metabolites. Wait. Uh, Normally, as I understand, I would try to research more on it. But as I understand, microbiome in the digestive system includes the probiotics, probiotics that we are trying to release every time that the organs are deteriorating. So,
I'll give a lead in that particular question, and then you please examine that. For
yes,
example,
sir. Thank you.
in case of lung cancers and also stomach cancers, it is definitely proved that lactic acid circulation increases actually carcinogenesis in these cases, and lactic acid producing microbiome increases the carcinogenesis. That is number one. Second is from the pandemic stories in Nature, June 24 also, there are several articles on that, but earlier also, short chain fatty acids are lipopolysaccharide binding proteins if they are secreted, or branched chain amino acids are
Sai,
secreted. That leads to
picture.
what is called
Dito.
cell death pathways and diabetes, obesity, right? How do we distinguish the type of microbiomes that need to be used, and how actually what would be the dietary relationship with the type of microbiome?
How do we differentiate the micro microbacteria or microbiome?
Oh, yeah.
Sorry, I didn't get the question.
Sir,
Now,
you
what
can
would be the products? Generally, what type of products actually they will be secreting into the blood? That will be the important question in actually approaching the microbiome theories. And that should be related to actually dietary monitoring also, in my opinion.
Sir, you can text in chat box, sir, so that everybody can understand the question you are asking. You can text in chat box.
Okay, thank you. Thank you for this too.
Thank you, doctor.
So are you going to ask further questions, sir?
Pardon?
Are you going to ask any questions furthermore?
These are the two things. Actually, these are two important approaches, but actually, we need to optimize diet microbe relationship, and then what is the output that will be entering into the circulation. That is one of the important questions which we need to add in microbiome. The second important thing in case of stem cell therapies is whether actually we are in a position to actually kill metastatic cancers by increasing the immune cell systems. That is one question actually which we need to, or phagocytosis of actually those cells. Unless these two approaches are optimized, we will not be in a position to control actually carcinogenesis. On the other hand, we may increase the carcinogenesis in stem cell therapy. That is my opinion, because it is well known now in the past 20 years. It is only transformation of cells to the mesenchymal state that creates actually aggressive cancers. Many of the drug therapies which cause actually these things are are not in a position to control these things. Aggressive cancers relapse reason is mesenchymal stage increases, and that particular stage repopulates actually the carcinogenic tissues. So unless we have actually a specific cell type which will be controlling mesenchymal cells, stem cell therapy approaches need to be optimized in that direction is the purpose of my question.
Thank
Sir,
you for the information, additional information, doctor.
Yeah, thank you.
yes.
Thank you. It was a good presentation, but these are the two questions, which are plaguing my mind. Tomorrow I'll be talking about actually the metabolome, how actually that regulates triose phosphates and hexose phosphate shuttles there. That pathway, basically the metabolic pathways themselves are actually deregulated in this 20th century. Hype on glycolysis and lactic acid. Tomorrow I'll be talking about that. Okay, thank you very much.
Yeah. Any further questions to Dr. Karin? Any further questions? I think so many questions from Dr. Lakshmipati sir. Yeah. Just if you have any further questions, sir, just you can mail us officially. We'll be sharing Dr. Karin's email ID officially. You can ask any if you have any further questions officially. So thank you so much, madam, for participating in this event. Since you are participating last 2 years on behalf of Inovine Conference, we want thank you for recent presentation. Looking forward to meet again next time.
Yes, thank you, doctor.
Yes. Next we ask
Thank you.
Dr. Noshin Muhammad from King Saudi bin Abdulaziz University of Health Sciences from Saudi Arabia. The topic will be disparaging link between microRNA 21 deregulation and smokeless tobacco
Tapos na yata ang
in the oral cancer, a potential capsule is blend.
Ay, hindi pa naman. Hindi pa pa naman.
So next we ask.
Hello, good afternoon. Can you hear me?
Yes, madam, go ahead.
Okay, let me just share my screen and then. All right, thank you so much for having me in this conference. And as we have gathered here from different time zones of the globe, so very good morning, good afternoon, and good evening, respectively. It is so exciting to be a part of this conference. And today I'll be talking about deciphering the link between microRNA 21 dysregulation and smokeless tobacco product use in oral cancer, a potential cancerous blend. So this is the outline for today's talk. I'm going to give you some background as to why this topic was interesting to me. Then I'll quickly drive you through the methodology and discuss my results with you. So I would like to start by sharing with you the ideas that steered me to do this research. Oral cancer is one of the huge problems seen in developing worlds, including Southeast Asia and Pakistan. So I will never forget that day. It was 13th of March 2013, when as a pathologist working in Ziauddin University, I saw this patient with oral cancer. This guy, who was just 42 years old, he presented with a non-healing ulcer in the cheek that over a period of 6 months became this huge tumor. And you can just imagine the amount of misery. And so is another guy who's just 35 years old, presented with a cheek lesion, and this guy. So looking at the misery of these patients and the fact that this cancer is so common in Southeast Asia, including Pakistan, there is a huge discrepancy in distribution of oral cancers. While it does not stand in the list of top 10 malignancies worldwide, the scenario is very dissimilar in Pakistan. Here, it is the most common cause of cancer amongst men and second only to breast cancer amongst women. The rising incidence as well as significant morbidity and mortality associated with cancer is another disturbing fact. Majority of the patients, they present at an advanced stage, and the survival is also very poor. The role of smokeless tobacco product chewing in the causation of oral cancer is no more a hidden fact, as a wealth of literature can be extracted to confirm such association. While I totally agree with the fact, and I believe that this is the major contributor, but I also think it's not the sole contributor. And there is some blend between these unhealthy life habits and some molecular events that are going on that results in carcinogenesis. The reason being, not everyone who is chewing these products ends up into cancer. And the progression of oral cancer from normal mucosa to frank carcinoma is a multi-step process. This involves various genomic and proteomic alterations, including unhealthy lifestyles and And if you look back, for years, the researchers have focused on identifying genes and proteins as the possible mechanisms. It's only over last couple of decades that they have started to investigate the role of non-coding RNA molecules, with microRNAs emerging as an alluring target for the research community. Identification of microRNA has revolutionized our understanding about the gene regulatory network. These short 18 to 22 nucleotide non-coding RNA molecules, they are referred to as the micromanagers of the genome. First microRNA was identified in Caenorhabditis elegans by Lee et al. In 1993. The following 7 years, there was no discovery until the first human microRNA, LET7, was discovered by Renat et al. In 2000. And thereafter, immense research was conducted in the field of microRNAs. And to date, we have more than 2,500 mature microRNA sequences registered in Mirbase. Now, what they do, these are non-coding RNA molecules, and we are saying that these are micromanagers of gene expression because of their ability to affect multiple genes. What they do is they have got binding sites in the 3' untranslated region of the messenger RNA of target genes. So it just goes there and binds there. And this binding, depending on the degree of complementarity between the two, the microRNA and its binding site in the messenger RNA, will either lead to silencing or to complete degradation of the messenger RNA. In this way, it blocks its target genes. So microRNAs, what is very interesting about the microRNA is the fact that they have capability. Their capability as genomic signatures is rising steeply. The potential of discriminating various tumor traits brand them as ideal diagnostic and prognostic markers. Their expression is abundant in tissues as well as different body fluids. Their detection is reliable and quantifiable. And with the fact that a single miRNA can bind multiple genes, their therapeutic potential should not come as a surprise. What is their role in the cancer? Now, they can act as either oncogenes, which are referred to as oncomeres, or they may act as tumor suppressor genes. And this role is dictated by the target gene it binds to. So an miRNA which binds to the tumor suppressor gene, it's going to suppress the messenger RNA, ultimately resulting in oncogenesis. So those are referred to as oncomeres, and vice versa. Tumor suppressor miRNA blocks the overexpression of oncogenes. We chose to work on microRNA 21. This is one of the most studied microRNA, was one of the first mammalian microRNA, which is highly conserved across all species. It is found to be upregulated in oral cancer, which has been confirmed in tumor tissues as well as in saliva and in plasma. Moreover, they have got therapeutic potential. Upregulation of microRNA 21 is associated with increased chemoresistance to cisplatin, a chemotherapeutic agent that is used in oral cancer treatment. And interestingly, we have microRNA 21 antagomeres being produced by Regulus Therapeuticus, though they have still not entered into clinical phase, but clinical trials are going on. Phase 1 and 2 trials are going on. So with all this set of information, with the fact that oral cancers are so common in our part of the world, and microRNAs could play a role, we came up with the following research questions. Is it possible to detect and quantify microRNA 21 in circulation? Because studies have shown that it does express in the tissue, but whether it holds true for the circulation, because identifying anything in the circulation offers us a lot of benefits. So that was our first target. Then to see if it is upregulated in oral cancers, does it have any discriminative potential? Is there any association with the tumor characteristics? Is there any association with smoking and chewing habits? And is there a link with the poor survival? And to answer these questions, we designed a case control study, which was approved by Ziauddin University. and all the molecular work was done at Molecular Lab of Karachi Institute of Radiotherapy and Nuclear Medicine. We selected biopsy-proven cases of oral squamous cell carcinoma and agent sex-matched healthy controls. The study was approved by Ethical Review Committee of Ziauddin University. Sample size was calculated using OpenEpi software. And briefly, this is the workflow. We recruited cases from oncology department. These were biopsy-proven cases, and the controls were agent sex-matched. Informed written consent was taken. 5 ml of venous blood was collected. MicroRNA was extracted. cDNA synthesized, and RNA extraction was done using real-time PCR-based methodology. This is what we got. The results, gender distribution as expected, as said, it's more common in the males. So we found that there was a ratio of 2:1 amongst males as compared to between males and females. And it can be seen that 85% of our subjects, they were using some form of smokeless tobacco products. The topographical distribution of the cancer, it very much correlates with the use of smokeless tobacco product, as it can be seen that 79% of the patients, they had the lesion in the cheek. When we compared the microRNA-21 expression, we found that it was significantly higher among cases as compared to controls. Next, we ran a receiver operative curve analysis, and we found a significant discriminative potential of microRNA-21 to differentiate between cases and controls. Next, we compared microRNA-21 expression in relation to patient characteristics. And we found that there was no difference between different age groups, gender, or smoking status, but we did observe a significantly higher expression among good gut chewers, beetle good chewers. This graph shows a higher expression of microRNA-21 among good gut chewers, as evident by a lower CT. Next, we ran the survival analysis curve to see the effect of survival among good gut chewers. And what we observed was good gut chewers, they had a significantly lower survival as opposed to those who were using other smokeless tobacco products. To find out the correlation with the chewing, there was a significant association between the frequency of chewing and microRNA-21 expression and years since chewing. So those who were chewing it for a longer period of time, they had a higher expression of microRNA-21. Upon comparing the microRNA-21 expression with different tumor characteristics, a positive association was seen with tumor size, with the nodal status, tumor metastasis. However, there was no association with the tumor grade. So I would just quote few of the studies which have also replicated similar findings. MicroRNA-21 expression has been observed in oral squamous cell carcinoma in both plasma as well as tissue by Inovine et al. Singh et al. Conducted a study on oral squamous cell carcinoma, and they found a higher expression among cancer as well as pre-malignant lesions. Zehran et al., they conducted a study. They also included the cancer patients and pre-malignant lesions, and they found a higher expression level even in the saliva. Salivary microRNA-21 expression is higher in oral submucous fibrosis. Tissue expression of microRNA-21 is higher in oral squamous submucosal fibrosis. And it has been observed that microRNA-21 overexpression is linked to poor survival. So I would like to conclude, these were the conclusions that we could draw from this study. There was a positive correlation between microRNA-21 expression and amount and duration of smokeless tobacco products use, with the significantly higher level observed in good gut chewers. Circulating microRNA-21, it echoes the tumor size, nodal and locoregional and distant metastasis, and use of gutka is linked to poor survival in oral squamous cell carcinoma. These are some recommendations. As we examine the expression once before starting any treatment. So we highly recommend that pre and post-treatment expression will edify their role in a targeted therapy, and serial measurements to explore acquisition of new tumor traits. So let's say if we keep on monitoring it every 3-4 months and then see when the tumor acquires any additional trait, or it becomes metastatic, or it starts to invade locally, what happens to the microRNA 21 expression level. And it's the time that clinical trials be started on the personalized treatment, and those who have a higher expression, they be segregated and they be given personalized treatment. Now, it does the future prospect of microRNAs, as we know that cancer treatment is an evolution. The concept of one size fits all is no more prevalent. Newer approaches include targeted therapy based on individualized molecular profile of the patient that makes it both cost-effective as well as less toxic. Development of microRNA diagnostics and therapeutics is exciting and potentially new frontier as FDA-approved small RNA drugs begin to enter area of clinical medicine. There are some challenges which need to be overcome before translating experimental findings into clinical utilization, and those small hurdles will soon be passed. We are already having phase 1 and 2 clinical trials. These are being run by different pharmaceutical companies, including Mirogene, Regulus Therapeuticus, and miRNA Therapeuticus. And interestingly, the Entagomir for microRNA 21, it has been approved as an orphan drug by FDA for the treatment of Alport syndrome, and this has also been approved as a therapeutic in progress by the European Commission. And with all this, I have absolutely no doubt in repeating the words from Subramanian et al., who say that landscape of both interventional and diagnostic medicine will continue to evolve as miRNA pass through clinical trials, and future of microRNA therapeutics is absolutely guaranteed. These are the co-investigators of my presentation, and I would love to share this this code that I found in the internet, that there is a can in cancer because we can beat it. So hopefully with advancement in therapeutics, we can do something which will ease lives of our cancer patients. Thank you very much.
Yes. Any questions?
Well, it's a good presentation. I just want the clarity I want to ask. Are these microRNA which are causing diseases, are they splice variants or the products of actually endonucleosis?
No, they're not splice variants. They have their gene just like we have normal genes. So we have microRNA genes. They are transcribed by RNA polymerase 2 and 3 into, first they are like primary transcripts, which is a long transcript that gets cleaved by certain enzymes. It is exported out of the nucleus into the cytoplasm, where it undergoes further degradation by certain enzymes until we get the final product. So it's a very detailed, I can talk about the mechanism, how they're being produced, but they have gene, just like we have a gene for a protein. So gene transcribes into messenger RNA that translates into proteins. So is the case with microRNAs. They have their genes, miRNA genes, which may be intergenic or intragenic, and then they are transcribed into these short nucleotide. To start off, it's 7200 nucleotides, then after splicing and removal of the tail, and then there is a helicase which breaks the bond. So ultimately you are left with a single-stranded short 18 to 22 nucleotide RNA molecule. And what it does, it binds to the messenger RNA of the target gene and it silences or suppresses it.
Thank you.
Yes. Any questions further to Dr. Nashyan? Yes. Thank you so much, madam, for participating in this event. And
thank you so much for having me. Thank you. It was nice.
Yes. Within the couple of days, even after the completion of the conference, you will be getting electronic certificate as well as booklet officially through your email.
Thank you so much. And if there is any question, you have my email. It
Yes.
can be shared and I'll be very happy to answer the queries.
Yes. Thank
Thank you so much.
Yeah, thanks for your sharing. Looking forward to meet again next time in physical event if everything goes well in 2022.
Sure. Thank you.
Yes. Next we ask Dr. Abdullah Hal Masood, Assistant Professor from Dhaka Dental College from Bangladesh. The topic will be oral and perioral oncologic defect destruction by microsurgical free flap in resource constrained in Bangladesh. You go ahead, sir. You can by sharing your slides.
তুমি ইয়াতে চলে যাও
Sir, are you going to share your slide? Dr. Abdullah Masid. Yes.
now can you hear me? Thank you
Yes,
very
sir.
much.
Yes, I
Good
can hear
evening.
you. I can hear your voice, but we cannot see your slide on the screen. Start sharing your PPT. I think yes, it's going to open, sir. Yeah, it's fine. So in top of the screen you can find slideshow. You can click on the slideshow after the animation.
The animation.
Okay, go ahead, sir. Go ahead. You can go ahead according to your convenient.
Now is it okay?
It's fine, sir.
Okay, welcome you all in the fourth virtual conference on Cancer Science and Oncology. I am Dr. Abdullah Masood from Bangladesh. Very good evening. And my topic is the oral and perioral oncologic defect reconstruction by microsurgical free flap in resource constrained Bangladesh. I am Dr. Abdullah Masood working in Dhaka Dental College and Hospital. It's a 100-bed oral and maxillofacial surgery hospital, and among the 50% of patients are occupied by the oral cancer. As we know, oral cancer is the sixth most common cancer in the world, but in Bangladesh, it is the second most common cancer in Bangladesh. And this is the second most commonest cause of death by cancer in Bangladesh. And we know the factor associated in this subcontinent is the same, such as the gutka, khoini, smokeless tobacco, pan, jarda, etc. So the situations is more common in this subcontinent and in Bangladesh also like the similar. And the commonest side is the cheek, lip, and tongue. These are the most commonest side, and it looks like some area is fungating and necrotic. These are the common scenario. So we can diagnose the oral cancer by taking the history and clinical examination as well as the histopathological examination also. And we know the surgical procedure is the main therapy, as we have the lots of therapy we can apply: surgery, radiation therapy, chemotherapy, targeted therapy, and palliative treatment. but we know that when it is resectable, then surgery is the first treatment line. And in my cases, I have done these works in various institute, among more than 10 institute, among them the, the BSSMU Hospital, Bangabandhu Sheikh Mujib Medical University, and National Head and Neck Institute, and etc. Then why I use the term the resource constraint as we reconstruct this lesion. So we face that we have to work in a different center, and we working in a different team, and inadequate armamentarium and lack of light, even the microscope, and also the lack of logistic support. And each and every day we face the advanced cases, because due to the delay of the patient, they don't know where and how it is treated. Is it treatable or not? They don't know the answer. So maximum patient we operated, these are the advanced lesion. And in case of advanced disease, we have to reconstruct it, because people wants the most natural looking, and they want the functional outcome. So let's see few cases, then I will analyze my case summary. It's a case of GB sulcus cancer, also affected the lip, and we done the neck dissection as well as through and through three-dimensional clearance. This is the defect, and it was reconstructed by the radial forearm free flap. And this is the outcome. And it's a patient who used the ghoul, the powdered form of the smokeless tobacco. And he used this tobacco about 25 years. And he also a brother of a dentist. And we did the three-dimensional excision for more longevity, and bilateral neck dissection. And this defect was reconstructed by the radial forearm free flap. And this is the outcome after radiotherapy. And it's another case of GB sulcus cancer, and also involved the skin. So this is the three-dimensional excision along with the neck dissection. And this was reconstructed by the radial forearm free flap. Special pattern was taken to improve her mouth opening. You can see the mouth opening is very fine. And it's another case of GB sulcus and retromolar area cancer, and also the skin is involved. For the functional outcome, I use the nerve cooptation also with the anterolateral free flap. Here you can see that we preserve the upper and lower labial nerve as well as the mental nerve, and it was reconstructed by anterolateral thigh flap, and the nerve of the vastus lateralis muscle. It is also coopted with the facial nerve trunk. Then the outcome was very good. And in case of tongue cancer, we know that tongue is a very mobile organ, and it has some fingering action, and its mobility is very important. So free flap is the answer. And after resection, the tongue is reconstructed by the radial forearm free flap. That's why tongue can move. There is, you can see in this picture, the tongue protrusion, he can touch the tip of the tongue in the palate, and his outcome is very good. And it is a near total glossectomy, and it was done by the pull-through technique, and bilateral neck dissection was done as because patient has received the radiotherapy. That's why, and it is reconstructed by the anterolateral thigh flap. It is a special design, and this is immediate after the reconstruction, and this is 3 months after reconstruction. Looks like the new tongue. And he has some mobility as because we co-opted the nerve of the vastus lateralis muscle with the hypoglossal nerve. And he can chew, and he can take the liquid and semi-solid food, and his speech is understandable. It's another case of advanced tongue cancer, and we excised up to the we excised the extended hemiglossectomy as well as the neck dissection. And as the tongue needs the mobility, so here the special pattern is done in the hand, radial forearm, and this is the ultimate outcome after extended hemiglossectomy and reconstructed by the radial forearm free flap. And there are some GB sulcus cancer which is involved the mandible, so we have to resect the mandible as well as the skin. So we now plan to do the reconstruction by the fibula flap, as because patient needs the aesthetic and function also. So here is the resected margin, and it was reconstructed by the fibula osteomyocutaneous flap. This is the immediate after reconstruction, and this is 3 months later, and this is the outcome. Her contour is intact, and she is very happy with this. And in case of large GB sulcus cancer, where the fibula skin is not so much suitable, on that case we apply the anterolateral thigh flap. Only the soft tissue we can reconstruct by the anterolateral thigh flap, and this is the outcome after 5.5 years later. It's another case of GB sulcus tumor, which was reconstructed by the anterolateral thigh flap, which was reconstructed very well, and he is also the survival more than 6 years. And in some cancer, which is where the ITF is also involved, we do the operation, and this is ITF involved cancer in the maxilla, as well as the node is positive, and we do the chimeric anterolateral thigh flap, one flap for the palate and one flap for the neck, and the result is very good. It's a T4B cancer, high ITF, and patient is also have some comorbid diseases, like is the hypothyroid, patient is epileptic, and he has the sodium depletion, and we had did it successfully, and we did the reconstruction by the anterolateral thigh flap, and up to 4.5 years, patient is very good without any recurrence. It's another case of GB sulcus and ITF, low ITF involvement, and we did the compartmental resection, both the mandible and maxilla and the ITF content, and reconstructed by huge anterolateral thigh flap. And this is the immediate result. This is after 2 years, and this result is satisfactory. Patient is very good. In case of floor of the mouth lesion, you see we need the 3-dimensional resection, as well as patients needs a good outcome. So the choice is the fibula free flap with the skin also, and this is the excision specimen, and you can see the fibula with the plate, and the result excellent outcome in the floor of the mouth, and patient is very much satisfied. So in case of very advanced diseases, sometimes we need a double flap. That is, we reconstruct the mandible by the fibula and the outer skin by the anterolateral thigh flap. It's a huge advanced cases. Bilateral neck dissection was performed, and the reconstructed by the fibula and anterolateral thigh flap. So in our 200 cases, our total failure is 20. That is our 90% success. In case of fibula free flap, our success rate is 80%. In case of radial forearm free flap, our success rate is 19.90. And in case of anterolateral thigh flap, our success is 92.17. And the majority of patients had not received chemotherapy or radiotherapy before surgery, but every patient used to receive the radiotherapy after operation, that is adjuvant radiotherapy, and 6.25% patients had received radiotherapy and chemotherapy before surgery. And our success rate is 90% and failure is 10%. So in conclusion, I want to say the oral cancer is a major problem in a large burden of advanced cases in our country, and multidisciplinary approach needed, and single modality treatment for early stage and combined modality for advanced stage disease. And compartmental resection have promising result, and salvage for advanced disease has also satisfactory outcome. Thank you very much.
So any questions to Dr. Abdullah Al Masood? Just if you have any questions regarding this topic, you can text in chat box. We'll be asking behalf of you. Yes. Thank you very much, sir, for speaking up in this event and providing a unique perspective. Thanks for sharing your tips with us. Also, on behalf of Virtual Cancer Summit 2021, our organizing committee, thank you for your presentation. Looking forward to meet again next time. Next, we ask Dr. Anita V. Hardor from Research and Development Department, Sigma Limited Private Limited from Nashik, India.
Hello?
Yes, madam.
Can you hear me, sir?
Yes, yes.
Oh. Just a minute. I am sharing my screen. Is my screen is visible, sir?
Yes, sir. Just be online, madam. Yes, it's fine, madam.
Hello and welcome to this presentation. Myself, Dr. Anita Handore, in charge and Research and Development Department, Sigma Wineries Private Limited, Nashik, India. Today I am going to present a topic, phytochemicals, the promising chemopreventive agent of upcoming era. But before going to this presentation, let us see the background of this presentation. So worldwide, cancer is one of the leading cause of the mortality. And as per the database of Globocan 2020, almost 10 million cancer deaths occurred in 2020. And expected global burden is about 28.4 million cases up to 2040. Although oncology treatment has made remarkable progress in chemotherapy, radiotherapy, surgery, immunotherapy, and targeted therapy, the treatment outcomes are still unsatisfactory due to the survival rate, side effects, efficacy, cost effectiveness, and few other obstacles with respect to the mechanisms of cancer drug resistance. So to overcome such limitations, there is high demand of natural chemopreventive agents like phytochemicals, which are the plant-derived bioactive compounds, and they show good ability to stop, postpone, and reverse carcinogenesis by specific mechanism. They could also be used as a promising option to improve the treatment efficacy in cancer patients and decrease adverse reaction and side effects of the cancer treatments. So in this context, there is need with respect to adaptation of the novel approach for cancer chemoprevention. Here we could see some factors responsible for the cancer development, such as reactive oxygen species, some radiations, biologicals like viruses, bacteria, few mutations, and chemicals. Here you could see the slide showing global cancer statistics. In this table, we could see leading sites of new cancer cases and deaths 2021 estimates. In case of the estimated new cases, here we could see that male cancer with respect to prostate cancer is highest, that is 26%, whereas in female, the breast cancer shows highest percentage, that is 30%. And estimated deaths are similar for male and female, which are for lung and bronchitis. Here you could see the existing cancer therapies like hormone therapy, surgery, bone marrow transplantation, chemotherapy, targeted therapy, immunotherapy, and radiation therapy. And these are some side effects of these different therapies like bleeding, blood clots, damage to nearby tissues, pains, infections, skin problems, intense itching, and various type of allergies. So let us look at limitation of these existing cancer therapies. So cancer treatment based on broad use of the cytotoxic therapies in unselected patient had reached its therapeutic plateau. Similar to any other cancer therapies, targeted therapies had its own limitation. For instance, identifying a molecular target needed to begin treatment as a specific molecule is crucial in such kind of treatments. Also, the toxicity which appears during the treatment is one of the major issue in case of the traditional chemotherapy and radiotherapy. Such mechanism of cancer drug resistance then develop in the response to given drugs is one of the obstacle, and it makes further treatment very impossible. Besides these immunotherapies, it may also cause a severe adverse reaction due to this overactive immune system. So, since last few decades, it is observed that synthetic drugs couldn't improve the overall survival rate. Existing therapies are also costly and having various side effects. So, in view of this, existing cancer therapies suggest a multimodal approach for effective cancer treatment and sheds deeper light on the cancer chemoprevention by using the phytochemicals. Let us see the multimodal approach of the phytochemicals in cancer chemoprevention. So, cancer chemoprevention has long been recognized as an important prophylactic strategy to reduce the burden of the cancer on healthcare system. Also, it assumes that use of one or more pharmacological active agents to block, suppress, prevent, or reverse the development of invasive cancer cells. In this context, these phytochemicals, which are clinically proved plant-derived natural phytochemicals, shows potential to block, suppress, postpone, stop, or reverse the carcinogenesis. These can be actively and effectively used as a chemopreventive agents. During the epidemiological study, it is found that various phytochemicals shows to inhibit the molecular events and signaling pathways associated with various strategies of cancer development. Here you could see different chemopreventive properties of phytochemicals such as chemical diversity, biological activity, easy availability, lack of toxic effects, then ability to modulate the various signal transduction pathways and cell processes. And these all properties are enriched with their mechanism such as antioxidative activity, then induction of the phase 2 enzymes, anti-inflammatory activity, cell cycle arrest, apoptosis, and autophagy, etc. In this slide, you could see various anti-cancer activities and the molecular targets of phytochemicals. So let us see different promising phytochemicals, their dietary sources, and chemopreventive mechanisms. Now, first one is the resveratrol. This one is the polyphenolic compound, and it is a stilbenoid. It belongs to stilbenoid group. It is generally found in grapes, blueberries, raspberries, mulberries, peanuts, etc. This resveratrol exhibits anti-inflammatory response by down-regulating pro-inflammatory factors. It also decreases survival-related proteins including PI kinase and AKT. Further, the signaling cascades are impeded by the down-regulating of NFKB, MAP kinase, and TNF alpha, resulting to the inhibition of mTOR. In addition to this, resveratrol can decrease the expression of anti-apoptotic marker of BCL2, apoptotic pathway, which are controlled by the upregulation pro-apoptotic proteins, which are responsible for the cell death, such as BAX, then caspase-3, with an increase in the DNA fragmentation. In addition to this, resveratrol can play key role by inducing the signaling pathways such as AMPK, SERTIN1, then HO1, P53, P21, P16, eNOS, and glutathione peroxidase, NFKB, and MP kinase. Second one is the quercetin. It is also a polyphenolic compound, but it belongs to flavonoid group. Grapes, other few fruits, vegetables are source of this compound. This compound is able to regulate cell cycle by directly binding several molecular targets depending on the cell type and tumor origin. Also, it blocks the cell cycle at G2M or G1S transition. At the G1S transition, this compound locks cell cycle progression through the upregulation of P21, P27, and P53. Apart from the blocking of cell growth through the direct action on the key modulator of the cell cycle, this compound also induces apoptosis via mitochondrial pathway. It is also found that it can disrupt the MMP, which in turn provokes the release of the cytochrome C in the cytoplasm. Next one is the terpenoid, which is volatile substance of terpene group. This compound inhibits cellular survival pathways and downregulation of the cyclin and CDK protein. and ultimately leads to inhibition of the tumor antigenesis, then metastasis and inflammation and cell proliferation. Next one is carotenoid, which is a group of pigment. Generally, this group are present highly in yellow, red, orange colors fruit. This carotenoid can induces the activation of the PI3 kinase AKT survival pathway. Also, it triggers the phosphorylation dependent inactivation of the BAX, which leads to apoptosis by decreasing capsid activity. They can also maintain the mitochondrial integrity by resulting P38 MAP kinase signaling pathway. Now, next one are peptides. These are the short strings of the amino acid. And this compound exerts anti-tumor activity by different mechanisms like apoptosis induction, blocking of the tumor generation by regulating cellular mechanism associated with the cell proliferation. Also, survival and biosynthetic pathway which can control the cell growth, along with the regulation of immune system function with respect to the antigenicity, immunogenicity, and susceptibility of the cancer cell. Next one is a piperine. It is a alkaloid compound, and it is generally found in black pepper or long pepper. This compound interfere with the cancer proliferation by inhibiting the expression of the cyclin, CDK, and other molecular regulator of the cell cycle. It could exert the anti-migratory, anti-invasive, and anti-metastatic effect by blocking the VEGF and VEGFR signaling pathway, as well as MMPs. Also, it rises in the cytochrome 450 and glutathione metabolizing enzymes by indicating its anti-cancer activity. It is also able to abolish the tumorigenesis by down-regulating oncogenic factors and by interfering with the ROS signaling pathway, that is reactive oxygen species pathway. It is selectively induces apoptosis and autophagy by acting the expression and activity of the related protein and signals. Next one is the phytosterol, which is phytosteroid compound, and it is generally found again in grape, different type of vegetable oil, nuts, legumes, etc. Generally, incorporation of the phytosterol changes the membrane composition by inhibiting cholesterol absorption, which targets signal transduction pathways. Also, this phytosterol suppresses the tumor metabolism by decreasing activity of the 5A reductase and aromatase and inhibits the sodium, potassium, and ATP's activity. Secondary messenger also affects the host immune function and stimulates T cell proliferation, pro-inflammatory cytokinase, and NFKB activation. This compound can also affect the cell cycle kinetics, promoting the cell cycle arrest in Z0, Z1, as well as Z2 phases and apoptosis. The next polyphenolic compound is ellagic acid. It is also effective phytochemical which can be used as an anti-cancer agent. This compound is generally found in grapes, pomegranates, strawberries, etc. This compound can act as an anti-cancer candidate by directly and selectively targeting the mitochondria, which can induce the apoptosis through mitochondria pathway. By increasing the ROS production, which finally ends in the cytochrome C and releases capsid 3 activation and apoptosis in cancerous cells. This one is the coumarin compound. This compound can inhibit the growth, proliferation, and metastasis of the various tumor cells through a variety of mechanisms like inhibition of the carbonic anhydrase, PI3 kinase, AKT, mTOR signaling pathway, microtubule polymerization, angiogenesis, monocarboxylate transporter, then hypoxia inducible factor 1. It also acts on apoptosis proteins and inhibits tumor multidrug resistance regulation of the reactive oxygen species. Further polyphenolic compound is tannic acid. It is also effective phytochemical. This is generally found in grape, cranberries, strawberries, blueberries, apples, apricot, etc. This tannic acid inhibits cell proliferation by inhibiting the Wnt beta-catenin and pathway and promotes the trial-induced apoptosis through the ROS induction in the cancer cells. Further phytochemical is the isothiocyanate. This compound exerts their anti-tumor activities through various mechanisms like modulation of the phase 1 and 2 enzymes, inhibition of the cell growth by causing cell cycle arrest and inducing the cell death. Also, it prevents the metastasis and angiogenesis and regulation of the epigenetic machinery. Next one is the epigallocatechin 3-gallate. It is generally present in green tea or black tea and cranberries, strawberries, etc. This compound reduces oxidative stress by down-regulating the reactive oxygen species, inflammatory factors, and several kinases, and targets different growth factors which abate the tumor growth progression. Also, it upregulates the apoptosis factor to reduce the oxidative stress. Next one is the sulforaphane. Then this compound enters into the cell and inhibits the PI3 kinase, then AKT mTOR signaling pathway, which enhances the activity of the phase 2 detoxifying enzymes. And also it traps the free radicals. And finally, it induces the apoptosis of tumor cell and also leads to downstream anti-inflammatory effects. Next phytochemical is anthocyanin, which is a flavonoid pigment. It is generally found in all type of colorful fruits or vegetables. So this compound inhibits the MAP kinase and mitochondria associated pathways capsis 378 to induce the apoptosis. It also shows inhibition of the cyclin B by acting on the P51 and P21 signaling pathway to induce the cell cycle arrest. This compound also acts through the NFKB signaling pathway to mediate the anti-inflammatory function. Now, next compound is silibinin. It is generally exhibited a decrease in mitochondrial function and releases cytochrome C. It carries an inhibition of the apoptosis and causes upregulation in the P21, P27 and P18, leading to the cell cycle arrest. Besides, it induces autophagy by upregulation of the BAX, BEAM and BACLIN-1. The next phytochemical is lycopene. It is generally induces factors leading to the anti-initiation and anti-progression by down-regulating the MMP9 expression. It mediates the anti-promotion effect by suppressing RAS, then MAP kinase, etc., and inflammatory cascades. Basically, tomato and other red fruits, also red carrots, watermelon, grapefruits, papaya are the rich source of this compound. And last phytochemical is curcumin. We all are aware of this compound. So this compound regulates not only the various pathway of immune system, cell cycle checkpoints, apoptosis and antioxidant response, but also numerous intracellular targets, including the pathway and protein molecule, controlling the tumor progression. Here you could see different dietary sources of the chemopreventive chemicals and their functional properties, which are not mentioned in this presentation. Now let us move towards the most important part of this presentation, that is controversies, limitation and future perspectives. So there is a controversy related to possible toxicity of the phytochemical to the animal or human system at certain situations with respect to drug-drug interaction and concentrations due to their synergistic effects when consumed as a whole or rather than a single extracted compound. Besides, the limitations like low solubility, bioavailability also impede their application as anti-cancer drugs. In spite of these controversies and limitations, it has been observed that in most of the clinical studies, presence of the methodological flaws, including lack of control of placebo group, small sample sizes, and short durations were the lacunae. So in this context, understanding of these compounds related to their solubility, bioavailability, pharmacological effects are essential with respect to druggability and their transition from benchtop to patient's bedside. Also, strategies such as chemical modification to reduce the toxicity and nano-based formulation to improve their solubility and bioavailability could be helpful to overcome such limitations. In addition to this, large-scale, well-controlled clinical trials should be carried out to validate the efficacy and toxicity before their use as anti-cancer drugs. Also, to resolve these controversies with respect to certain epidemiological or clinical studies, meticulous preclinical investigation should be further carried out. In-depth metabolic study of the phytochemical should be carried out to identify the biomarker in readily available fluids and tissues. Also differentiate the responder and non-responders in clinical and epidemiological studies. The potent phytochemicals should be characterized with respect to their effect on the gene, protein expression, modulation of their activity in light of the nutrigenetic effect. Further, tailored studies should be performed for better understanding of the specific role of phytochemicals with respect to specific cancer therapy for prevention of specific tumor type. And the phytochemical compound should undergo same analysis which is used for drug development to determine their pharmacokinetic, pharmacodynamic profile as well as to confirm the putative interactions with the other molecules. And research with respect to improvement of the bioavailability using delivery system like liposomal formulations, nanoparticles, then microemulsions, polymeric implantable devices should be carried out. So we can conclude that the phytochemicals have significant potential to block, suppress, postpone, stop, or reverse the carcinogenesis. Use of phytochemical supplements in the target population and patient constitute promising tool for management of the cancer chemoprevention and treatment. Also, several phytochemicals synergize with the anti-cancer molecule and radiotherapy. Therefore, appropriate combination of therapy will potentially lead to reduce the side effects without modifying or even increasing the chemotherapeutic effect. More efforts into the phytochemical research involving optimizing the doses then target of phytochemical could yield not only their beneficial effects in normal cell but also damaging effects in the cancerous cell. So in upcoming era, cancer research with respect to dietary phytochemical will endure as a promising active research area. Phytochemicals are efficient and cost-effective cancer chemopreventive agents. Also, the nutraceutical produced by use of such phytochemicals could be served as a functional supplement for cancer prevention. The novel approach with respect to cancer chemoprevention therapy, along with the natural product chemistry, will help to harvest full potential of phytochemicals as a chemopreventive agent. And regular intake of phytochemical-rich precision diet will promisingly support the chemotherapeutic targeting of the cancer cell and cancer chemoprevention. So, although the additional clinical studies propose to develop phytochemical as an anti-cancer drug, daily consumption of almost all kind of dietary phytochemical in our diet will be the promising, safe and efficient way of cancer chemoprevention. Here are some key references. So, we are grateful to the organizer, speaker and participant of this conference for giving me this opportunity. I am thankful to Research and Development Department of Sigma Wineries Private Limited, Nasik, and Medical Oncology Molecular Laboratory of Tata Memorial Hospital, Mumbai. Thank you, sir. Thank you.
Any questions? Any questions to Dr. Anita? Just if you have any questions, you can ask through chat box. Even after the completion of the conference, we will be asking you. I think no questions, madam.
Thank you.
Yes. Thank you very much, madam, for speaking up in this meeting and providing you new perspective. Thanks for sharing your tips with us. Also, on behalf of Virtual Conference on Cancer Science, on behalf of our organizing committee members, we want to thank you for inside presentation. Looking forward to meeting again next time in physical event if everything goes well in 2022, either in Dubai or in Europe.
Yes. Thank you.
Yes. Yes, according to the program, Dr. Shireen, Dr. Udriston, Dr. A.C. Matin, Ms. Aishwarya, Dr. Rafil, Dr. Jungbi, Dr. Yuto Hali, Dr. Ganeshan, Dr. Narita, as well as Professor Zialani supposed to give their talk. So meanwhile, just we have short 10-minute break and we'll be reviewing the program again. It's 5:20 according to IST timings. We'll be joining by 5:30, by 5:31 according to IST Indian Standard Timings. Thank you. Just 10 minutes break we will have.
Hello?
Yes, madam.
Hello?
Yes, madam. If you are okay with your PPT, so
Hello?
yes, yes.
I couldn't hear anybody.
Yes, madam.
Um,
If you are okay with your PowerPoint, you can start.
I couldn't hear the voice.
Hello.
Can you hear me?
Yes, I can hear your voice.
Maybe some problem with the voice. Just 1 minute.
Yes.
Can you hear me now?
Yes, I can hear your voice.
Okay. At what time I will start?
Yes, if you are ready with your PPT, you can start presenting.
Okay. But how could I share the screen? It is disabled.
Just on what name you are going to share your screen? Please let me
On
know.
desktop. On my desktop.
Yes, you can start.
Can you see my presentation?
Not yet, not yet.
Okay.
We have a lot of time, madam. No need to. Just you can take your own time.
Can you see now?
No, not yet.
Okay. I'm not sure why I couldn't share the screen.
Yes, shall we play from your side? I have.
Is it okay now?
Yeah, it's going to start.
Can you see my screen?
Yes, it's fine.
Okay. Can I start now the presentation?
Yes.
Thank you very much. Hello, everybody. My name is Ruqayya Zilani. I'm Associate Doctorate at the University of Jordan. Today, I will present on behalf of my master student, Hibatullah Khader. She's one of my master students at palliative care nursing. The name of my presentation, Anxiety and Depression Among Patients with Cancer Confirmed with COVID-19, a comparative study. This study, this study conducted in north middle of Jordan. In a brief, Jordan, one of the small country located in the Middle East and bordered by Syria, Palestine, Saudi Arabia, and Iraq. As an introduction, COVID-19 pandemic is an impacting individual around the globe. By the 30th of October 2020, around 44 million confirmed cases of COVID-19. Number of cases increased significantly during this year, and still there is a new version of COVID-19 pandemic. Nowadays, the prevalence of COVID-19 cases more than 72 million. For cancer patients, cancer is the second cause of death globally, and since 2 million of new cancer cases were confirmed in 2020, more than 600,000 death causes has been reported. The high death rate could increase the risk of mental health, additionally impair their mental and physical status, which can adversely affect the patient's health status. A significant number of patients with COVID-19 show symptoms of psychological problems such as depression and anxiety. Our problem statement is that patients with cancer are highly being infected with COVID-19. Some of the reasons for this is the immunosuppression state that they have, which increase the risk of getting infected compared with the general population. A significant increase in the infected cases by COVID-19 among oncology patients worldwide and in Jordan. COVID-19 crisis increased the risk of death from infection among patients and among oncology patients in particular. Studies explore the psychological impact of anxiety and depression among general population or patients in general health found that oncology patients are vulnerable and they are more susceptible to get COVID-19 infection. In Jordan, only one study assessed the mental health status of the public healthcare professionals and the level of stress among university students. There is no studies examine the stressful effect and the effect of COVID-19 on oncology patients in Jordan. The significance of the study, developing psychological interventions in order to enhance the studying the psychological impact of anxiety and depression during COVID-19 for oncology patients is a necessity. Early identification of psychological disorders such as anxiety and depression makes an intervention strategies more effective. This will help to eliminate some of the unknown psychological effect of the COVID-19 among Jordanian and globally. No studies investigate psychological constructs such as depression and anxiety among oncology patients. The purpose of this study is to assess the level of anxiety and the level of depression among patients with cancer confirmed with COVID-19 in comparison to patients with cancer not being confirmed with COVID-19. So what we do, we divided the patients in two groups. The first group, they confirmed diagnosed with cancer and they had infected with COVID-19. And the other group, they had a confirmed diagnosed with cancer, but they did not have any infection or they don't have any positive COVID-19 infection. So the questions are, what is the level of anxiety and level of depression among patients with cancer confirmed with COVID-19 and those who are not confirmed with COVID-19? Is there a difference in the level of anxiety and the level of depression among patients with cancer confirmed with COVID-19 and those with not confirmed with COVID-19? In relation to health-related factors, personal factors, and demographic data, is there a difference in the level of anxiety and the level of depression among patients with cancer confirmed with COVID-19 and those not confirmed with COVID-19? We did a comprehensive review of literature related to COVID-19 pandemic, patients with cancer and the COVID-19, anxiety and depression, and we identify the gap in literature. Our design is a cross-sectional correlational design to identify anxiety and depression among patients with cancer confirmed with COVID-19 and those who are not confirmed with COVID-19. We use the two largest centers for oncology patients in Jordan. We have the Ministry of Health, which includes all of the patients registered through the National Registry Unit. And we have a specialized cancer center in Jordan called King Hussein Cancer Center, which is the biggest center in the Middle East. The population, patient diagnosed with cancer confirmed and not confirmed with COVID-19. The target population are Jordanian patients with cancer who were confirmed with COVID-19 and those who are not confirmed with COVID-19. The accessible population, all the Jordanian patients with cancer who are registered in the specialized cancer unit or in the registry office and the ministry at the Ministry of Health. The sample size during the data collection were 204 patients with cancer, and the population recruited from the selected setting by using random selection computer-based sampling technique. The inclusion criteria for the patients should be aged above 18 years, diagnosed with cancer and confirm the diagnosis. In order to make a comparison, we just used we took only the patients with breast cancer, prostate cancer, and lung cancer. The reason why we choose this client group is that because breast, lung, and prostate and lung cancer are the most common cancer in Jordan, and the percentage of these three more than 70%. Also, the patients should be able to read and write in Arabic language. The exclusion criteria were not comprehending or have mental illness, patients who did not do the COVID test to confirm the diagnosis, and any patient who has a history of anxiety and depression before the data collection. The instrument, we have three instruments: the demographic data, and that's the age, the sex, the social demographic characteristic, and the cancer diagnosis, the stage of cancer, and also the three types of cancer that we mentioned before. The second tool is the history of anxiety or depression, family history of anxiety or depression, personal protective equipment availability, and this was a valid and reliable tool. And the third one is the depression and anxiety stress scale, and this is valid and reliable scale. The pilot study, we chose 20 participants, and we checked the tool for the visibility, for the clarity, and we calculated the Cronbach alpha, which is 0.87 for the anxiety scale. The Cronbach alpha for the depression scale was 0.89. For the ethical consideration, we get approval from the University of Jordan and from the two centers, the largest centers in Jordan. We use the online questionnaire. The reason why we use the online questionnaire, because in Jordan at that the time of data collection, it was locked out, and nobody could move or go outside of the house during the pandemic, so we could not get access to any of the patients other than a telephone call or online questionnaire. We already mentioned the ethical consideration. The signing of the consent form was used we just send it through the WhatsApp, and the patients have to put the tick, then it will go through the sticking, which means that he agreed to participate. Also, the information were highly confidential, no names or data from the, 1 minute. No identification names were written, and the data kept in the researcher desktop locked with password protected. The data analysis, we have the research questions, the three research questions. We use the descriptive statistics for the general descriptive statistics and the demographic characteristics. We use the ANOVA and t-test to examine the difference in the level of anxiety and the level of depression among patients with cancer confirmed with COVID-19 and those not confirmed with COVID-19. And for the differences between the level of anxiety and the level of depression between the patient who confirmed COVID-19 and those who not confirmed, we use the t-test. For the results, the demographic characteristic of our result, more than half of the participants were females, about 52%. Most of the participants above 64 years old. The percentage of 45.6 were married patients. Half of the participants hold bachelor degree, 42.6. Half of the participants unemployed. Half of the participants were unemployed and reported an average monthly income between 201 JD to 499 JD, which considered low income. Most of the participants diagnosed with breast cancer, about 46.6, have medical insurance, 93.6, and were treated in governmental hospitals, 55.4%. The main findings, after the analysis, we found that the participants who were infected with COVID-19 exhibited higher level of anxiety and depression than those who did not infected with COVID-19. Patient with positive COVID had severe and extremely severely anxiety level, and these are really unexpected because we expect that patients with COVID-19 pandemic, they got a very special care, especially in the King Hussein Cancer Center. And they have severe to extremely severe anxiety during that time. Patients with positive COVID-19 female participants had lower scores of anxiety compared with male participants. Anxiety means scores significantly lower among patients with breast cancer than patients diagnosed with lung cancer and prostate cancer. Patients with negative COVID-19 with age 55 or older and those who are widow or widower have a significant level of depression. Those were not, there is no statistically significant differences in mean score between groups based on having infected relatives, death of the family member due to COVID-19, and receiving awareness about COVID-19. Patients who are infected with COVID-19 exhibited statistically significant higher anxiety levels compared to those who are not infected. Those who were infected with COVID-19 exhibited statistically significant higher depression level compared with those who are not infected. The implication of this study is that this study will provide a baseline data about the status of oncology patients during the COVID-19 pandemic. There should be a process to take action to reduce the potential unpleasant consequences of anxiety, depression among oncology patients. So it might be preparing policies that regulate patient screening or provide oncology patients with aids to assist psychological counseling during the COVID-19 pandemic. Psychological support and counseling is needed to all patients with cancer, mainly those who are infected with COVID-19. Patients with cancer require routine follow-up through phone calls or telemetry conferences to check their condition and encourage them to contact healthcare provider as needed. This also has implication to the education, provide awareness to the healthcare providers, especially nurses and doctors, about the appropriate screening and detection of anxiety, depression at early stage for oncology patients. Highlight the oncology patient characteristics that increase the risk of psychological disturbance, such as gender, age, marital status, health insurance, type of hospital, and losing family member due to COVID-19 infection. Recommendation: examine the impact of different psychological intervention on alleviating the level of anxiety and depression among oncology patients. Replicate the study using different approach. Conduct a qualitative research that help to understand the lived experience of oncology patients during COVID-19 pandemic. As a conclusion, we found that the prevalence of anxiety and depression among patients diagnosed with cancer in Jordan is highly alarming and need immediate action. Patients infected with COVID exhibited severe anxiety and depression level that those who are not infected. Important to maintain a comprehensive care for oncology patients, especially psychological support and counseling. The level of anxiety and depression were affected the patient's characteristic. Higher level were reported by males, older, widowed, and low-educated patients. Patients with lung and prostate cancer being without a health insurance, admission to governmental hospitals, losing a family member during COVID-19 infection also increased the level of anxiety and depression. The limitation of this study is that it used a self-reported questionnaire to access the anxiety and depression. So some of the patients, they did not fill the questionnaire. And also we used the online links because we could not access the patient face-to-face due to COVID locked out in Jordan. Thank you.
Yes. Any questions?
Any questions?
Yes, any questions to Dr. Professor Rukaya Zialani?
No questions?
I think there are any questions to Professor Rukaya Zialani? Just if you have any questions, you can ask through chat box. We'll be asking you in front of you, behalf of you.
Okay.
I think there is no questions, madam.
Thank you very much.
Yes.
Thank you for your help.
Yes, thank you very much for madam for speaking
Thank
at
you.
this meeting and providing a unique perspective. Thanks for sharing tips with us.
Thank you.
Yes, on behalf of organizing committee members of Virtual Cancer Summit 2021, we want to thank you for instant presentation. Looking forward to meet again next time in physical event if everything goes well in 2022.
Thank you very much.
Yes, yes.
Bye.
Have a nice day. Bye.
Thanks. Bye.
You want me actually to talk now?
So, are you?
Yeah, I'll be okay. I just went out for bathroom and came back. Saw your message. Shall I? If you have a gap, I can talk on the topic. If you want tomorrow also, I can extrapolate the work. Hello?
Just be online. Just I'll meet you. Just be online.
Yeah.
Actually, we are 40 minutes ahead of actual program.
40 minutes?
Just we are fast.
40 minutes talk you want?
No, sir. What I'm saying is just we are 40 minutes ahead of actual program. We are supposed to be 40 minutes late. 40 minutes late to our actual program. We are ahead. We are fast to our actual program. So we need to manage the time session. So we came to just now. We came to know Dr. Rafi. Yes, Dr. Utali, Department of Integrated Oncology, University Hospital from Bonn, Germany. Yes, madam, you can go ahead.
Yes, I want to share my screen.
Yes.
Wait a minute.
So we ask Dr. Lakshmipati, you can deliver your talk after this talk, sir.
Shall I deliver the talk or okay, after this talk you want me to deliver, I'll deliver.
Yes, sir. After this talk.
Okay, that's fine.
Yes. So, yes, madam. Go ahead.
Okay, can I start?
Yes, it's fine.
Yes, my name is Zitao Li. I come from Department Integrated Oncology, University Hospital Bonn, Germany. Today, I want to share my latest publication, which is PD-1 blockade enhances cytokine-induced killer cell mediate cytotoxicity in B cell non-Hodgkin lymphoma cell lines. Can you hear me? Sorry, can you hear me?
Yeah.
Yes.
Okay.
Yes.
Okay, I start. Okay. Firstly, I will introduce the lymphomas. Lymphomas are conventionally divided into two main groups: Hodgkin lymphoma (HL) and non-Hodgkin lymphoma (NHL). In non-Hodgkin lymphomas, which is classified according to the types of lymphocytes, involve B lymphomas and T lymphomas. Lymphocytes defines large B cell lymphoma, DLBCL, follicular lymphoma FL, and Burkitt lymphoma BL are common NHL types that are usually classified according to their aggressive or slowing growing characteristic. According to German Center for Cancer Registry data, CFDK, about 19,200 people in Germany were diagnosed with NHS in 2017, mostly in people of advanced age. That average woman is 72 years, men average is 7 years. Similarly, approximately 81,560 patients are expected to diagnose with NHL in the United States in 2020, according to data from Statistics Center of American Cancer Society. So, recent study using program cell death 1 PD-1 blockade have shown some promising outcome in phase 1 trials of B-cell non-Hodgkin lymphoma. PD-1 and its ligand PD-L1, PD-L2 have also been pronounced as diagnostic and prognostic determinant in lymphomas. This can be evident from immunohistory-based study where the variable expression of PD-L1 has been observed in classical Hodgkin lymphoma, which is a percentage of 87% to 100%. Diffuse large B-cell lymphoma was approximately 7% to 31%, while pocket lymphoma approximately 0%. Increasing the clinical utility of PD-1 blockade along or with combination therapy is currently gaining attention. And in this context, cytokine-induced killer cells, which is CIK cells, are emergency as new potential options. CIK cells is a heterogeneous subset of extra expanded T lymphomas. Exhibit cytotoxicity towards tumor cells, thus contribute to prolong the survival in cancer patients. The use of autologous and allogeneic CIK cells in clinical trials of acute myeloid leukemia, chronic myeloid leukemia, and chronic lymphomocytic leukemia had already demonstrated a promising clinical perspective. However, the cytotoxicity of CIK cells of non-Hodgkin lymphoma has not been fully excluded. And also, the efficiency of combination PD-1 blockage with CIK cells with non-Hodgkin lymphoma remains unclear. Therefore, we aim to investigate the cytotoxic potential of CIK cells in non-Hodgkin lymphoma cell lines and further elucidate the relative contribution to CIK-mediated anti-tumor immune response. So these slides, I want to show you how to generation CIK cells. I think it's, in this study, we use the healthy donor from PBMC. After we got PBMC, 24 hours infrared gamma stimulate, then next day we use IL-1/2, IL-1 beta, and anti-human CD3 to stimulate the 3 days. After 3 days, we change the media and continue use interleukin-2 stimulate until we got the mature CIK cells. These CIK cells consist of CD3 positive, CD4 positive cells, T cells, CD3 positive, CD56 positive T cells, and CD3 positive, CD8 positive T cells. I want to mention this CK cells were described by Goldschmidt-Wolf in 1991 at Stanford University, and the subpopulation of CD3, CD56 serves as main effector cells to lysis tumor cells. Its pathway may be from the LFA1, ICAM1 pathway, and O NKG2D receptor, and MICA-AB and ULBP family on tumor cells, which result in an upregulated secretion of porphyrin and Graze B. Additionally, CK cells also represented CD16, that's FAC gamma receptor. It might be the cytotoxicity. It might be ADCC led antibody media cytotoxicity contribute to the whole cytotoxicity. But it has been reported ADCC induced by anti-CD20 and rituximab contribute to the cytotoxicity of CK cells. Most of these anti-PD-1 antibody are IgG4 isotype with S228P mutation, which has similar effector combining properties as the natural IgG4 with reduced ADCC, but still retaining high affinity to Fc gamma 1 and binding to Fc gamma 2b. For instance, in the MC38 mouse model, Dahan exertal reported engagement Fc gamma reduce the anti-tumor antibody of an anti-PD-1 antibody by elimination of CD8 tumor infiltration lymphocytes via ADCC. So we are not sure now whether PD-1 inhibitor or PD-1 blockade or PD-L1 blockade contributes to the cytotoxicity of CK cells or inhibit this CK cells cytotoxicity. So this figure, since the CK cells therapy has been shown to be safe, there has been 17 clinical trials conducted for the treatment of lymphoma. I want to mention the first clinical trial on lymphoma was reported by Igor Schmidt-Wolf in 1999, where 10 patients, including 2 with FL, were enrolled. The study reported that interleukin-2 transfected autologous CK cells were detected in PBMC up to 2 weeks post-infusion. After significant increase in interferon gamma, GM-CSF, and TGF-beta was also detected in the serum of patients. In the terms of adverse effects, only grade 2 fever was observed in 3 patients during treatment, thereby demonstrating the safety and the clinical potential of CK cells immunotherapy. I want to explain 4 independent trials in 2011. Among them, Gore et al. Took the initial to induce 5,000 million CK cells per treatment, which was repeated every 3 to 6 months in the first year and every 6 months in the second year. Secondly, The patients show the measurable radiographic reduction in tumor size, and so PET-CT also improvement to the physical conditions. Considering that age is a risk factor for cancer treatment, Lu especially focus on elderly patients with DLBCL and observed that 2 patients was in complete response and 7 in partial response pre-treatment, while all patients achieved complete response post CIK cell infusion without any severe side effect. Also, for example, young etc. include elderly patients and confirm the feasibility of CIK cell therapy in older patients with HL and AHL. That's all. So my presentation divided 2 parts. One part is PD-1, PD-L1 profiles on CIK cells. This figure shows after 14 days in vitro expression, the majority of CIK cells had 3 subpopulations, that is CD3 positive CD8 phenotype with a percentage approximately 74%, and a subset of NKT cells with co-expression is of CD3 CD56 was approximately 78% in contrast to co-expression of CD3 and CD4 of 27%. I also want to show you the surface expression immune checkpoint PD-1 and CTLA-4 on CIK cells. From the flow cytometric analysis, it has been shown that the percentage of CD3 positive PD-1 on surface CIK cells was very low, approximately 3.9%, while CTLA-4 also very low, is approximately 1.3%. After 14 days expression, PD-L1, this figure show the phenotypes of PD-1 and PD-L1 CIK cells. Analysis show that the percentage of PD-1 positive, CD3, CD4 positive CIK cells increased significant after 14 days. However, no significant difference in CD3 positive, CD40, CD60, 56 positive, and CD3 positive, CD8 positive CIK cells compared to day 0. In contrast, the proportion of PD-L1 CIK cells also increase among 3 subpopulations. That's next step. Next slide. This figure show that nivolumab is PD-1 blockade harbors potential to block surface expression PD-1 on CIK cells. We examine the social age between the CIK cells activation and PD-1 surface expression in the presence nivolumab and found that PD-1 expression on surface of CD3 positive CIK cells decreased significantly after 48 hours compared to isotype IgG4 control. When counting the absolute number of PD-1 positive CIK cells, there was also a notable decrease in both PD-1 positive, CD3 positive CIK cells and PD-1 positive, CD3 positive, CD56 CIK cells after nivolumab treatment. Of note, PD-1 blockade treatment show no significant difference in intracellular PD-1 expression. Also, the assessment of mean fluorescence intensity, MI5, of surface expression of potential immune-associated marker, including PD-L1, PD-L2, CD21, CD28, CTLA4, GITR, on CD3 positive CIK cells show no alterations. Besides, PD-1 mRNA levels were not altered by nivolumab. This finding suggests that PD-1 blockade nivolumab blocks PD-1 on only surface surface of CIK cells. Interestingly, nivolumab also caused a significant increase in the level of CD4 positive, CD25 positive CIK cells expression FOXP3. So I want to summarize in this part. Firstly, nivolumab significantly weakened PD-1 surface expression on CIK cells without impacting other immune checkpoints or PD-1 mRNA expression. Additionally, nivolumab increased FOXP3 expression in CD4, CD25 subpopulation of CIK cells significantly. I want to introduce part 2. PD-1 blockade enhances cytokine-induced killer cell mediated cytotoxicity in B cell non-Hodgkin lymphoma cell lines. And firstly, we select the cell line is Dowdy is Burkitt lymphoma, and SU-DHL4 is diffuse large B cell lymphoma. And we generate CIK cells, as I mentioned before, and detecting PD-1, PD-L1, PD-L2 cell surface expression on tumor cells by flow cytometry. Additionally, evaluation of cytotoxicity of CIK cells to target tumor cells by cell viability assay CCK8, and then after that we use the blockade of PD-1 on CIK cells prior to co-culture with tumor cells, or block PD-L1 on tumor cells prior to culture with CIK cells, then with detection of cytokine secretion of interferon gamma by ELISA. We aim to investigate the cytotoxic potential of CIK cells in B non-Hodgkin lymph nodes and further elucidate the relative contribution of PD-1 and PD-L1 inhibitor towards CIK mediated anti-tumor immune response. This is our result. Firstly, basically, Dowdy and SU-DHL show a lower expression is PD-1, PD-L1 and PD-L2 below 10%. After co-culture with the CIK cells, approximately 24 hours, the ET ratio is 5:1, and the PD-L1 expression significantly increased compared to untreated tumor cells. Let me explain the ET ratio is the effector cells ratio to target cells. In this study, effector cells is immune cells is CIK cells. target cells is tumor cells. So next figure, it has we determine the we determine the percentage of variable cells and varying target cell to effector cell ratios, that is 0 to 0.1 to 1, 1 to 1, and 3 to 1 by using MTT assay. We found that Dowdy cells were more vulnerable, compared to SU-DHL4. Notably, and ratio 1 to 1, the variability of Dowdy cells were found to be reduced by 35% compared to positive control, while it was decreased severely by 40% in case of SU-DHL. So I think SU-DHL4 is more sensitive than Dowdy when encounter CIK cells. So next slide. We want to investigate the amount of antibody that could effectively block PD-1 and PD-L1. We perform the series titrations with them and examine the cell variability using CCK8 assay. Use the 5 microgram per millimeter PD-L1 antibody significant decrease the cell variability approximately 60% compared to positive control in Dowdy cells, and 12 microgram millimeter PD-1 was required to achieve the comparable results. Next slides also show that the cell variability in both cell lines, Dowdy and SU-DHL4, was severely impacted when co-culture with PD-1 blockade activated CIK cells. For instance, the concentration of 12 microgram per millimeter PD-1 antibody led to a significant decrease in cell variability in Dowdy, approximately 38%, and SU-DHL4 approximately 50% cells. To mention, no significant difference was observed after treatment with PD-L1 and CD40L antibodies. However, it can't be excluded that high concentration of CD40L may exert severe cytotoxic effects. The next step, we detect the secretion of interferon gamma. To evaluate the efficiency of PD-1 and PD-L1 blockade, we perform interferon gamma ELISA assay and observe the significant increase in interferon gamma secretion in both cell lines, treated with CIK cell alone and with PD-1 antibody. In contrast, this tendency was not observed for PD-L1. Similarly, we also detect the effects of CD40L blockade, and there was no only significant change. So in conclusion, our in vitro data suggests that CIK cells can exert the significant cytotoxic function against the B non-Hodgkin lymphoma, and the combination of PD-1 inhibitor with CIK cells may provide a potential therapeutic option for this particular lymphoma. This is my research about chronic myeloid leukemia, for example, K562. Also, when the basic expression of PD-L1, PD-L2, and PD-1 is very low. When co-culture with CIK cells, the PD-L1 significant increase compared to basic level. This result is very interesting because without immune cells like CIK cells, when I adding blockade nivolumab, PD-1 blockade nivolumab, and PD-L1 blockade durvalumab, the result is different. Because I use the proliferation marker Ki67 marker tumor cells. After 48 hours, proliferation increase after use the PD-1 blockade nivolumab. Well, there was no increase after using PD-L1 blockade durvalumab. That may be suggest that in the absence of immune cells, nivolumab might proliferate some tumor cells. Then in previous publication, tumor cells divided two parts. One part is, for example, nivolumab liver and bladder cancer. This kind of cells have different response to nivolumab because when adding nivolumab, intrinsic PD-1 signaling has been shown to promote tumorigenesis in nivolumab liver and bladder cancer cells, where in lung cancer and colorectal cancer, intrinsic PD-1 signaling in this kind of cancer has been shown to inhibit tumorigenesis. So this animal model also supports tumor cell intrinsic PD-1 receptor is a tumor suppressor in non-small cell lung cancer. Yes, I can finish. Thank you.
Yes, ma'am. This was a presentation from Dr. Utali. Any questions to Dr. Utali? Any questions? Just if you have any questions, you can text on in chat box. We'll be asking behalf of you, even after the completion of the conference. Any questions? Yes, madam. I think there is no question from the participants. Yes, thank you very much, madam, for joining us. Thank you so much for speaking on this event. Thanks for sharing tips with us. On behalf of organizing committee of Virtual Conference 2021, we want to thank you for your presentation. Looking forward to meeting next time. Next, we ask Miss Aishwarya, the postgraduate resident of Kidvi Memorial Institute of Oncology from Bengaluru, India. The topic will be predictors of distant metastasis in acidic cell carcinoma of salivary gland. Yes, madam, we asked to start your sharing of a slide. Yes, madam. Start sharing your slide. Are you ready? Hello. Do you hear my voice, madam? Please start sharing your slide. Please start sliding your slide. We asked Dr. for Miss Aishwarya. So, is Dr. Ganesh is ready with your PPT?
So shall I share my PPT? Ramakrishnan sir?
Just be online, son. Just be online. Yes,
Yeah.
Miss Aishwarya is. I think she is having some technical problem. She is going to adjust. Yes, Miss Aishwarya, we ask you to start sharing your slide, PPT.
Let the next speaker come in till she corrects her technical problems.
Yes, I think so. So, meanwhile, we ask Dr. Ganeshan Sivamani, the assistant professor and PG research department from zoology and biotechnology, Viraya Vadayar Memorial Sri Pushpam College from India. The topic will be targeting breast cancer stem cells. Yes, go ahead, sir.
Yeah. So slide is visible to all?
Yes, sir. It's fine.
Yeah. Very good evening to all. So my name is Dr. Ganeshan. I'm an assistant professor in the Department of Zoology and Biotechnology from India. The title entitled the targeting breast cancer stem cells through EPCAM targeted therapy along with chemotherapy promote better progression in breast cancer. Breast cancer is the most common cancer, representing closely 25% of all cancer. According to the Indian Council of Medical Research and the National Center of Dialysis Informatics, a report published in August 2020, the total cancer causes estimated to be 13.9 lakhs in 2020. Maybe it rise to 15.7 lakhs by 2025. The breast cancer is expected to be the most common worldwide. A study estimated that in 2020, in the developing country, the incidence rate of the breast cancer will be 1.7 million and 70% of the breast cancer mortality will occur. So this is a structure of the cancer has spread far away from the lymph node. The most common site of the bones, lungs, liver, and brain. So there are various treatment options are available here. So now we are going to see one by one the treatment options. Reason for failure: the cancer stem cells are the main reason. So the treatment is surgery, chemotherapy, radiotherapy, hormonal therapy, immunotherapy, and T-cell therapy. So this is a systematic diagram of the cancer stem cells role in tumor recurrence and chemoresistance. So now the cancer stem cells play important role in the gene therapy. So here the CSC stands for cancer stem cells. It targeted the cancer therapy, and another way the traditional cancer therapy. So here we are in the traditional cancer therapy, the drug that kill only the tumor cells, but not in the cancer stem cells. So tumors again it's going to regenerate. But in the targeted cancer therapy, the drug that kill tumor stem cells, the tumor lost the ability to generate the new cells, and finally the tumor degenerate is occurs. The chemo for the early stage of the breast cancer, The chemotherapy can be given before surgery or non-surgery. Surgical is a neoadjuvant, and after surgery there is a adjuvant. See, some of the drug molecules are involving in this EPCAM targeted therapy, anthracyclines such as the doctorubin and epidine, traraxan such as the facilital and these are the various drug or inhibitors mainly involving the EPCAM targeting research studies. The chemo of the metastatic conditions. Here, so we're mentioning the various inhibitors related to the EPCAM targeting, but here my study is cisplatin. Cisplatin is a major common drug which is available for the cancer treatment. It is mostly most of the in Indian Indian scenario, most of the oncologists are recommending this kind of drug. The conventional chemotherapy fails to eradicate tumor completely in many cases because of the small population within the tumor called cancer stem cells. There are strong evidences to support that these cancer stem cells are involved in chemo and radio resistance through various mechanisms like overexpression of ATP binding cassette and ABC transporters. It is also increased in KLH activities. It also enhanced the DNA repair mechanisms. The reformed reactive oxygen species is challenging the cell death escape. I mean the apoptotic markers like the cell death escapes, detection of the dormancy and the artifacts. So the targeting cancer stem cells by combining inhibitor along with conventional chemotherapy would be the better choice to eradicate the tumor completely. So here I'm putting the small hypothesis of the scholar work. See, if conventional chemotherapy fails to eradicate tumor completely in the case of the small population within the tumor called cancer, there are strong evidences to support that these cancer stem cells are involved in the chemo-resistant and radio-resistant through various mechanisms like the ABC transporter or ABC efflux and the ALDLG vectors. So this is a study design. See the combinatorial approach to identify the factors involved in chemo-resistant and tumor relapse, and followed by screening of the chemo-resistant cells, and then studying the cancer stem cells associated signaling pathway, and then targeting cancer stem cells through EPCAM specific target, and the EPCAM targeting inhibitors like XAV939 and sRNA like EPCAM. EPCAM is nothing but epithelial cell adhesion molecule. The approach is the tumor's growth by using the combination therapy, then chemotherapy plus cancer stem cell targeted therapy, and finally assessing the tumor relapse property, and final touch with bioinformatics tools like in silico approach or in silico model. So already mentioned it. That understanding the mechanism of drug resistant via through phenotypic approach. So first of all, we are going to standardize the generation of the optimal culture condition to study the drug efficacy, like optimization of culture condition, then followed by drug resistant assay, then screening of which anti-cancer reagent promote the cancer stem cell population. With the help of flow cytometry and the colony forming assay, we confirm it whether the cells is going to act as a anti-cancer reagent property or like. Then identify the factors that involved in the drug resistance. The transcription factors as cancer stem cell markers involved in liver cancer or some other breast cancer or like some associated oncological things. The cancer stem cells associated signaling pathway in liver cancer in chemo-resistant. This is a morphological analysis. So here we are choosing the one type of the liver cancer stem cells here. This is a hepatocellular carcinoma. These are control things. It is some of the drug like so 3 different drugs we are using here. Facilitox, 5-FU and cisplatin. So compared to the facilitol and 5-FU, the cisplatin is maximum the cell death observed in all 3 drug treatment. It's compared than the control, even small population remains live in the cisplatin treatment cells. So, okay, this is results confirming that all the chemo drugs were promoting the cancer stem cells in some level, but the cisplatin treatments promote the higher level. So compared to the 5-FU or palcitol or EOS, the cisplatin is a higher level of the keeping the normal. Then spheroid formation, the spheroid formation, otherwise known as the chondrogenic assay. So this is a different, so here compared to the control subject, the cisplatin treated cells having the more number of the clumping, I mean the spheroid formation. So the hemoresistant and the cancer stem cell property where we confirm it, the spheroid formation assay. There is no spheroid information in non-drug treatment, the cells, whereas other pre-treatment cells form the spheroid, especially the cisplatin pre-treated cells, a well-differentiated spheroid observed. So this is another important interesting result here, the beta galactosidase assay. So here the green color to indicating the the cisplatin treated cells took more beta galactosidase staining compared to the control subject. So the staining to indicate the cells is going to senescence state. The transcription factors as cancer stem cell markers involved in liver cancer and chemoresistance. So this ACT4 and non-ACT, there are the two different main genes involved in the hepatocellular research. And compared to the normal, so compared to the control subject, the ACT4 is, the treating condition of the ACT4 is significantly decreased. Is a cancer stem cells associated signal pathway in liver cancer. This is a systematic diagram of the EPCAM signaling pathway. So EPCAM positive cells are the key regulator of liver cancer stem cells and the chemoresistance. So the majority of the CD133 positive cells and express the EPCAM level. The data, the flow cytometric data to convince that EPCAM also one of the important marker in regulating the cancer stem cells. The EPCAM targeted therapy along with the chemotherapy or chemo drugs may be excellent choice to eradicate the tumor completely. So the conclusion of the first objective, all together, the liver cancer stem cells play a major role in chemoresistant in liver cancer. The targeting liver cancer stem cells through the EPCAM targeted therapy might be a better choice to eradicate the cancer stem cells population in liver cancer. So this is a paper we published in the Journal of Oncological Science in the year 2017. So here I am the corresponding author, and one of my scholars right now working at Bangalore, the Biocom. The EPCAM is a novel therapeutic target for hepatocellular carcinoma. So another journal, International Journal of the Pharmaceutical and Drug Analysis, we published the selected conventional chemotherapy promotes the cancer stem cells in liver cancer. So, okay, next hypothesis, we are going to follow certain another important techniques. I mean, methodology, the flow cytometry by Silla Education et al. Immunofluorescence, Western blot, 2D culture, spheroid formation, invention assay, wind signaling by luciferase, gene silencing, viability assay, cytotoxicity assay, molecular clocking, chemosketch, and this reports. So these are the very high-end technology used for the second hypothesis. Some noise are coming. Yes. Yeah. Thank you.
So go ahead, sir.
Yeah. Thank you, sir.
So that's it, sir.
No, sir, it's coming, sir. Yeah. Now okay, sir. Now okay. Yeah, this is a culture methodology, the morphology of the epithelial culture property. This is an adherent cell type of the breast carcinoma. This is the first one, the low density of the culture mechanism, and it's a high density. This is the low density, the morphological culture property adherent at breast, the ER. So here the high density, the cells are, the overlapping cell to cell that is going to form a beta galactosidase related functioning. This drug, the chemical formula or chemical structure. So here the HS and carcinoma cell lines, we are going to treat in the different mechanism like ACD, the 4 different conditions. We are looking at the cells is going to clumping stage or tumorigenic assay like that. So 2D But here I'm putting the 2D and 3D structures. So, but right now, so most of the pharmaceutical sectors are focusing to the 2D. But right now, the current scenario in developing stage or developing countries are focusing to the 3D structure model, because the 2D is not recommended for the clinical trial. The clinical trial in the field of oncology, because the 3D is a highly suitable technique to find out whether which side or which drug is highly suitable to find out the type of the cancer, as well as how to eradicate the cancer cells. The cells were cultured in the RPMI 1640 medium. RPMI is the Rexall Park Memory Institute 1640 medium, supplemented with 10% of fetal bovine serum and 1% of penicillin and streptomycin at 37 degrees centigrade in 5% of CO2. The cells from passage number 4 to 5 passage were used throughout the experiment. For the 3D culture, the cyto, because now, right now the Invitrogen and other Corning and Sigma, they are ready to provide the 3D ready-made plate also available. The CytoSelect 96 well transformation assay kit is available in the cell biolabs. Was used after agar layer. The RPMI is the 1640 medium was placed on the top of the 3D culture, and the culture for the 6 to 8 days. After that, we are going to treat with the inhibitor cells XAB939, the 20 micromolar in DMSO was added to the cells. After 24 hours of the stabilization, then RPM medium was containing that inhibitors, then was replaced with every 40 hours. So the effect of the inhibitors into 2D and 3D culture. So for 2D culture, the cells were seeded in 6-well plate and the inhibitor was added after 24 hours. So for 3D cell culture, the mixture of the agar, the MCF7 cells were seeded into 96-well plates and the inhibitor was added after 24 hours. The medium was replaced every 48 hours and incubated for 2, 4, and 6 days. After incubation, the 3D agar cell layer was stabilized with the addition of the 50 microliter of agar solubilization solution, and cell proliferation was quantified using the dye and the fluorescence at 520 nanometer. It is measured by the apoptotic curve as well as the annexion 5, and the dead cell assay kit was used to analyze with the cell analyzer. So this is the systematic diagram. So here, so the viability assay, the MC breast cancer cell lines, we are going to check whether the viability assay, the lethal concentration effect in the colorimetric or spectrophotometric reading. So this is a flow cytometric analysis. Here the mammosphere formation in the third day, the formation is very minimal, and the 9th day, the mammosphere formation is level. So this is followed by the treatment of the flow cytometric markers like CD44 and FP TC CD424 is both are the markers of the epicams. And MC F epicam here highly expressed compared to the actin control. This housekeeping gene compared to the housekeeping gene, the expression of the protein epicam is highly significant. So immunofluorescence of the epicam localization. So here the control cells, it is very minimal. Then is the another cell lines control. It is treated with some drug molecules like the falciparum resistance. It is emitting the encapsulation of the cancer cells. So here, so the silencing of the epicam alters the expression of beta-catenin and the anti-apoptotic proteins. So here PCL2 is apoptotic marker, and beta-catenin is another marker of the oncological site, and then actin is a housekeeping gene. The compared to the housekeeping gene, the both PCL2 and beta-catenin expression was significantly increased in the control level compared to the treatment option. So this is the invention assay. So this is the migration we are going to find out. The DMOs is a control. So this is 0 hour, this is 12 hours. Without any silencing, the cells are migrated to, the cancer cells are, close it. And here compared to the control, say here silencing, epicam silencing part, the space, that scratching level is not able to close it, because the epicam is playing an important role to inhibit or to preventing the growth of the cancer cells. So here another interesting, the XAB939, the inhibitor to again to maintain the growth of the cancer cells. So IATP binding asset of the this protein expression plotting result. So compared to the control subject, so the expression of the XAV939 inhibitors expression level is significantly reduced compared to the CAP-PTH housekeeping gene. So this is a gene expression study. We are going to make it quantify the expression level. Then EPCAM and active. Active is housekeeping. Then EPCAM level is controlled, is highly expressed. Under treatment conditions, the level is very low. This is EPCAM negative image. This is a EPCAM positive image. Then the apoptotic markers like immunofluorescence. So here the various indicating the image to indicate the whether the cells are active or inactive. So here the three different the treatment options to clearly showing compared to the DMSO or control subject. The self-renewing property of the mammosphere in MSCF functions. The day one, the mammosphere formation is very minimal. Then day fifth is a single colony is going to form a very limboprosting nature. And the ninth day, the single colony is going to overlapping onto another one. The wind signaling activity, the immunosuppression signaling, the previous we are going to calculate. Then we are putting the graph right here. So this also BIST viability assay and LDH assay to find out the combination therapy of the low dose PTX with XAV continuums. Spiral formation, I already mentioned that they become promote the chemosensitivity to pulse of interest cancer cells by down-regulating the expression of PCL2. The prediction, validation, and the preparation of proteins receptor. So the X-ray crystal structure of beta-catenin downloaded from Swissport, the protein data bank. The protein 3D structure were prepared by Mastro docking tools. We are going to find out the catenin with the help of the bioinformatics tools. We are going to confirm it. So the level of the incubation as well as the it also generated using the biomarker. So in silico findings, the interaction analysis revealed that all the small molecules used in this study had shown a preferential binding.
Excuse me, sir. Ask your kid to go. Just we are getting some small disturbance from your kids, sir.
Yeah.
Just we are getting somewhat disturbance from. Yes, you can go ahead.
Yeah. Now it's okay. Yes. Yeah. Any small molecules bind with glycine will be the crucial for the cancer treatment. So all the small molecules had shown a hydrogen walking interaction with arginine, trypsin, lysine, in various things. From the overall analysis, we might suggest that the hydrophobic interaction play a crucial role in the anti-cancer treatment. So of this, drugs rather than the curing cancer, it promotes the hemoresistant and the reference via treating the cancer stem cells, especially the facilitates the breast cancer carcinoma. The Wnt beta-catenin signaling is on the essential signaling pathway for breast carcinoma, the stem cell activation, invention, and proliferations. The XAV939 plus low dose palcitar significantly reduce the EPCAM expression. The EPCAM is the essential marker and the target to eradicate the breast cell carcinoma. The XAV939 is a promising small molecule inhibitor for CABR in combinatorial therapy and to avoid the metastasis. In the inhibitor plus the beta-catenin combination will impact the palcitar through the glycine and the to make it as inhibitions. The combinatorial approach of the epithelial cell attention molecule, the specific target through the inhibitor and the low dose palcitar is a better option to treat the breast cell carcinoma to avoid the relapse. So these are some of the publications related to our research. Okay. If you give time permit, I will show you another, take another 5 minutes.
Yes, sir, go ahead.
Yeah. So that's almost finished. So here, the absence of the tumor initiation property in Wnt beta catein targeted cells. Here, the control cells. You see the control cancer cells making a huge, to occupy the most of the cell plate. But here, in the Wnt targeted therapy, the cells are going to validate it. Some of the cells are going to inhibit. The proliferation rate is going to decrease. The reason behind Wnt targeted. Sir. Noise.
No, sir. Go ahead.
Yeah. So here, this another interesting scratch essay. This is reducing the tumor invention properties in EPCAM targeted therapy. So here, the control EPCAM silence and the Wnt targeted. So here, the 0 hours, 30 hours, 6 hours, 9 hours. So we can check it here. The 0 hours, the three slides. The 3 control cells. The space is very clear. But slowly, the time incubations or time consumed, the cells are migrated. Here, control, the cells are going to replace. But in EPCAM silence, the space present till the 9th hour. Then Wnt targeted again. So I mean here, compared to the Wnt, the EPCAM silencing is a better option to control the cancer. So the evaluation of the chemoresistant property in Wnt beta catein targeted cells is reduce the chemoresistant gene, the APC G2 expression in EPCAM targeted therapy. So here, see the normal cells, the HN RNA, and the inhibitor of the EPCAM and cisplatin. So compared to the cisplatin, so the two different, the inhibitors maximum to inhibit the cancer cell proliferations. The APC-G2 is a well-studied marker for chemoresistant, was statistically decreased in both EPCAM targeted therapy compared than in cisplatin targeted cells. So the beta catein BCL2 EPCAM protein expression was statistically decreased in XAV939 and silencing RNA treatment than control cells and cisplatin the pretreated cells. So reducing the expression of the cancer stem cells associated gene after treating the EPCAM targeted therapy. So control as well as the the treating of the two different concept. We are going to check whether the markers such as the CD138 and the EPCAM expression was decreased or not. So the conclusion of this another factors, the EPCAM gene silence and the inhibitor as was Wnt beta catein signaling pathway that result in decreased level of cancer stem cell marker CD138 and EPCAM, reduce the tumor initiation property, reduce the invention property, reduced colony formation properties, reduced one of the chemoresistant responsible gene APC-G2 expressions. So we are published in the paper in the International Journal of Pharmaceutics and Drug Analysis. The final approach to arrest tumor relapse in the liver cancer. So evaluate the absence of tumor relapse in combinatorial therapy, enhance the chemosensitivity in combinatorial therapy, studying the apoptotic cytotoxicity and the proliferation effect of the combinatorial therapy. Yes. So the most of the chemo drugs, rather than curing cancer, it is promote the chemo resistant and recurrence via triggering the cancer stem cells, especially cisplatin, those in the hepatocellular carcinoma. Wnt beta catein signaling is the essential signaling pathway for liver cancer stem cells activation, invention, and proliferation. EPCAM is the essential marker and the target to eradicate the hepatocellular carcinoma. And the combinatorial approach of EPCAM specific target along with the chemotherapy is better option to cure the hepatocellular carcinoma without any tumor relapse. Thank you.
Yes.
Well, the focus as well as actually the approach is the right approach.
Yeah.
There is a concept called simorphosis. This also applies to the cancer cells. As a child, all of us have benign tumors, and that will be going out in the form of pus cells. So any extra cell that is produced in benign tumors will die automatically. There is a regulatory system. But cancer cells evade that particular thing because of accumulation of this so-called stem cells, it is known. There are two questions in this thing. We know that, mTOR and also AMPK act in opposite direction. We still do not have proper answers as to how autophagy is able to target specific these things. But we know in stem cells, many of the receptor systems will be dying. And what are the specific receptors that are actually autophagged during this autophagy is one of the questions which needs to be addressed. I have been asking some of the students in Harvard University. One girl took it up, but halfway through she fell ill, and then her parents married her and then sent out. Second important question which I would like to ask you is, we are only concentrating on so-called genes and then, receptors and other things. Basically, it is the nutrient problem. And under that particular condition, you have actually anti-diabetic drugs like metformin, thiazolidinediones. Thiazolidinediones act at the pyruvate uptake at the mitochondrial pyruvate carrier level, whereas in this particular case, metformin is an inhibitor of monocarboxylate transporters. Supposing, you take actually instead of taking it at graded stage of actually your cell death is taking place, if you apply metformin, what would be the actually recurrence of the cancer? Can you do that thing?
I will try, sir.
Metformin controls actually lactate, which is actually a stimulator of oxidative metabolism. The concept that lactate is the product of glycolysis is an error created in 20th century. Okay? Warburg hyped it. So supposing, if you prevent actually, lactate shuttles, I believe. Yes. Brooks, Gladden, and also Savnix, etc., they have all a relapse of cancer cells because of actually much of the lactate that is circulated in the cells also. Supposing you target these monocarboxylate transporters, prevent the lactic acid uptake, then what would be the effect? Halfway through this thing, when you use cytotoxic drugs, at just half lethal point, apply metformin, examine what is happening. It's a suggestion.
Yeah. Okay. I will try to add these points in my further studies, because you are mentioning the very good. You are giving a very good idea. Because right now, one of my scholars doing the anti-diabetic related studies, but he's doing the rosiclutamide and metformin. But now I get the idea why we are not going to apply the metformin to the anti-cancer and other related stem cell related studies. I will try and I will get it.
Basically, it is the nutrient problem. It is the angiogenesis problem in the case of cancer and diabetes. The main difference between the two is angiogenesis is active in case of this thing, whereas angiogenesis is suppressed in case of diabetic patients. And in this angiogenesis system, ATP that is produced in the cytoplasm is exported outside through the exosomes, and it is there actually ATP is hydrolyzed. CD39 is coming into the picture, and that hydrolysis suppresses immunity, propagates it, but it also actually thrombus formation will be suppressed, angiogenesis will be activated. This particular enzyme, apirase, is actually downregulated in diabetes. That is the reason actually angiogenesis will not be taking place. Thrombus formation, platelet aggregation, and all other things will be taking place in these things. Basically, if you are targeting angiogenesis also, they are trying to do actually these cell receptor systems only. But if you target actually the lactate uptake, automatically there will be a regulation of actually the cell growth. Think about that. It's only a suggestion. I was examining
Thank
these.
you very much. Thank you.
I was examining these things for the past 10 years. So this is one approach which can help you.
Yeah.
Metformin per se will not be able to kill actually the total tumor cells, differentiated cells, but the EMT cells that can be arrested for further growth.
I will contact you, sir. I will contact you personally after this virtual conference. I will contact you, sir.
Yes, I'll be sharing the Dr. Lakshmipati's email ID through WhatsApp. Through chat box, sir. You can receive. You can have the information from him. Yes. Any further questions to Dr. Ganeshan?
It's okay. Yeah.
Any further questions?
Next speaker has come.
Yes, I would like to inform Dr. Ganeshan is attending our event since last 2 years, since 2019. This is the third event he is going to attend our conferences and encouraging this kind of scientific events during this pandemic period. Thank you very much, sir, for speaking up in this meeting.
Yeah, thank you, sir.
Yes, I am providing you the perspective. Thanks for sharing your tips with us. Also, on behalf of organizing committee members of Virtual Cancer 2021, we want to thank you for this presentation. Looking forward to meet again next time. Next, we ask Miss Aishwarya, postgraduate resident from Kidvi Memorial Institute of Oncology from Bengaluru, from India. The title will be the predictors of distant metastasis in clinic arsenic and sarcoma of salivary glands. Yes, madam, I want to inform you that we are going to share your PPT from our side. Sure. Just as soon as you complete the slide, just to mention the word slide change, will be changing from our side instead of confusing you from yourself and ourselves.
Yeah, sure.
Is it visible, madam?
Yeah, it is visible. Can I view it in a full screen? Like I'm not getting.
Yes, madam. Full screen, just.
Yeah, sure.
Just on the top of the screen, you will find view. Just to remove the view, madam. Just you can find.
Okay. Very good evening to everyone. My topic for today is today I'll be going to speak on predictors of distant metastasis in arsenic cell carcinoma of salivary gland. Firstly, I would like to introduce about myself. Second slide, please. I'm a junior resident doctor. I'm pursuing my PG in pathology in Kidvi Memorial Institute of Oncology. So why did we took up this topic is basically because we had seen that most of the cells, arsenic cell carcinoma, which were diagnosed in our hospital, had a poorer prognosis. So we wanted to know what were the predictors which led to the poorer prognosis in these cases. So coming next slide, please. Yeah, I'll be telling about this topic in the following headings. I'll be briefly telling about what is this arsenic cell carcinoma and current burden of the salivary gland neoplasm, that is globally, Asian, and then in India. and basic objectives of my study, then materials and methods, result, discussion, and conclusion. Coming to the introduction, next slide. Acidic cell carcinoma are rare, low-grade to intermediate-grade malignant epithelial neoplasm of the salivary gland. They show good curative rates, and they are low likelihood of distant metastasis. According to the literature, about 95% of the patients who are diagnosed with acidic cell carcinoma have good 5-year survival rate, but which was not seen in the cases which were reported in our hospital. High-grade transformation is rarely seen in this group of tumors. High-grade transformation has been increasingly reported in past 10 to 15 years and has been significantly related to distant metastasis. In the earlier literature, the tumor was referred to be as acidic cell adenoma. They thought this tumor to be a benign entity, but it is not true because these tumors can undergo dedifferentiation and high-grade transformation, and they can show lymph node metastasis, and they can recur locally. So the term was further made as acidic cell carcinoma. Distant metastasis is very rare in case of acidic cell carcinoma, which makes up only about 16%. Next slide, please. Current burden of the salivary gland neoplasm. It was Globocon 2020, which had divided the cancer. It has selected the top 30 cancer, and salivary gland tumors rank about 27, and it's 26th leading cause of death. The salivary gland, most of the salivary gland neoplasms are benign in nature. That is 80% of the salivary glands are benign. It is only 20% of the salivary gland neoplasm which are malignant. Next slide, please. So here you can see that the majority of cases, that is more than 50% of the cases, belong to the Asian age group, Asian population, that is 53.1%. The second is European. The mortality is also more in case of the Asian, that is 57.6%. So why this Asian predominance? Maybe because of the familial history, which is an important etiological factor for developing the salivary gland neoplasm, or it may be like it was seen that most of the patient, Hodgkin's lymphoma patient who were treated with ionizing radiations, developed acidic cell carcinoma in future. Next slide. In India, it is ranked as 27th cause of cancer, and there are about 7,850 cases of cancer registered in India. Most of the cancers, salivary gland neoplasm, are not registered. Why? Because they do not produce any symptoms, and most of them are benign in nature. Coming to the next slide. It was a WHO which took an initiative to classify the salivary gland neoplasm. The first classification of salivary gland neoplasm by WHO was done in the year of 1971, where only 10 entity in malignant epithelial neoplasm was found out. Later in the year of 1991, we had 33 different entities in the salivary gland neoplasm. And now, totally, we have around 37 entities. That is 2017, the fourth edition of the WHO is a recent edition of head and neck tumor. This is a recent edition, which says that there were 37 different types of a salivary gland neoplasm. We have to remember that the term secretory carcinoma is no longer belongs to acidic cell carcinoma. It is a separate entity. Why they had separated the secretory carcinoma from acidic cell carcinoma? The main reason was that it was similar to the breast secretory carcinoma and shared a common gene fusion, that is ETV6-NTRK3. So what was a new update in this WHO classification of salivary gland 2017? Next slide, please. Yeah. The secretory carcinoma was removed from acidic cell carcinoma, and it had become a separate entity. And there were a few simplified terminology introduced in salivary gland neoplasm, like polymorphous adenoma, clear cell carcinoma, intraductal carcinoma. And regrouping was done for adenocarcinoma not otherwise specified and poorly differentiated carcinoma. Next slide, please. Okay. So this is a basic histology of a salivary gland neoplasm, a salivary gland, where you have acinus, you have intercalated duct, you have striated duct, and excretory duct. From the region of acinus, we can get acidic cell carcinoma. From the region of intercalated duct, there are two tumors which can arise. One is acidic cell carcinoma. The second one is secretory carcinoma. From third, that is excretory duct, is the most important site for the development of mucoepidermoid tumors and adenocarcinomas. and salivary duct carcinomas. Next slide. So the basic objective of my study was to identify the primary tumor characteristic in acidic cell tumor that predispose a patient to develop distant metastasis. So how did we conduct the study? Materials and method. Next slide. A retrospective single institutional study was done. The study was conducted in Kidwai Memorial Institute of Oncology. The list of patients diagnosed with acidic cell carcinoma between the year 2014 to 20 were obtained. Clinical details of these patients were collected. The histopathological slides of this patient were reviewed and synaptic reporting was done. So, next slide. Any patient who comes with a salivary gland tumor to our institute, first we perform a fine needle aspiration cytology or a core biopsy is performed, following imaging study for the patient. Then, beyond the cytology, we divide the tumor as benign or low-grade malignancy or high-grade malignancy. Those tumors which are high-grade malignancy have to undergo a workup for metastasis, and they have to be completely resected with the lymph node dissection. High-grade malignancy are treated post-operatively with adjuvant radiation therapy and a chemotherapy. Now coming to the other part, those tumors which are diagnosed as benign or low-grade will be conservatively treated by surgery. Following surgery, if patients are diagnosed as benign on surgical pathology, they will be followed up for quite a few times. If they are diagnosed as low-grade malignancy with high risk, they will be given radiation and followed up. Next slide. So the synaptic reporting in our institute is done according to the CAP protocol, that is College of American Pathologists Accredited Protocol, which says that in any case of a salivary gland or any neoplasm of salivary gland, the following entities has to be noted. The first, name, age, gender, the various clinical feature with which the patient presented, and type of surgery which is performed on the patient, and the type of specimen received in the laboratory. The gross dimension of the specimen has to be taken in a fresh state, and high-grade transformation, lymph node metastasis, perineural invasion, margin status, and lymph node status had to be seen microscopically. And the post-operative radiotherapy has to be mentioned. Next slide. A total of 15 patients were studied. As I had already stated, that these groups of tumor are quite rare. They form about 5 to 6% of all the head and neck malignancy. So it's quite rare to find these tumors. So we got around 15 patients which were included in the study. Next slide. So the mean age of diagnosis was 52 years. Majority of the patients were between 51 to 60 years. The youngest patient was around 16 years of age, and the oldest was 72 years. Next slide. So majority of this tumor were located in the parotid gland. That is about 73% of this tumor were in the parotid gland. Rest other were in the minor salivary gland, which is situated in buccal mucosa, nasal septum, and glottis. Next slide. So type of surgeries which were performed, we received a total of 12 patients who had undergone a definitive surgery, which consisted of complete parotidectomy, that is total parotidectomy, 9 patients. Mandibulectomy was done in a single patient, laryngectomy in 1 patient, superficial parotidectomy was done in 1 patient, wide local excision in 1 patient, and biopsy was done in 2 patients. We had 12 patients who had undergone a definitive surgery with the negative margins and a lymph node dissection. Okay, here I would like to state that whenever a deep lobe of parotid is involved, a surgeon will prefer a total parotidectomy as a procedure. And involvement of a deep lobe of parotid is a sign of a worse prognosis. Next slide, please. So here are different parameters which we have seen. First is gender. About 53.3% of the patients were female. This acidic cell carcinoma shows a female preponderance. The clinical features were varying. Majority of the patient came with the complaint of swelling over the cheek. That is 80% of the patient had swelling over the cheek. Rest of the patient had varying complaint like a mouth ulcer, dysphagia, and pain in the angle of the mouth. Coming to the facial nerve palsy was seen in about 33% of the patient. Why this acidic cell carcinoma causes facial nerve palsy? Most of the time it is idiopathic. Sometimes it is by the growing tumor which can compress on the nerve. And third cause may be direct invasion of the tumor, direct invasion of a nerve by the tumor. There were about 47 patients who showed high-grade transformation, which was unusual for actinic cell carcinomas. And there were about 26 patients who showed lymph node metastasis. Next slide, please. The tumor staging was done for this patient. Majority of our patients were in the T2 stage. That is 6 patients were in the T2 stage. 5 patients were in the T1, 1 in T3, and 3 in T4 stage. This T-staging is done according to the AJCC 8th edition, which states that a tumor between 2 cm to 4 cm without extraparenchymal invasion comes in the stage T1. Tumor which is more than 4 cm but less than 6 cm is T2. Tumor which is less than 6 cm without the extraparenchymal invasion is T3. Tumor which shows the infiltration of overlying skin, underlying bone is T4A, and T4B is invasion of a tumor. That is, if the tumor invades the base of a skull or a pterygoid plate, it is given as T4. Next slide. Then the end staging was done. There were only 4 patients who showed the lymph node metastasis. 3 were in the N1 stage and 1 was in the N2 stage. Next slide. So this was a histopathological slide which we had reviewed. This belongs to one patient which just shows actinic cell carcinoma of salivary gland. This actinic cell carcinomas of a salivary gland are also called as blue dot tumors. You can see they appear more of blue in color. The blue is not because that they have an increased nuclear size. It is because of the zymogen granules which give a blue basophilic appearance. In the first slide, that is, I have shown a magnification in the 20x, which shows a tumor cells arranged in a lobules, the lobules separated by the fibrous gland. You can see that they have got some resemblance with a normal salivary gland. Yeah, but they differ from the normal salivary gland in the way that a normal salivary gland will be arranged in a grape-like cluster. And this is more diffuse type of a pattern you can see in slide 1. In the second slide, when you put it under the higher power, you can see here the individual cells have a well-demarcated cell border. They have a granular cytoplasm. Presence of a granular cytoplasm is a characteristic for actinic cell carcinoma. So here you can see the cells have a granular cytoplasm. When you see the nucleus, they are slightly eccentrically placed and they are condensed. Next slide, please. Yeah. This is a special stain which we have done on the case. That is, we are given a PAS stain. Most of these actinic cell carcinomas of a salivary gland are PAS positive. Here you can see that the zymogen granules have taken up the PAS stain, which appear more of pink magenta in color. So they are PAS positive, PAS with diastase also positive. A special test can be done, that is even immunohistochemistry can be performed in case of actinic cell carcinoma. Most of this actinic cell carcinoma are positive for DOG1, SOX10, they're CK positive. Now there is a new marker which has come up for the actinic cell carcinoma, that is NR4A3, which is the latest marker for actinic cell carcinoma. This NR4A3 will show a nuclear uptake. Next slide, please. Yeah, this slide is of more importance. This is a quite unusual thing which we had noticed when we had reviewed the slide. Here you can see in the slide 1, when I had focused in the 20x, this is high-grade differentiation in the actinic cell carcinoma. Here the tumor cells are arranged in a glandular pattern, which shows increase in the nuclear to cytoplasmic ratio. They contain scant cytoplasm and vesicular nucleus and prominent nuclei. And here you can see there is a stratified squamous epithelium, which is eroded by the tumor. There is infiltration of the overlying skin by the tumor. So they are given a stage as T4A. And in the second slide, this is a lymph node which is involved by the tumor arranged in the glandular pattern. This particular tumor has undergone a high-grade differentiation and it has involved the lymph node. Next slide. So this is a form of FNAC of a liver lesion. A 40-year female had come to us with a salivary gland neoplasm with a cheek swelling, for which she was operated and diagnosed as actinic cell carcinoma in the year 2018. After 1 year, we saw that the patient developed multiple mets at the different sites, liver, lung, and skeletal mets were seen. So we performed an FNAC from the liver mets, and these are the MGG stain smears which I'm displaying. So first in 20x, you can see that there are discohesive clusters of the neoplastic cells seen. When I focus it under the high power, you can notice that these individual cells are large. There are abundant amount of granular cytoplasm, slightly eccentrically placed nucleus with condensed chromatin. So this was diagnosed to be as a metastatic actinic cell carcinoma. It is quite unusual to see that within 1 year, the patient developed multiple mets. Next slide. So 4 patients showed high-grade transformation with lymph node metastasis. 2 patients with high-grade transformation showed recurrence of the tumor at the same site. 4 patients with high-grade transformation and lymph node metastasis succumbed to the disease due to the distant metastasis. Next slide. So coming to the discussion part, actinic cell carcinoma is viewed as low-grade neoplasm. As I'd already stated earlier, it was called as actinic cell adenoma. But in our case, we had seen them to show a high-grade differentiation. And they usually show a good curative rate. These tumors rarely metastasize. In our case, we saw 4 cases which showed distant metastasis. The tumor is most common in parotid gland, which was same in our case. We saw about 73% of the tumor had occurred in the parotid gland. And male to female ratio is 1:2. So we had also got more of a female patient when compared to male patient. And they are evenly distributed between second to sixth decade of life. It was the same for our study. The mean age of diagnosis of actinic cell carcinoma was 52 years, with majority of patients between 51 to 60 years. Only 16% of this group of tumors are known to show distant metastasis, but this distant metastasis was quite high when we noticed, and 35% are known to recur in the local site. So this actinic cell carcinoma have higher tendency to recur, metastasize, and may have an aggressive evolution. So a long-term follow-up is required for this patient following treatment. Coming to the conclusion, we concluded that the lymph node metastasis and high-grade transformation are the independent predictors of distant metastasis. Extensive sampling of a tumor and thorough examination of a tumor are the most important thing, and every pathologist to note to extensively sample the tumor when they are suspecting actinic cell carcinoma to look for this high-grade transformation areas. What were the limitations of a study? Some of the patients could not cover up the 5-year follow-up. So we would like to continue and see whether what will be their prognosis. IHC is required to differentiate between the high-grade transformation and dedifferentiation, which was not performed in our study. Next slide. So these are my references. Next slide. I'm going to conclude my seminar by one of the beautiful lines said by Mother Teresa. The biggest disease today is not leprosy or cancer or tuberculosis, but rather a feeling of being unwanted, uncared, and deserted by everybody. The greatest evil is lack of love and charity, the terrible difference towards one's neighbor who lives at the roadside, the victims of exploitation, corruption, poverty, and disease. And next slide. I thank Inovine Scientific Meeting for giving me an opportunity to present my work here. Thank you.
Yes. Any questions to Ms. Aishwarya? Any questions?
One question I would like to ask, is there any relationship between the oral microbes and the occurrence of this type of cancer?
Sir, as such, sir, most of this cancer, they have genetic predisposition, sir. Like it is seen in the family members. The second etiological factor is exposure to ionizing radiation, sir. As we've seen, most of this Hodgkin's lymphoma patient who are treated with ionizing radiation developed this kind of salivary gland neoplasm. And certain population who work in the wood industry are also more likely to get this tumor, sir. There is no study which state that actinic cell carcinoma could be caused by oral microbes.
Oh. I think that plays a critical role in case of oral cancer, heavily.
Yes.
Yeah, that is byproducts. What are the products that are produced by those microbes that need a survey at least?
Yes, sir.
Yes. Any questions further? Just if you have any questions, you can ask directly. We'll be asking through chat box also. You'll be getting from the chat box also. Yes, thank you very much, madam. Thank you for speaking up in this meeting and providing your perspective. Thanks for sharing tips with us. Also, on behalf of Virtual Cancer Summit 2021, our organized committee will be appreciating like we have those who are coming from background of this life sciences group. Next, we ask Dr. Rafael Silvia Torres, Department of Pharmacy, National School of Biological Sciences, National Polytechnic Institute from Mexico. The topic will be cytotoxic activity of fraction of Kalanchoe from diagnosia in A549 lung cancer cells. Yes, sir. As one of the keynote speaker for this conference, I would like to inform to you all. Yes, sir. Go ahead.
Thank you very much, Dr. Bruce. I come from Mexico and I work for National Polytechnic Institute. I am going to present you to a work cytotoxic activity from fraction of Kalanchoe dagemontiana in A549 cells, cancer cells. Yeah. Introductions. The chemistry of natural products is closely related to the isolation, biosynthesis, and elucidation of the structures of new chemical compounds that act as a powerful protective agents both for human and animals' health and for agricultural crops. It has been confirmed that the secondary metabolites, the chemical diversity, and varied activity against various diseases, natural products, and traditional medicine play an important role in agriculture and pharmaceutical research as Kalanchoe dagemontiana. Mexico is a country with a great biodiversity due to its variety of climates and topography. The different plants are used for different purposes, including medicinal ones, as well as they use it in clothing, fuel, or cultural needs. Kalanchoe dagemontiana. The genus Kalanchoe is a native to Madagascar and belongs to the Crassulaceae family, which comprises about 1 to 5 species. Through in Mexican territory, there are various species found in different parts of the country. This can be identified by a floral analysis. It has ganopetals, flowers, tetramers, and diplostomes. These are succulent than heterophilic plants, which adapt well to drought, so they develop well in regions where it does not freeze. Here is the photograph of Kalanchoe and Kalanchoe dagemontiana and flowers of Kalanchoe dagemontiana. Here you can find in Mexico, in the states of Veracruz, the state of Hidalgo, Guerrero, Oaxaca, and Chiapas. The Kalanchoe dagemontiana is distributed in some parts of Mexico, the country of Mexico. Uses of Kalanchoe dagemontiana in the world. Around the world, Kalanchoe dagemontiana is widely used within traditional medicine. Mainly, it has given application to treat a wide range of disease, such as infections, inflammatory, and cancerous. On the other hand, studies have been carried out in which it has been shown to be effective as anti-tumor, antihistaminic, and anti-inflammatory, and immunomodulatory, as well as cytotoxic or lymphoblastic or leukemia cells. Chemical compounds found in Kalanchoe dagemontiana. There are different chemical substances identified and isolated by researchers from Kalanchoe genus, which can be classified into flavonoids, glycosides, anthocyanins, coumarins, bufadienolides, triterpenes, esterols, phantrines, and fatty acids. Of the most studied metabolites are the bifenolides, which have been tested for their antitumor activities in different cells, such as A549 human lung cancer, colon tumor cells, human nasophagix carcinoma, and intracellular carcinoma, which has been reported inhibitory activity. This has been the bufadienolids has been published in several journals, and it has been studied several species of Kalanchoe. This is one of these chemical structures of Kalanchoe species. One of them is from Kalanchoe dagremontiana. In Mexico, 72% of cancer patients had malignant tumors in the lungs, according to GOVAC estimates. Lung cancer is the second most deadly for men, with 14% of deaths from malignant tumors, prostate cancer, according to the NEGI. Methodology. The crude extract of Kalanchoe dagremontiana was obtained for the purpose to know the chemical content. We made chemical tests. The ethanolic extract was further chromatographed on dry silica gel, column, and TLC chromatograph. Using as a mobile phase, methanol acetone fraction 1,5 was analyzed chemical and biological. Cell culture. MTT technique. The cells were cultured in fresh medium and counted by exclusion of trypan blue to seed is 5,000 cells per milliliter in 96 well plate incubated overnight. Subsequently, the cells were treated with ethanolic extract of Kalanchoe dagremontiana as a positive control. The cells were seeded with paclitaxel. Sorry. At the end of these times, the MTT technique, 4 milligrams per milliliter sigma, was added. It was allowed to incubate 3 hours. Once its time has passed, the supernadan is removed. Subsequently, the MSO, 100 milliliters, microliters was added, and the reading was made in ELISA detector at 570 nanometers. Then the viability was calculated. Results. It was obtained 70 grams of crude extract of Kalanchoe dagremontiana and was identified mainly flavonoids, coumarins, alkaloids, sesquiterpene lactones, and tannins. The flavonoids is by 2,4-hydrophenyl 5,7 dihydroxychromone. The identification of flavonoid was made using NMR techniques. The proton spectra was obtained. Here is the spectrum of the flavonoid isolated from the ethanolic extract of Kalanchoe dagremontiana using DMSO as a solvent, a 500 megahertz equipment. Here is the formula of the flavonoid isolated and purified of the fraction band to 1 to 5 from ethanolic extract of Kalanchoe dagremontiana. The results of activity on the viability of the cell shown at a concentration of 2 milligrams per milliliter, inducing a cytotoxic effect in a 459 cells line, presenting similar effect of drug paclitaxel, which is broadest spectrum anti-cancer compound. Here is the graph of percentage of viability MTT technique in A549 cells exposed at biochanin A in concentration from 1.125 to 2 milligrams per milliliter. Conclusions. In the ethanolyc stripe of Kalanchoe digremontiana, the following metabolites were identified: flavonoids, coumarins, alkaloids, sergiterpene lactones, and tannins. The flavonoids 2,4-hydroxyphenyl 5,7-hydroxychromone was isolated from the crude extract of Kalanchoe digremontiana. The flavonoids isolated of ethanolic extract of Kalanchoe digremontiana induces a cytotoxic effect in cell line A549, presenting a similar effect of the drug paclitaxel. Acknowledgements. I will give thanks for biological tests, Dr. Eva Ramón and Alfonso Sequeda Juárez. Chemical analysis, Dr. Francisco Díaz. Plant donation, Jesús Aurelio Martínez Godínez. Vivero Biznaga, Tulancingo Hidalgo. This project was supported by National Polytechnic Institute. Here are some bibliographic. And thank you very much for your attention.
Yes, sir. Yes, any questions? Any questions to Dr. Rafael Silva?
Could you find what is the target, specific target of this molecule in the enzymes?
Yes. Yes.
What was it?
Pardon?
What was the specific enzyme that was targeted by this particular flavonoid?
God, we can find the activity from a very low concentration to 2 milligrams per milliliter in comparison with the Taxol or paclitaxel.
Target was not identified. Specific target was not identified.
No, not yet. A specific target, not yet. We are going to continue the research.
Yeah.
With silico technique.
Flavonoid dependent SDH, what would be the effect of this thing, this particular compound? That is one lead we can think about.
Yes.
SDH is actually respiratory activating enzyme, and suppression of that thing automatically actually suppresses the carcinogenesis also.
Yet we don't know.
Yeah. That's one target which you can think about.
Yes, yes. You have good questions. But actually, we don't know.
Yeah. Thank you.
Yes. Any further questions to Dr. Rafael? Yes. Thank you very much, sir, for speaking.
Thank you, Dr. Bruce.
Yes.
Thank you.
Yes. In this meeting and providing you. Thanks for sharing your tips with us. Also, on behalf of organizing committee members of Virtual Cancer 2021, we want to thank you for instant presentation. Looking forward to meet again next time in physical event. Yes. Next, we ask. Actually, we do have more speakers for today's session. That will be Dr. Jongri, Dr.
Yes.
Sita Kushit.
Hi.
Yes, Dr. AC Martin, Dr. Aurelian. So, We asked Dr. Jongri, the Department of Radiation Oncology, School of Medicine, University of Mary, Baltimore from USA. The topic will be conformation of aerobic cells switching position with hypoxic cells within the valuable realm of multicellular spheroids. So, sir, we ask you to start with your presentation by sharing your slides.
Yes, I'm trying. Let's see, how can I do it? No, it's not the case. I'm sorry.
And I also like to inform to all that Jongri is one of the keynote speaker for this conference for day 1 of the session.
How can I share my trouble? I have a trouble.
Sir, you can bottom of the screen. Excuse me, sir. In bottom of the screen, you may find with green color share screen.
Okay. No, if so, our viewing screen will be shared. I have to bring my data up to. So let me see, how can I problems. I cannot bring my slide here. How can I do it?
Sir, do one thing, sir. You can share your PPT to us. I'll be sending you. I'll be sending you personally through chat box my email ID.
Okay.
Yes, my email ID as well as WhatsApp number. You can send to me. I'll be playing from here.
Okay, great. That's great.
Sir, as one more thing, sir. If you give permission, we'll go with alternate speaker.
Yes, that's fine. Thanks.
Yes, it's fine. So, we asked Dr. Aurelian from Tito Maisorescu University from Medicine Faculty from Romania. The title will be Mutated Status of the P53 Gene as a Unfavorable Market in Breast Cancer. Sir, Dr. Aurelian, if you are ready with your PPT, you can start sharing the slides, sir.
Yes.
Okay, slides. You go ahead, sir.
I am Dr. Aurelian Udăiștioiu. I speak from Romania. Dear college, I want to speak about mutant status of the P53 gene as unfavorable marker on breast cancer. Breast cancer affects more than 1 million patients annually in the world and is a leading cause of mortality. The prognosis of patients with localized breast cancer is determined by clinical and biological factors such as age at diagnosis, tumor size, nodule status, tumor histological grading, expression.
Excuse me, sir. We are unable to see your PPT on the screen. No slide sharing on the screen. Just start sharing.
Yes, I have a screen, and I can read. Treatment combines surgery on the primary tumor, radiation therapy on the breast, chemotherapy, and hormone therapy. P53 gene is mutated in about 30% of breast cancer. The possible links between alteration of P53 and clinical pathological feature of breast tumor have been widely investigated. The first study to examine gene expression pattern of breast cancer suggested that at least 4 major molecular class of breast cancer exist: luminal-like, basal-like, normal-like, and HER2 positive. Basal-like breast cancer account for 15% of breast cancer and are often described as triple negative breast cancer. In fact, triple negative breast cancer, defined by lack of estrogen receptor, progesterone receptor, and each ER2, probably include both basal-like breast cancer and some poorly differentiated luminal breast cancer. They are also associated with younger age and poor prognosis. Triple negative breast cancer also have an increased frequency of T53 gene mutation. Recently, it was shown that P53 status was a strongly unfavorable prognostic factor for relapse-free survival and overall survival only in the triple negative group in patients treated with adjuvant anthracycline containing chemotherapy. Inflammatory breast cancer is a clinical diagnosis known as T4D category in the TNM classification. It is a distinct clinical subtype of locally advanced breast cancer with a particularly aggressive behavior and poor prognosis. P53 mutation are most frequent in inflammatory breast cancer, 50%, than in non-inflammatory breast cancer in 20-30%. Interpretation of prognostic data is complicated by the fact that early studies only use immunochemistry to detect the accumulation of P53 protein. Breast tumors with positive immunostaining for P53 are usually estrogen and progesterone negative. This is often associated with the high rate of proliferation, high histological grade, aneuploidy, and poor prognosis. Specific germline mutation in hereditary breast ovarian cancer susceptibility genes BRCA1, BRCA2, and BALB2 have been shown in a retrospective study to recur in French Canadian of Quebec. Germline T53 mutation carrier are known to segregate in Li-Fraumeni syndrome families, which feature young age of onset breast cancer. In this retrospective study of T53 germline mutation provided from Hereditary Cancer Clinic and have investigated 37 new BRCA1 and BRCA2 T53 mutation. Level of P53 mutant gene among the sera of the studies group have been measured in units per milliliter using ELISA technique. The patient age range was 20 to 84 years, a mean age 31 years. Most of them were in the fourth decade. 21 patients, 41% were premenopausal, and 69% were postmenopausal. The study showed that demographical feature which indicates that the mean of age of the majority of patients were within or above post-menopause duration, 1%, which significant difference in comparison with control 29 years. And these results was compared to some extent with another Baghdad previous study. The mean value of P53 gene of malignant ELISA technique was 47 units per milliliter in comparison with the 27 units per milliliter for health control. The functions of P53 gene is altered in nearly 50% of total cancer disease. P53 gene being inactivated by mutation in the DNA binding domain or deletion of the carboxyl terminal domain. In other cases, loss of p53 gene function is related to another mechanism, such as interaction with viral proteins in lymphoma, hepatocellular carcinoma, multiplication of the suppression MDM2 gene in sarcomas, and deletion of P14ARF gene in breast or lung tumor. The P53 gene transcriptional activity is based on the formation of tetramers, dimers, or dimers of dimers. Some protein may interfere with wild type or P53 gene by forming hetero-oligodimers that are less competent for specific DNA binding. Has been shown that some missense mutation gain oncogenic properties. Similarly, methylation of the CDKN2A gene can epigenetical silence to expression of the P14ARF protein and block the ability of activated gene to stabilize P53 response. In experimental models, disrupting of MDM2 P53 gene proteins at the cytoplasmic level interaction restore P53 function in tumor to chemotherapy or radiotherapy. This strategy could be particularly beneficial in treating cancers that harbor P53 gene mutation. In this tumor type, the induction of P53 using a small molecule inhibitor of MDM2 as nutrient 3 can induce apoptosis in malignant cells. On the other hand, non-malignant cells seem to tolerate MDM2 inhibition, and no high-grade toxic effects have been observed in normal tissue. With the recent discovery of new specific MDM2 inhibitor that activate function P53 protein, is now possible to probe the P53 MDM2 response in different tumor setting. Nucleins are a group of cis-imidazole analogs that have a high binding potency and selective for MDM2 protein. Nuclein 3 displays P53 protein by competing for binding to MDM2 protein. In last study were shown that the nuclein 3 potency induced apoptosis and cell line derived from hematological malignancy, including acute myeloid leukemia, myeloma, acute lymphoblastic leukemia, and B-cell chronic lymphocytic leukemia. Nuclein induces cell cycle arrest in normal cells and is associated with minimal toxic effect in clinical study. Further, stabilization of modification form of P53 by nuclein 3, which inhibits the negative autoregulatory loop between MDM2 and P53, results in activation or other P53 dependent pro-apoptotic pathway. Restoration of endogenous P53 protein function by engineering technology, CRISPR-Cas9 13 gene editing with replace mutant amino acid alanine from structure of isoform protein P53 protein may induce apoptosis while cell growth is reduced. Thus, pharmacological reactivation of P53 is another cancer treatment option. An increasing number of studies has confirmed that microRNAs play an important role in development and progression of breast cancer. Nucleic acid microRNA 214, a member of the microRNA family, has been demonstrated to function as oncogen in various types of human cancer. Furthermore, P53 protein, which has been reported to be downregulated in breast cancer, was predicted to be the target gene of microRNA 214 using bioinformatics software program. Moreover, luciferase reporter vectors were constructed and was confirmed that P53 is a target of microRNA 214. Following the transfection with microRNA 214 in breast cancer cells, was found that overexpression of microRNA 214 markedly enhance the cell invasion through the downregulation of P53 expression. But contrast, the overexpression of P53 abrogated the effect of microRNA 214. In conclusion, this study was demonstrated that microRNA 214 function is an oncogene in breast cancer, at least partially by promoting cell invasion through downregulation of P53 gene. Antibody specific for P53 phosphorylated protein as 3 different sites within the activation domain were used in parallel analysis. A large number of patients with cancer produce P53 reactive T cells. Short time in vitro stimulation with P53 transfected dendritic cells shown that more than 40% of patients with breast cancer have P53 reactive CD4 and CD8 T cells in their peripheral blood. These responses occur most frequently in patients with high P53 protein expression in their tumor. The results serve as a justification for attempts to vaccinate patients using P53 derived peptides, and a number of clinical trials are in progress. However, the response may not be potent enough to result in clinical benefits as monotherapy, because most patients had T helper cells that failed to produce K cytokines for the destroyed malignant cells. Some studies suggested that P53 may influence response to antitumoral treatment. P53 mutation gene are less frequent in patients with estrogen positive breast cancer, but they are associated with a poor prognosis in these patients. In vitro study of human breast cancer cell line derived from a MCF7 line were shown that P53 mutated cells were more resistant to cytotoxic effect of 4-hydroxytamoxifen compared to 53 wild type cells. Clinical studies on patients with locally advanced breast cancer treated with tamoxifen or primary chemotherapy shown that mutation in P53 gene is associated with a poor survival. Conclusions. P53 gene status shows a strong prognosis impact, and this could be useful in choosing the best treatment for breast cancer. Discordant studies concerning its predictive value yet exist, and this is linked to a method of detection of TP53 gene status. Another different studies were shown that microbiological VACAI test and the sequencing of P53 gene by another method, polymerase chain reaction, single-stranded peptide microarray, next generation sequences, and the sandwich ELISA are better than immunohistochemistry to determine if TP53 gene is mutated or not. Perspective studies using this method could better determine the predictive values according to response to treatment. Thanks for your attention.
Yes, sir. Any questions? Yes. Any questions to Dr. Aurelian?
Thank you for your attention. Thank you.
I think no more questions, sir. Thank you very much, sir, for joining this event. On behalf of organizing committee members of Virtual Cancer Summit 2021, we want to thank you for inside presentation. Thank you.
Thank you, sir. Thank you.
Thank you very much for speaking up in this meeting and providing a new strategy. Looking
Great
forward to
pleasure.
meet. Yes, looking forward to meet again in next time. Have a nice day.
Thank you. The same. Thank you.
Yes, yes. So again, we ask Dr. Jongli, Department of Radiology Oncology, School of Medicine from University of
Yes.
Yes, sir. I'm going to share your PPT, sir. Just as soon as completion of your talk, just to mention the word slide change, I'll be changing from here.
Okay, yes, that's right. Okay, hi everybody, nice to see you. Let's say my topic today is a conformation of a cell migration, cell relocations within the viable rim of multicell spheroid. As you know that the multicell spheroid is good 3D models to test various therapeutics efficacies. So our hypothesis for this study is whether the location of cells within a spheroid system may not be confined to their point of origin over the course of their lifespan. I had these ideas 10 years ago, and I tried to publish it, but it's very difficult. So could you show me the next slide? Okay. The basic first, multicell spheroid. Are you seeing my pointer? No, you cannot see my pointer. Okay. You may see the pictures. It's a multispheroid, million cells growing in abundance. It has a cycling cells outer layer, an aerobic viable rim, of course, its outer layer, hypoxic cells inside, deep inside, where the acidic region as well. So it is very interesting 3D models to use this system to check whether the radio sensitivity, how that works and how they're related based on the aerobic versus hypoxia and the chemosensitivity as well, because it has a different cell population, aerobic and a neutral pH versus acidic pH inside. And then, of course, the hypothermia, heat sensitivity, because heat sensitivity, hypothermia is often combined with the radiotherapy and chemotherapy as well. Next slide, please. Next slide, please. Yes. Here, the RIF1 spheroid was stained with a viral dye, host 33342, for 1 hour or 6 hours, then frozen section 6 micron thick, and observed under an epifluorescence microscope. On your left, there is a shorter time, only the surface of the spheroid. On your left is the surface cells stained. And then when we stain the spheroid continuously for 6 hours, we can see the wider staining. And at the beginning of this experiment, I was excited whether this is the diffusion of the dye, vital dye, or whether it's the cell movement within the spheroid. Next slide, please. Yes, here, again, the same slide are the pictures. On the left is a shorter time, and the picture on the right for longer exposure, continuous exposure. But the right panel C is stained like A, and then, yes, and then incubated extra hours. So there was some decrease in the intensity, as well as its spread similarly without the continuous the exposure to the stain. Here, the bottom graphs, we analyzed the intensity at the depth of 8 to 100 micron versus as a function of staining or staining time. And there are several times repeated experiment plotted, and the solid curve is the best fit curve. And then the dotted line is 95% confidence limit. So it looks like there was about 6 hours or so, cell is moving around. That's what we thought. Could you give me the next slide, please? But our observation has been challenged as reflecting dye being released from stained cells. That's most challenging critics. So in order to overcome that kind of problem, this time, to ensure our observation for cell migration, we recently constructed an adenovirus, which has 3 embedded DNA sequence, GFP, green fluorescence protein, and the HRE, hypoxia response element, conjugated with an ER1 gene. Next slide, please. Here, it's not a RIF1 spheroid. It is a DU145 spheroid. The cell DU145 is cells divide very slowly, grow slowly. So we need a longer time to observation. So in this slide, the DU145 spheroid were infected with the new adenovirus, GFP and HRE, and the ER1 gene inserted for 2 hours, then incubated for X hours, and then observed the GFP expressing cells using a confocal microscope. So on your left, on your left, 8 hours after that, you see only the surface of the cell of the spheroid were positive to green fluorescence proteins. And then 16 hours after that, some of the cells move inside of the spheroid. Next slide, please. Here, 46 hours plus 2 initial infection, total 2 days after that, which is a slow growing cell line. You can see the aggregation first. On the surface, somewhere in the middle, aggregated, and then the cells in the middle or deeper region of a spheroid, fragmented. I was lucky enough to see on your right, lower right, there was some repositioning of unstained and stained cell crossing each other. It's interesting. So we can see the cells are moving in within the multicell spheroid. Next slide, please. Here it's again basic. It's a cross section of multicell spheroid, about 1 millimeter. Here on your right graph, it's an old graph, but it's first time the person made a microelectrode and monitored the oxygen pressures through the spheroid. So there was initially high oxygen level and deeper decrease in oxygen pressure there. When it goes through the center area, there was a minimal oxygen availability. That's already known things. Next slide, please. Here, we used pimonidazole, then the pimonidazole stain was followed by immunohistochemistry. When we use this one, all spheroid, 800, I'm sorry, it's not milli, it's a micron in diameter, contain the hypoxic cells in the inner region of the spheroid. Could you show me the next slide? I have to come back to this earlier slide later. Could you show me the next slide, please? Yes. On your left, 3 hours exposure to the pimonidazole shows in the hypoxic area, you may see the thicker red color stain versus outsider lightly stained aerobic cell region. So we can see distinguish aerobic cell versus hypoxic regions in the spheroid. Could you come back to the earlier slide, please? Earlier slide, please. Yes, no, earlier. Previous slide, please. 2 slides up, please. 2 slides up, please. 1 more, please. Yes, here, since pimonidazole is heavily metabolized by the aerobic cell at 37 degrees, that's why we can see light staining in the aerobic region within the spheroid. So we cannot see the pimonidazole depositing in the cells in aerobics. So we adopt the trick. Since the pimo is metabolized and removed, we intentionally expose the pimo-treated spheroid to an additional incubation period overnight, 10 hours at room temperature. That's our trick, hoping to minimize the loss of a pimo in the aerobic region. That's our purpose. Could you show me the next slide, please? Here on your right, 3 hours pimo staining, followed by 10 hours at room temperature. We can see some deposit on the surface of a spheroid. That means that the hypoxic cell, which was exposed to the pimo and metabolized and have something keep during the 10-hour room temperature, they migrate outside through the aerobic regions and being detected as red colors on the surface of a spheroid. It was exciting. Could you show me the next slide? Yes, so our conclusion is that based on the above 2 new set of data, we confirm the cell migration, relocation within the spheroid, namely that outer aerobic cells migrate inward, while inner hypoxic cells migrate outward. That's my conclusions. It's never been published or exposed to the world, and people does not accept cells within the spheroid, organoid, even organoid cells moving around. And there may be some directional moving things. Could you give me the next slide, please? Next, yes. The remaining question is, what is the driving force of the cell relocations? I suspect glucose-hungry cells try to move outward to reach the glucose available outside. So that's the driving force, and we need to test it. And the second one is there a time course of cell relocation depending on cell type? Yes. Fast growing cells have a fast moving around to have a more glucose availability things. So it's quite possible. So by using several different cells with the different cell cycle times, we need to test this kind of things. It's quite possible. Third one, can the cell location be observed in vivo? I think it's much likely because, and the person who studied the embryology said that when the cells establish monolayer or double layer, they don't have a problem. But when they have a multi-layer before the vessel formations in the system, they have that kind of a cell movement most likely happen there. I will show you here that the first question is, how does this cell relocation affect the outcomes of different therapeutic modality alone or in combinations? It's a good question. We have to solve this problem. Could you give me the next slide, please? Yes, this is one example of a tumor cross-sectional view with a different color. And the blue, you can see the blue inside of the mass is a blood vessel, CD31 positive. So the oxygen and nutrient diffuse out of the capillary. And you can see the green fluorescence, which is the pimonidazole hypoxic. And further than that, it's a necrotic cell death. In between, there is a HIF1 alpha staining red. So I'm quite positive that cells between the capillary and hypoxic area moving around like what I saw in the spheroid. Next slide, please. Here, just for your information, there is a different hypoxia marker. First of all, misonidazole go to the hypoxic area, kill the cells there. We can label misonidazole with the tritium or C14. So we can use these things for autoradiography or scintillation counting. And then the second one, pimonidazole, I used, and even if it's some trick involved, we can show that the hypoxic cells are moving outward. And then down there below the dotted line, for SPEC, we can use 123 iodine for scintigraph technetium-99 can be used. For PET, fluoro-18 compound can be used. For MRI, fluoro-19 compounds can be used. Next slide, please. Next slide, please. Yeah, that's all for me today. Thank you very much.
Yes. Any questions? Any questions to Dr. Jongri? Any questions?
No questions.
I think no questions, sir. Thank you very much, sir, for joining us.
Thank you.
Yes, for joining this event as keynote speaker for this event. Thank you for providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meet again next time.
Okay, thanks. Nice to see you.
Yes, sir. Yes, sir. Have a nice day, sir. Next we ask Dr. Narita Khurshid, the specialist medical oncologist, Evercare Hospital, Dhaka from Bangladesh. The title of the talk will be Risk Factors for the Local Recurrence of Breast Cancer in the Perspective of Bangladesh. Yes, madam, go ahead by sharing your slide.
Oh, yes. No. Está bien.
So very good evening to all the participants, organizers, and audience. Can you hear me?
Yes, madam, it's fine. Yes, it's fine.
Okay, thank you. So welcome you all to my presentation on the topic risk factors for local recurrence of breast cancer in the perspective of Bangladesh. My fellow co-authors are Dr. Mushfiqur Rahman, Kazi Abdullah Rahman, Abdullah Mahmud Khan, and I am Dr. Narita Khurshid. I am working as a specialist in medical oncology department at Evercare Hospital, Dhaka, Bangladesh. Now, local recurrence. It is a very unfortunate incidence for breast cancer patients, and here we have some great photographs from them. This one, a locally recurrent case along the axillary fold. This one just overlying the chest wall. This one occurred just over the lumpectomy site. So breast cancer is the most common cancer in a female population of Bangladesh. Due to advanced disease and poor compliance with treatment protocol, they often come up with local recurrence and also distal metastasis. Local recurrence of breast cancer is one of the great prognostic factors. The objective of our study was to find out the factors affecting the local recurrence of breast cancer in the perspective of Bangladesh. We conducted a case control study by selecting some patients with inclusion criteria. Patients who were previously treated, stayed disease-free for at least 1 month, and developed local recurrence within the next 2 years were taken as cases. And breast cancer patients who received treatment but had not developed local recurrence within the next 2 years were taken for controls. All the patients were aged from 18 to 65 years. The case control study was done from July 2017 to June 2019 in the National Institute of Cancer Research and Hospital, Mohakali, Dhaka. All the data were compiled and then analyzed by SPSS 22 statistical system of analysis. This was the formula we used to calculate the sample size. So a total 104 patients were included in the study with 52 number of cases and 52 controls. Now coming up with the results. This is a table showing a distribution of the study subjects according to the age. The most prevalent age group was 41 to 50 years among the cases. Mean age for the cases was 40 years, with the lowest age being 18 years. And mean age for the controls was 43 years, with the lowest age being 25 years. Chi-square test was done to measure the level of significance. This is a bar diagram showing the distribution of the study subjects according to the histopathology of the tumor. And we can see that all of the cases came up with ductal cell carcinoma. And 96% of the controls also had ductal cell carcinoma. A very few, that is 4% of the control group only had medullary carcinoma. Here again chi-square test done, but the result was found not to be significant between the two groups. Next table shows the distribution of the study subjects according to the tumor size. 58% of the cases had 2 to 5 centimeter tumor size. 2% of the cases had more than 14 centimeter size, whereas 58% control had less than 2 centimeter size, with none having more than 11 centimeter of tumor size. P-value was less than 0.05, so inferring statistically significant difference, which means larger the tumor size or diagnosis, greater will be the risk of local recurrence. Distribution of the study subjects according to the surgery type. Here we are seeing a bar diagram. 32.7% of the cases had lumpectomy and 67% had mastectomy. 85% of the controls had mastectomy and 15% had breast surgery. Here again, we found statistically significant result, which inferred mastectomy can act as a protective factor against local recurrence. This table shows the distribution of the study subjects according to the surgical margin. Only 31% of the cases had negative margin. On the other hand, 85% of the controls had negative margin, p-value less than 0.05, which infers that positive or close margin can act as risk factor for local recurrence of breast cancer. Now, lymph node involvement. From this table, we can see that 7.7% of the cases had no lymph node involvement. Major portion had no data available. 54% of the controls had absence of lymph node involvement. Chi-square test gave us statistically significant difference. So, axial lymph node involvement as well as unavailability of data can act as risk factor for recurrence. Now, the number of lymph nodes involved. 11.5% cases had more than 6 lymph node invasion. None of the control had more than 6 lymph node invasion. So we can see from this table that larger the number of lymph nodes involved, higher will be the risk of local recurrence. Next, we have a pie chart. This pie chart is showing the distribution of the study subjects according to the receptor status of the patients. Largest two areas represent unavailability of data and triple negative receptor status. The next one is 11.5% with HER2 positive receptor status. Distribution of the study subjects according to the received radiotherapy in groups. So it's a bar diagram. 27% of the cases and 54% controls receive adjuvant radiotherapy. Chi-square test done and result was found to be significant. From this diagram and study, we can conclude that radiotherapy acts as a protective factor against local recurrence when used as an adjuvant treatment after surgery. Bar diagram showing the distribution of the subjects on the basis of received chemotherapy. 69% cases and 42% controls received chemotherapy. P-value was less than 0.05, statistically significant difference found between the two groups. Next one, a bar diagram showing the patients receiving hormone therapy as adjuvant therapy after surgery. Again, we found significant difference between the two groups, which concluded that failure to maintain hormone therapy as adjuvant can act as risk factor. Here we have a pie chart showing the frequency of the study subjects according to the disease-free interval. The most prevalent duration was 3 to 6 months, followed by 1 to 3 months. Compared to similar studies done abroad, longer the disease-free interval, less will be the chance of recurrence and better will be the survival. Here we have a table showing the distribution of study subjects according to the tumor grade. 61% of the controls were diagnosed with grade 1 disease. Only 4% of the cases have grade 1 disease. Here again, we got statistical significant result, which implies that the higher the grade, more is the risk of recurrence. And availability of data can also be a thing of concern here. Now, the last but not the least stage of the disease at diagnosis. 30% of the cases were diagnosed at stage 3A or above, whereas 38% of the controls were diagnosed at stage 1 with none of the controls above stage 3B. Fisher's exact test was done to measure the level of significance for individual stages, and the overall picture we derive is that more advanced the stage, greater will be the risk of recurrence. Of course, our study had some limitations. Throughout the study, unavailability of data acted as a risk factor since planning of treatment and follow-up becomes difficult. Data was not available regarding certain operation notes, histopathological report that include a surgical margin, intravascular invasion, as well as histological grading. The sample size taken was small. It was a single center study. And in addition, some patients were too poor to afford the hormone receptor study even after being advised. We have some recommendations based on this study. A large scale in-depth study should be done that will include larger sample size and longer study period. Awareness should be developed among the breast cancer patients about the need for completing treatment and the need for regular follow-up, especially the younger age group. Awareness should be developed about the importance of preserving medical records for future use. Awareness should be developed among the people about the need for breast cancer screening. To conclude, we found total 9 risk factors for local recurrence of breast cancer. They were lumpectomy or breast conserving surgery, larger tumor size, positive or closed surgical margin, lymph node invasion, lack of radiotherapy or lack of hormone therapy, chemotherapy, higher tumor grade, and advanced stage were all the risk factors we found for local recurrence. We should give priority on the preventable and modifiable risk factors to make comprehensive treatment plan for better prognosis of breast cancer in Bangladesh. Everyone has a right to be treated and die with dignity. The relief of pain, physical, emotional, and spiritual and social is a human right. So thank you all for your patient hearing, and thank you Inovine Scientific Committee for allowing me to present my speech.
Yes, ma'am. Yes. Any questions? Any questions to Dr. Narita? Yes. Any questions? If you have any questions regarding this topic, even after the completion of the conference, you can mail us. So we'll be sent it to concerned speaker. Any questions? Yes, thank you very much, madam. We want to compliment on your topic. Thanks for sharing your tips with us. Looking forward to meet again next time.
Thank you all. Thank you, Inovine.
Yes,
Hope
yes.
to meet next time.
Yes. And we would like to inform that Bangladesh Cancer Association is joining this our Inovine scientific meetings since last 2 years, 2019, 2020 as well as 2021. They were joining these events either physically as well as virtually, and they'll be sharing their knowledge, the tips to the scientific world by sharing this, by involving this, by participating in the scientific events. Once again, we would like to thank to all of the Bangladesh Cancer Association participants on behalf of Inovine Meetings. Yes, if you go to the remaining speakers, we do have left Dr. A.C. Metin from Stanford University School of Medicine from USA, Dr. Shehrin from Bangladesh, Department of Microbiology and Immunology, as well as a poster presenter from Xia Gong from Southern University from China. If possible, they will be presenting this their talk for tomorrow's session. We may be think that they may are absent due to their some other issues like technically or their healthcare. If you go to the vote of thanks, if any questions regarding this today's sessions, just you can raise your hand. We'll be asking behalf of you. Any questions, sir? Any questions?
Hello.
Yes.
Hello. Sir, I want to ask one thing. My presentation, myself Josna Singh, and my presentation is going on tomorrow at 8 o'clock. Sir, I would like to request you that can you please shift my presentation in daytime approx when conferences start, if possible.
Yes, definitely. Definitely. Definitely, we'll input through mail, madam. Just when to join the event. But we need to you need to join the Zoom meeting prior to 30 to 40 minutes before your talk, because we can adjust your talk.
Okay, sir. Okay.
Definitely, ma'am. Definitely.
Thank you, sir.
Yes. Any questions regarding today's sessions? Any questions? Yes. If you go to vote of thanks, thank you very much to all the participants who have joined this webinar, virtual conference of Cancer Science during this period having different time zones. Our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, general collaborators, media partners who have joined from different destinations around the globe to their support and cooperation. Let us thank speakers who have responded so well to our invitations to participate in this conference. We have received several papers which will inform the basis of our discussion in these various sessions. Let us thank you all the associating with this conference by your presence. A special thanks to Program Manager Mr. Henry Bruce, as well as Ms. Nadia, for his as well as her continuous effort in putting all together in one platform, either through social media. If we go to the keynote speakers of the day one, that is Dr. S. Sundaresan, Dr. Sutepa Mukherjee, Dr. Rafael Silvia Torres from Mexico, Dr. Jongri from University of Maryland, Baltimore from USA, as well as session speakers Rukia Zialani from Jordan, Dr. Nirituta Kurshid from Bangladesh, Dr. Juduhali from Germany, Miss Aishwarya, the postgraduate student from India, Dr. Arielian from Romania, Dr. Anita from India, Dr. Abdullah Al Masood from Bangladesh, Dr. Nashid Muhammad from Saudi Arabia, Dr. Disek from Indonesia, Dr. Miss Karin Kalibuki from Philippines, and Dr. Shipang Mahuluna from King's College of London from UK, United Kingdom, and 4 to 5 delegates from different parts of the world. If everything goes well in 2022, hope we will join in physical event on same topic, that will be cancer science. We are planning to organize either in Dubai or European continent, just like if you select best cities like Italy or Spain. And a special thank you to Dr. Lakshmipati for managing whole day of the conference by asking number of questions and joining this event since starting of the conference. I would also like to thank participants hope we can collaborate in the future events either in physical or virtual events. And kindly note that electronic certificate will be sent through your email ID within 3 to 4 working days after the completion of the conference. Finally, we extend our appreciation each of you for participating in this online event. Thanks again. Have a nice day. We'll be meeting the same topic by tomorrow. We'll be completing day 2 of the conference. Thanks again. Have a nice day, madam. This is signing off, Madhu Bhurti. So we'll be closing within 1 or 2 minutes. If you have any questions, just you can raise your hand. You can ask directly. Any questions? No comments? And also, we request all the participants, those who joined today's sessions, I request all the participants to join tomorrow's session also, because the drawback is as soon as completing your talk, just you are leaving. And we appreciate Dr. Rashil Silva joining from since the conference started. I appreciate you, sir. So shall we close the session, sir? Any questions further? So we'll be closing within 1 minute. And if you want any recorded video, you can find from our YouTube, Inovine Meetings LLC. If you type the word Cancer Science today's date, you'll be getting the YouTube link. You can copy from it. Thank you very much, sir. Have a nice day. I'll be saying a YouTube link just to be online. So this is the YouTube link. You can copy your presentation from here. Yes. Wow.